projects through the Ministry of Health, but also President's Office, Regional Administration, and the Local Government Office, or PORAG, because they are the ones responsible with the administration of the health facilities within the districts. So because of their cooperation, we were able to smoothly implement this project, which has brought us thus far as we are celebrating the outcome today. And of course, as I said, we have other partners like WHO, UNICEF, and other implementing partners locally and globally are also recognized for their contribution in implementing this project. And last but not least, it is path commitment and trust with donors and local government authorities, which has enabled us to implement our project and also come up with whatever results we have been able to achieve. So without taking much of your time, and with these remarks, I wish you a good and a productive discussion for the next 2.5 days. I will be with you for some hours. I won't stay for the entire meeting, but for anything, since you are in our country, our office is here to provide whatever help you might need, to provide whatever assistance you might need, and you are once welcome. Karibu sana, karibuni sana, asante sana.
Thank you, Amos, for the warm welcome once again for us. And thank you for the assurance as a hosting country. We thank you for the assurance. So our next speaker, if I may quote some words from one of the religious books, I would say is somebody whom I cannot untie the strings of the sandals, because he's a person with a lot of experiences, decades of experiences in project designing and implementations. Currently is the global director for the TIMCI project. He was there at the inception of this project, and good to see that he's still with us. He steers all the implementation up to this end. May I, ladies and gentlemen, give a warm round of applause to Mikey Lufo. Okay.
Thank you, Deus. It's very nice of you to say all those kind words. Okay. Hello, everybody. So I think I'll give a few words and then I'll hand it off to our funder, Unitaid, and then come back up to give a presentation, start this thing. So I wrote some words because I didn't want to forget what I wanted to say. So first, thank you, Deus and Amos, for the wonderful introduction. Welcome, everybody. It's great to see some familiar faces and some new faces. And I'm grateful for everyone that's come and that's online. Okay, so we're here at the end of this 5-year project. The project aimed to improve health outcomes for children under 5. And over that 5 years, we've accomplished a lot. We've built partnerships, we've overcome challenges, we've conducted one of the largest studies in child health that's been done in many years, and we've contributed a lot to the understanding of how to implement sustainable interventions in primary health care. So I'm very proud of what we've done. I'm proud of this team, this consortium, and the learnings we are contributing to the world. I'm very grateful to each and every person that's worked on this project, to Unitaid for the support, to the Ministries of Health for their partnership, to our research partners for their diligence and their rigor, and every healthcare provider, caregiver, and child that participated. And I'm grateful to all of you for joining us in the room and online. So for the next 3 days, we'll share what we've learned through this project and discuss the implications. Today, we'll talk about the implementation and the outcomes of the research. Tomorrow, we'll talk about policy implications and the next generation of devices. And on day 3, we'll talk about the concrete next steps. And in the room, we have a broad range of expertise and knowledge, and online, including Ministry of Health representatives, IMCI experts, oxygen experts, community organizations, academic researchers, programmatic implementers, representation from global normative bodies and procurement agencies. So I think we have everyone in the room that we need to do to have a good discussion about what we can do next. And if I forgot somebody, I'm sorry. So we've done what we can to bring the right people together with excellent data, and I'm hoping we can have a frank discussion with 55 of our closest friends and another, I don't know how many are online. Discussion about the best way to improve health systems and save children's lives. So again, this is meant to be a discussion. So please, everybody engage, and it should be a good 3 days. So let's get started after Matthew. So I'll introduce Matthew next, getting the nod. Thanks.
Hi, can I be heard?
So I can give an introduction to Matthew. I'm going to introduce you, try to embarrass you a little bit. So Matthew Black is a program manager from Unitaid. He's been an excellent partner for us throughout this journey. He's been a thought partner. He has experience working on the African continent and conducting programs for many years. So that's what I'll say, Matthew, and hand it over to you.
Hi, can you hear me?
Yes.
Ah, good. Okay. I think I can't switch my camera on, but that's okay. I can just speak. Maybe if someone can help me with the camera. I don't have permission to turn it on, and it would be nice to see you all, but so I'll carry on anyway. So Hamjambo, it's an Asante Deus and Mike for the introduction. I'll stand on the protocols previously observed by the other speakers. And just to say thank you very much. So Unitaid has been the funder for this project and is an international agency which was established. Was an international agency established in 2006, and we are very proud to be associated with this project and this important work that has been going on and is now finally coming to a conclusion. My humble apologies for not being there. I would have loved to be there. As an organization, we are trying to reduce our carbon footprint, and at the moment travels, we take very few travels, and we try to join things remotely. It's a shame for me because I always love to be in that part of the world, and I would have liked to have been there. But myself and my colleagues will try to join you throughout the workshop, and we are looking forward to the messages that are coming out, and we're looking forward to the understanding and discussions that will come from this workshop today. And what has really been, as Mike said, quite a challenging project, but also a very rewarding one and a very successful one in many ways. So I would like to thank PATH for the leadership, and in particular Mike, Mira, and the rest of the team that have worked ever so hard in many different aspects in order to make this project as smooth running as possible, in order to sit down and tackle the challenges, to be very open in communication with us about where the challenges were, and to be collaborative in being able to deal with those challenges. And as part of that, Ifakara, Swiss TPH have been, I'd like to thank them as well. They've been very professional, very engaged, very knowledgeable, and that's very much appreciated. And I'd also like to appreciate the work of the local partners, the ministries, the local organizations that I work with, and the communities themselves who've been engaged in this work and without whom really nothing would have been possible. And that goes obviously for Tanzania, but equally for India, Senegal, and Kenya teams. And I'd like to thank also the observer countries for their engagement in this project. And I really hope that the work that's done and the discussions that can happen can really help to roll out and scale up the implementation of pulse oximeters at primary health level, and will form a real benefit for countries going forward. So I won't say much, but I just wanted to highlight the fact that from our side, Unitaid takes on a triple role in its work across HIV, TB, malaria, and maternal child health, which is where this project fell. And our role is one of an investor, two of an innovator, and three of a pathfinder. And I feel like the pathfinder role really fits within this project. Pulse oximetry and the algorithms and tools that are needed to put it in place is a complex issue, certainly more complex than I realized when I first came on board the project in 2021. And there's many nuances, many challenges, and many considerations that have to be made in ensuring that one, not just that that you get a product which can be utilized, is welcomed by health officials, is accepted by communities, and is reliable. But not just that, but that product will be able to lead to stronger healthcare delivery, and better effects and better health outcomes for in this case, the children that use these tools. Now that has been, I think, quite a challenge for the team, and Mike and the team are to be really congratulated on the way in which they've continually tackled that challenge, continually trying to make sure that this project puts the devices in the best place it can, so demonstrates to health givers and health systems across the world that the value of these devices and the value of the effort in terms of pulse oximetry. As I guess will be mentioned maybe several times through the 2 days, this project was preconceived before the COVID pandemic, and the COVID pandemic really put this project in a different light. And in some ways, the highlighting of the need for good oxygen systems was in some way a contributor to the outcomes of this project, and made it. I want to make sure I'm not suggesting anything that positive about the COVID pandemic, but if there was any silver lining on it, it was that it helped emphasize the importance of the TIMCI project and the importance of this work, and helped us be able to make the link in oxygen work and oxygen provision going on and the efforts of this project. So I certainly think we view that O2 space as sort of somewhere where we can take on the results of this project, and the work of this project can be brought forward in terms of finding what piece pulse oximetry fits in the overall healthcare provision jigsaw, and particularly what piece it fits in the overall oxygen response. So I'm really looking forward to hearing and participating in some of these discussions over the next 2-3 days, and really looking forward to hear from the people who are in the countries where we're expecting these devices to be used, so we can hear from you how best you think that this work will be taken forward, and how best you will utilize it to strengthen your systems in terms of having the best health outcomes that we can, and addressing things like antibiotic prescription, and addressing things like strengthening referral systems. So I'm really sure that there'll be lots of fruitful conversations coming out in many different directions. Obviously, I've had a lot of discussions about the results with Mike and his team over the last, well, maybe 6 months or longer. And I certainly appreciate the way that they, especially maybe working with Swiss TPH, have been able to shape the messages and understand the information that comes out of the data. So another appreciation for that. And with that, I'm sure I've taken up my 5 minutes already. So I just want to wish you good deliberations going forward, and to ask the questions that you need to ask. Mike and Amir are very good at answering questions, and to make sure you engage in conversation and really explore the best way in which these tools can be used. So with that, I'll hand over back to Mike. Asanteni sana.
Thank you, Matthew. Appreciate the kind words. So, okay, I'm going to set up here. So I think we'll start the presentation now. And I'm going to grab my notes. Here, will you hand me that? Yeah, perfect. Okay. So for the other speakers, we'll get a laptop up here with the presentation. Open this. Okay, try this. Okay, so I think we all have the agenda in our hands, so we don't need to look at that. Logistics. Done it. Okay. Overview. Okay. So, too many children die of preventable causes. Most of those children are in low and middle income countries. And I don't think I need to say more there to this group. So to prevent those children from dying, the integrated management of childhood illness was created, the algorithm, by the WHO and UNICEF in 1995. And it's been implemented since then. And it aims to address the major causes of morbidity and mortality, which you can see in this chart here. And it includes simple structured approach for integrated assessment, classification, and treatment of children. And so I think you all know what it looks like. There it is. However, there's some gaps in IMCI. I'm going to look at this. So assessing is not always done. Clinical signs are not always reliable. Actually, I haven't. Danger signs are not always assessed. There's been a lot of research into this, and it shows that their danger signs are not always looked at, and the complete assessment is rarely done. So again, there's been a lot of research looking at the implementation of IMCI. Classifying children, not always correct. 33 to 87% of the consultations result in a correct classification, and only 47% of children with severe disease are correctly identified. So then finally, the treatment is not always perfect. So antibiotics are prescribed in 50 to 80% of consultations. I believe WHO recommends that should be closer to 30. And only 38% of children with severe disease are referred. That was from Tanzania. And so the causes of those are multiple. And somewhat overlapping, but it's lack of diagnostic tools, it's knowledge gaps for the healthcare workers, resource constraints for the healthcare facilities and the health system, often in cognitive and work overload, and gaps in guidance, or for example, what to do when a child has fever, but they don't have malaria. So to overcome some of these gaps, Unitaid put together an RFP to look at non-malarial fever, and the TIMCI project was born. So TIMCI and the AIR project also was part of our portfolio. So tools for integrated management of childhood illness aims to increase healthcare workers' ability to identify severely ill children and get them care. So we did that by giving pulse oximeters and digitized IMCI, or tablet-based IMCI. And It was a 5-year, started as a 4-year project, turned out to be a 5-year project. Funding by Unitaid. The other project in the Unitaid portfolio, as I just mentioned, was the Alima Air project. And we had 2 goals, which I just said. The first one to help healthcare workers identify severely ill children. And the second was to look at what's next for pulse oximetry. So helping to advance non-invasive devices that not only measure blood oxygen, but also and heart rate, but also things like respiratory rate, hemoglobin, potentially blood pressure, any number of things. So that was the second goal. Today, we're going to talk primarily about that first goal. Tomorrow, we'll get into the second goal. And I think you all know, we worked in Senegal, India, Kenya, Tanzania, and we had our research partners, Swiss Tropical and Public Health Institute, University of Nairobi in Kenya, Ifakara Health Institute in Tanzania, King George's Medical University in India, and University Cheikh Anta Diop in Senegal. Okay. So pulse ox, again, everybody knows, easy to use devices that can help identify hypoxic patients. Theory is that they would identify hypoxic children who need urgent referral, but might not have other signs of severe disease. And then the other piece was that they would increase referral of children with severe disease, increasing healthcare worker confidence and caregiver confidence. So our hypothesis was giving these tools to healthcare workers in primary healthcare facilities would increase the number of referrals because it would identify more children who needed to be referred and might have been missed. And it would reduce severe complications because you're identifying those children who might have been missed. Clinical decision support algorithms, similarly, aim to strengthen guideline implementation because, as I mentioned before with IMCI, the guidelines are not always followed. So they guide healthcare providers step by step through the consultation to make sure they take every step. And they provide recommendations on the treatment and referral. And these, you'll learn more about this, but the system we used allowed the healthcare worker to agree or disagree with the diagnosis and then agree or disagree with the treatment recommendation. And then finally, using clinical decision support algorithms to support management of sick children can improve their recovery and decrease unnecessary antibiotic use. Trying to speak slowly for the translators. So the intervention package that we put into place included paper-based IMCI algorithms, so working with the ministries to identify where the pulse ox would be integrated into the IMCI consultation, providing the pulse oximeters and providing the tablets. So we did community engagement to encourage care seeking for pneumonia danger signs and encourage following referral advice. And we conducted trainings using the ministry's systems, mostly training of trainers, but we also implemented some mentorship and supportive supervision. And then we did provide operational support to the primary healthcare facilities and the referral hospitals in the form of treatment commodities and oxygen to make sure that those patients that were identified could be treated. So just strengthening those. So a couple things to note from that global implementation, and then I'll hand it off to our research partners to tell you how the outcomes of the research. So the package was developed through consultation with ministries of health and other national and global stakeholders. So it was customized for each country's health system and the Ministry of Health's preferences and how they wanted to conduct their own. Oh, I'm moving my slides forward, but not yours. Sorry. This is the intervention. And this is the highlights. This is where we are. So we worked closely with the ministries and other experts to design the interventions in the context of each country. Pulse oximetry criteria varied by country. So the ministries of health, again, decided how to integrate the pulse ox into their clinical consultations. So this is interesting to remember because it kind of plays out in the results. So all sick children had pulse oximetry used in India and Kenya. So it was more of a vital sign in India and Kenya. And then in Tanzania and Senegal, the pulse ox was used on all young infants, all children 2 to 59 months with cough and difficulty breathing, or the children 2 to 59 months who were classified as moderate or severe, or yellow or red, through the IMCI consultation. So you'll be tested on that later. There's a referral threshold was less than or equal to 90% in all the countries except for Senegal. Senegal chose to use less than or equal 92%. The CDSA, the clinical IMCI tablet, was not used in India following a pilot due to low uptake. And you'll hear a little bit more about that, but so no CDSA in India. And then, of course, contextual events influenced the implementation in all countries, particularly in Senegal, where there was a major health worker strike immediately following the implementation and rollout. And of course, COVID also had some implications. So I think that's the final slide for me. And I will hand it off to Dr. Leah Boll from Swiss Tropical and Public Health Institute to talk about the study design and overview. Welcome. There is, yeah. That's fine. Don't forget to switch that and that.
Is it possible to activate this one? Can we activate this mic as well, or is it not possible?
No.
Perfect. Right?
Yeah, let me make sure. Oh, actually, let's switch this. Sorry, that's about the same. I'm going to switch these out. Actually, Mira, can we use yours for that?
Great. Good morning, everyone. Karibuni sana, hamjambo, habari za asubuhi. Haya. Nafurahi sana, safiri Tanzania. I'm very happy to be here. My name is Leah Boll, and I'm coming from the Swiss Tropical and Public Health Institute. Okay, this is very loud now. I'm here and presenting on behalf of Professor Kaspar Wies. He is the principal investigator of the global entire TIMCI research component, as well as Dr. Fenella Bainan, who couldn't be here, unfortunately. So can I hand over the microphone to? Great. So for my presentation, I'd love to give you an overview on the actual study design. And as you've learned from the previous slides, the TIMCI project was a combination of an intervention package, which was led by PATH and the team, as well as very rigorous research surrounding the entire implementation. So what did we actually do? We conducted a large-scale mixed method intervention evaluation. And the aim was really to evaluate the impact of the intervention on clinical and quality of care outcomes, cost and cost effectiveness of the intervention, as well as understanding the mechanisms of and facilitators and barriers to the implementation. Okay, it's working. As you know, the TIMCI project was implemented in 4 countries. This includes Uttar Pradesh in India, Tanzania, Kenya, as well as Senegal. In India and Tanzania, we conducted a pragmatic cluster randomized controlled trial. In Kenya and Senegal, we conducted a quasi-experimental pre-post study. And in all of the countries, we conducted service provision assessments in facilities. We collected CDSA consultation data. We also conducted facility-based process mapping and time flow studies. We conducted in-depth interviews with caregivers, but also healthcare providers and key informant interviews. We also ran an online survey with key informant stakeholders, and we conducted a cost and modeled cost effectiveness study in all of the countries. So how did the pragmatic randomized controlled trial in India and Tanzania actually look like? The objective was to evaluate the impact of the intervention on clinical and quality of care outcomes. The timeline was as following. In Tanzania, we included 66 facilities, and the RCT was running over 12 months. Whereas in India, we included over 106 facilities, and the intervention and the RCT accompanying the intervention was carried out for a total of 10 months. In Tanzania, we had 3 arms, whereas in India, we had 2 arms. Among the facilities included in the RCT, we conducted a random allocation. And the 3 arms, the first arm included the pulse oximetry in combination with the clinical decision support algorithm, which is algorithms on a tablet based on IMCI guidelines, as well as a refresher IMCI training for healthcare providers. The second arm included the pulse oximeter only, in combination with paper job aid, as well as also a refresher IMCI training for healthcare providers. And the third arm was refresher IMCI only, the control arm. And in all of the 3 arms, the children were recruited at study facilities and followed up, and outcomes were compared. What about the pre-post study in Kenya and Senegal? The objective was to evaluate the impact of the intervention on quality of care and health outcomes. The timeline was as following. We conducted 15 months of data collection. This included 6 to 7 months of baseline, as well as 8 to 9 months following the interventions rollout in study facilities. Among the 60 TIMCI facilities, we selected randomly 20 for the pre-post study. In all of these facilities, we implemented pulse oximeter in combination with clinical decision support algorithms. And in the pre-intervention phase, children were recruited at study facilities. At post-intervention, also children were recruited at study facilities throughout the data collection, and again, outcomes were compared. What were the eligibility criteria? At the level of facilities, these were government-led facilities providing curative primary care services for children 0 to 59 months of age. They have had to have access to oxygen either on site or at referral facility, as well as electricity. We also had some excluding criteria, which included inaccessible for long periods, such as, for example, because roads were not accessible, having less than 20 sick children per month, and that was an average of based on the prior year, already systematically using pulse oximetry, as well as having another child health program or study that actually could influence study outcomes. When it comes to the eligibility of children we included into the research, these were 0 to 59 months of age, and they were attending a study facility with an illness or reported unwell during routine visit, such as coming for vaccination, for example. We excluded children which were younger than 1 day, so only a few hours old, children who attended only for trauma, children who were already admitted within the facility, or who were previously enrolled in the study preceding 28 days. On the slide, you can see the outcomes we were looking at. For the randomized controlled trial in India and Tanzania, we were looking at the percentage of children with a severe complication by day 7. as well as the percentage of children admitted to hospital within 24 hours of day 0 consultation and as a result of referral as primary outcomes. The primary outcomes for the pre-post study included the percentage of children referred by primary healthcare providers to a higher level of care at day 0 consultation, as well as the percentage of children prescribed an antibiotic at day 0. We also looked at a variety of secondary outcomes, and these included health, hospitalization and referral outcomes, hypoxemia outcomes, follow-up outcomes, as well as antimicrobial outcomes. And we still conduct subgroup analysis, sensitivity analysis, as well as exploratory analysis based on the data collected. This is just a quick overview on the data collection of the RCT as well as the pre-post study in the 4 countries. We collected socio-demographic and care-seeking information by research assistants who were permanently based in the TIMCI, what we call the TIMCI facilities. And this was done before the consultation. We also conducted post-consultation, we retrieved post-consultation information from the records, as well as from the caregivers through short exit interviews. In addition, the teams conducted a phone follow-up on day 7, and for the RCT, in addition, on day 28. And if we couldn't reach them through phone, in Tanzania specifically, there were trackers who also visited the caregivers at their household level. We didn't do any re-examination or a direct observation as part of the RCT or the pre-post study. And you can see here on the graphic and how all of this was actually embedded into the study. So here, just a brief overview on the numbers for both the RCT as well as the pre-post recruitment and follow-up. For the cluster randomized controlled trial, we included a total of 100,057,667 children in a total of 172 facilities. In India, this meant a cluster of 53 facilities in the control arm, as well as 53 facilities in the pulse oximeter arm. And around 40,000 were screened following the enrollment. And there was a follow-up rate in the control arm of around 90%, 89.1%, as well as in the intervention arm of around 91.2%. In Tanzania, as I had mentioned before, we had 3 arms, 2 intervention arms, and it included in the control arm 21 facilities, in the intervention arm with the pulse oximeter only 21 facilities, as well as in the combined CDSA and pulse oximeter arm 24 facilities. And when you're looking at the very bottom at the follow-up rate, in the control arm, this was 97%. In the intervention arm with the pulse oximeter, 98.2%, as well as in the combined arm, 97.2%. And you can see it was a very high follow-up rate, and it really shows also the dedication of the entire team doing the work on the ground. How did it look like for the pre-post study? We included 50,580 children in total. And this was done in 39 facilities overall. In Kenya, we had a total cluster of 19 facilities, whereas in Senegal of 20 facilities. And as I said before, it was a pre-post study where we had either an IMCI refresher training or a combination of pulse oximeter and CDSA as an intervention. And here the follow-up numbers are slightly lower. In Kenya, for the control arm, it was 66.6%. In the intervention arm, 78.3%. And in Senegal, for the control arm, 5.9%, and in the intervention arm, 61.8%. And again, as Mike was already mentioning, in Senegal, there was a massive strike by healthcare providers, and obviously it really impacted data collection as well as follow-up. But Prof. Fai is going to probably share more information on that later. So these were particularly information related to the RCT as well as the pre-post study. But as I mentioned before, we also conducted numerous additional studies, implementation research studies embedded in this overall research package. These included so-called service provision assessments. And the objective was to evaluate the impact of the intervention on quality of care as well as care processes. The timeline was actually periodic assessments in a subset of facilities. And we conducted observations of consultations, healthcare provider interviews, exit interviews with caregivers, as well as facility assessments. We also conducted process mapping and time flow studies. Here, the objective was to understand the influence of the intervention on quality of care and care processes, as well as identify barriers and facilitators to implementation. And again, it was conducted in a subset of facilities, and this is how it looked like. We conducted really process maps where we were looking at the entire flow from entering the facility up until leaving the facility, and we were doing the time flow study by stopping the time for each step when a caregiver is moving within the facility to understand the time investment, as well as the influence of the intervention on time. We also conducted a variety of qualitative studies, and I had the pleasure to coordinate them. So if you have specifically questions related to these studies, please do approach me. These included healthcare provider interviews. And the objective was to understand the acceptability as well as perceptions related to the intervention. We conducted the data collection prior to the intervention and pilot facilities, as well as early and late during the intervention rollout. And we purposefully selected the participants based on socio-demographic criteria, as well as professional characteristics. And at late intervention, we looked at the uptake, and we also purposefully selected healthcare providers either extensively using the devices or not really using them to understand what are drivers for uptake or non-uptake. And in the box, you can see the number of interviews we conducted in each of the countries. We also conducted caregiver in-depth interviews, and here the aim was to understand the acceptability as well as the perceptions of intervention, healthcare decision-making, as well as healthcare seeking. And again, it was the same pattern as for the healthcare provider interviews. We conducted first interviews in pilot facilities and then conducted interviews early and late to the intervention. Again, we had a purposeful selection of caregivers participating in the study based on socio-demographics. And we also tried to recruit at least 50% who received a referral advice. And you will see later in the results, this was rather challenging. And again, in the box, you can see the number of interviews we conducted. We also conducted stakeholder surveys as well as key informant interviews in Kenya and Senegal. And the stakeholder key informant interviews were conducted at different levels, and the perspectives on the implementation, policy and research, as well as process evaluation criteria were explored. The online survey was conducted with selected project informants, either those implementing or being affected by the implementation. And again, we wanted to seek perspectives on the implementation itself. Also, economic data was collected, and TIMCI study type and tool evaluation varied actually by country context. The local economists collected data using questionnaires administered at primary healthcare level and public hospitals. And the questionnaires were adapted to local conditions together with staff on the ground. It collected socio-demographic data as well as cost data, and the data was stratified based on level of care, urban, rural, location, and size. And ministries of health, civil society organizations, community advisory boards, etc., were consulted when it came to designing the research objectives, key outcomes, as well as the instruments themselves. And on the right, you can see some of the numbers, the data collection. We also collected CDSA data, and these were de-identified data from consultations conducted using the clinical decision support algorithm. It included basic socio-demographics, the reason for the consultation, measurements, danger signs, as well as signs of severe illness, which were captured during the consultation, history, examination, assessments and test results, diagnosis, whether the healthcare provider agreed, disagreed, or added, as well as medication related to also availability and whether they added additional medication, for example. To summarize, the TIMCI project aimed, and the research around it aimed to support healthcare providers to detect and manage severe illness in children under 5 years of age, while supporting resource stewardship. The intervention included pulse oximetry in combination or without clinical decision support, along with training, supportive supervision, and community engagement. And all of this, and I think this is really important to emphasize, embedded real-world health systems in Uttar Pradesh in India, Kenya, Senegal, and Tanzania. We used a mixed method approach in research to evaluate the impact on health and quality of care outcomes, to really understand the mechanisms, often facilitators and barriers to implementation, and to evaluate cost and cost effectiveness. This was one of the largest scale evaluations in child health in the recent years, and it required collaboration across many institutions and with many, many individuals. And this is how I would like to end, but now there's one slide missing, it seems. It's at the very end. All right, so someone else is presenting on the very last slide I had on my screen, which is actually the acknowledgements. And maybe I'll leave it here. You will see on the slide, there were many, many different institutions involved, many people on the ground who conducted the data collection. And without all of these people, this research would have never been possible, obviously including all of the healthcare providers as well as the caregivers who participated in the study. So thank you very much. And many of these people are also today present in the room, and I hope you get a chance to talk to everyone. Thank you very much for your attention. So I just heard there are few minutes for questions. And prior to starting the round of questions, I'd love to introduce you to my colleague, Dr. Grace Malu from Ifakara Health Institute here in Tanzania. Grace was an extremely important person as part of this research on behalf of TIMCI. She was the research lead here in Tanzania for the entire research surrounding the TIMCI project. And she is probably the best to answer the questions related to the study design because she was also the one who actually implemented it in the end. So please, the floor is open to any questions you may have.
Thank you very much, Dr. Leah. Good morning, everyone. So I will stand here so every one of us can see me. I am tall, as you can see. So we're welcoming questions, and anyone with a question. There is a saying that goes, if someone presents and then there are no questions, it means the understanding was very well. But this hypothesis should be null because I see. Thank you. You're welcome.
Yeah, thank you very much, Yasser from WHO. Two quick questions from my side. One is that you have shown us a very high follow-up rates. I would like to know why it was so high. Second question is what information we gathered during the follow-ups.
We'll just take another question and then we'll respond. Thank you very much, Yasser.
Thank you very much for the talk. Ambrose Agweyu from Kenya. Really impressive work and congratulations to everyone involved. My question may be preempting discussions that might happen later, but I wonder if you could share some lessons from the experience designing and conducting the study that might inform future work. Are there any things you would do differently?
You want to answer those two first? Or one more?
Okay. Yes, I think we can answer. That is not working. I think we can answer the first two. Okay. I'll start with the first on follow-up rates that were very high and why they were high. So to give a sort of background is that the follow-up rates specifically for Tanzania and India and Senegal were not high in the beginning. So during the pilot, for example, in Tanzania, we had a follow-up rate of only 40% because these were phone follow-ups particularly. But during the implementation of the project, after the pilot phase, we added physical follow-up. It means for the provider, for the caregivers who did not have phones and were not reachable because the study was conducted in rural parts, these were followed up physically. And this was one of the ways that increased the follow-up. So for the follow-ups, we struggled a bit in the beginning, but later on, we got this another approach of doing physical follow-up, which led to a higher rate of follow-up. But also you've asked what kind of questions were asked during follow-up. I'll speak specifically for RCT, but these are similar also to pre-post intervention. So one of the outcome for us RCT was day 7. We wanted to look at severe complication at day 7. So one of the questions that were asked were, how is your child after 7 days of visiting the healthcare facility? And this was the main question that the research assistants were asking the caregivers while they were calling. How is your child doing? Is there anything that has happened? We were also following up to see if death has occurred, if the child died, if the child was also referred, went to another healthcare facility for treatment after the 7 days. So this was done in 7 days and also in 28 days. I hope I've clarified. Thank you very much. We're going to the second question. I think I've answered it partly, and then I'll give it to Dr. Leah as well to answer. What are the lesson learned? The first lesson that we learned, particularly for us African countries, conducting studies in rural parts of the countries might be a bit different in urban areas logistically. Meaning for us, for example, I've said the follow-up rates were very low because we imagined from the beginning that everyone would have access to my mobile phone. However, this was not true during the pilot phase. That's why we started using physical follow-ups. So the first key lesson that we learned is that settings are different, and we have to sometimes contextualize our interventions depending on these settings from the beginning, because I don't want to tell you how hard it was for us to be able to conduct the follow-ups. And this was a very, really big problem. But also another thing that we've learned from this project is that co-designing, should I call it co-design or should I call it collaboration with the ministries, with the caregivers, with the healthcare providers from the beginning. And for this, I applaud PATH because they did a very good job. And our time spent in the health facilities was very easy. We were liked because we had a very good We build rapport from the beginning with these healthcare facilities. These are the key lessons that we learned. Other lessons are very scientific, and we can navigate with scientific methods. Thank you very much. Any other question? 2 more questions or 3 questions, and then we'll end this up.
Yes, I have the microphone.
1 question. Okay.
Yeah, so thank you so much. Robert Mutumba is my name, from Uganda, and I want to thank the presenter for this. My only question is, it's been indicated that the study focused on government facilities only. And I'm wondering why the private facilities got neglected. Was it by any, so what could be the reason? Because we really see a lot of issues in the private sector. And honestly speaking, much of the focus is in the public. Thank you.
Thank you very much. I will take only this 1 question because I'm told our time is out, but kindly reserve your questions. We'll have questions during break time. You can please approach us, any of us, for any, just note them down. So thank you for your question. First, I would say private facilities are not neglected, and devices such as pulse oximeters are very easy to be found in private healthcare facilities. That's one. These devices are not found in many of the government facilities. But as you can know, of course, there are people who are going to private facilities, but majority of us still use government facilities, and especially in rural areas of our settings and our countries. So we cannot start intervening in private facilities while we are leaving the child, who is the government facilities. So the aim and for this implementation was for the government facility first, because our healthcare system caters and carries these people more than the private facilities. Most of us afford to visit government facilities. That's why these interventions are going there. But also, some of these devices are also already implemented in private facilities. But to assure you is that if something has worked in government facility, it will be very easy to scale up in private facilities. So no problem. Scalability can really happen. Thank you very much. For those with questions, we can take them afterwards. Thank you. I see you, but thank you.
So you can post your questions later, but also on every table, there are post-it stickers. So please also write your questions there, and you can put them on the whiteboard at the back of the room to make sure that we capture everyone's questions and insights. So I hand over to Des.
Thank you very much, the presenters, and Grace has, the last words of Grace has sort of directed it to talk about the Minister of Health, the way the Minister of Health is the custodian of the health services in the country. So at this moment, I'm honored again to welcome the Minister of Health representative, who was among the 3 high-level speakers in the morning. The person whom I'm welcoming is a very dedicated person. And in all TIMCI implementing countries, our host department within the Ministry of Health was the Department of Reproductive, Maternal, Neonatal, and Child Health. This has been a very friendly department to us to take us through, to navigate into interdepartmental consultations within the ministry. I'm honored to introduce to you Dr. Mzee Nasolo, who is the Assistant Director for Reproductive, Maternal, Neonatal, and Child Health at the Ministry of Health. Applause to Dr. Nasolo, please. Okay, sir.
Hello? Hello.
Okay, thank you very much. As I've been introduced, my name is Dr. Mzee Nasolo. from the Ministry of Health, Department of Reproductive Maternal Child Health. First of all, I should apologize for coming late. With some traffic jam on the way from the airport. But I'm very pleased to be here with you today. And I'm going to convey our greetings from the Ministry of Health. First of all, I should thank all of you for attending this event. I know most of you have come from very far, and I welcome you to Dar es Salaam, although we are based in Dodoma. As you know, the capital seat of the country is now in Dodoma. Dear PATH and country directors, I have my colleagues from the Ministry of Health. Are you around? Nani yuko hapa? Mena? Mena, umekaa kwenye giza sana. You are invisible there. So we have colleagues from the Ministry of Health, TIMCI consortium representatives, that is Ifakara and Swiss TPH, the UN agencies. We acknowledge your presence here. Implementing partners, I'm aware that we have JIPIGO, NIMRI, and other partners whom I haven't mentioned, but we acknowledge your presence. The CSOs, and other partners such as Tasede, Thubutu, AfriWork, and all those whom I haven't mentioned, but we acknowledge your presence and your participation in this event. First of all, I greet you in the name of the Republic of Tanzania. Asante sana. Marahaba. I take this opportunity to welcome you to Tanzania, as I've said before, and I know you had some times to visit our touristic sites, such as Mount Kilimanjaro. If you haven't, then if you still have an opportunity, you can still visit such sites. Zanzibar is not far away. You can also visit Zanzibar. We have a very beautiful beaches there, and I think you'll take this opportunity to visit Zanzibar too. And I hope that you had a safe journey to our country. First and foremost, let me express my sincere gratitude for the Almighty Lord for giving us the health that we are enjoying without paying anything. And secondly, we extend our thanks to PATH, as I said before, for this meeting. To the best of knowledge, this is the first time the TIMCI project is holding its meeting in this country. And for the past 5 years, the government of Tanzania, Ministry of Health, PORALG, that is President's Office, and the Swiss TPH have been implementing the tools for integrated management of childhood illnesses, simply called the tools for IMCI. This is due to familiarity of IMCI interventions in the country. This project, which Unitaid supported, aimed at improving the management of childhood illnesses through the introduction of pulse oximeters and clinical decision support algorithms into integrated management of childhood illnesses. And I'm happy to join you today to discuss the project research and implementation findings as it was being presented here when I was coming, and to see how we can improve access to tools that detect severe illnesses in children. The government of Tanzania congratulates PATH, as I have said before, for these achievements and the other partners. And I believe that you have dedicated much of your time and energy in this. In Tanzania, we always say that there hakuna kazi ndogo, there is no small business. And so everything someone does, they must dedicate their full commitment. We know that. This also goes to the healthcare providers who are mentioned here at the facilities. That is the regional and district facilities, together with the community members in all these countries where this project is being implemented. We thank them very much for their participation. Detecting illness is the backbone of today's evidence-based diagnosis in the management of many diseases. Therefore, the work of the TIMCI project, not only timely but relevant in Tanzania's national treatment guidelines, recommends the use of pulse oximeter in the diagnosis of several clinical conditions. I believe this is also true for other countries which are being represented here. The outbreak of COVID has also exposed our country to the importance of pulse oximeters in detecting severe illness. And it is my view that this meeting is not only focusing on disseminating TIMCI project findings, but also on providing global solution for improving the detection of severe illnesses. Dear ladies and gentlemen, before I end my speech, let me remind you that most of our countries are still below the United Nations SDG and targets for child survival. Therefore, it is on this account that our government should prioritize on new science-based innovations to improve child health. And it is our role as implementing partners, research and policymakers to support our government's initiatives to reach this, the SDGs by 2030. Ladies and gentlemen, receiving the research results is a critical first step. But what is important and rewarding to researchers how these results to improve childhood management services and our policies. I expect that the TIMCI project and lessons learned that we have been hearing today will enlighten us on how to better implement pulse oximetry and digital health systems to improve the management of childhood illnesses in our country. And to our financial supporters, that is Unitaid, I thank you for your continued support for various health interventions in low and middle income countries. Our government will always provide the necessary support, as it was mentioned, to the success of any future project that you are going to implement in our country. And as we close our this project, our doors remain open for further partnership. I would like to end by wishing you an enjoyable and a very productive meeting. And now I should say that this meeting has been officially opened, although it had already started. So thank you very much for listening.
Okay. So I'm pleased to introduce the next section, which is TIMCI results, learning and key takeaways. And for that, I'm delighted to welcome back Dr. Grace Malu, the Senior Research Scientist at the Ifakara Health Institute in Tanzania. So over to Grace.
Thank you very much and good morning once again. I believe every one of us is back. Can I have some help here? Thank you.
I'll fix this for you. And there should be a remote change there. There are two things going. I'll come back with this.
Okay. Okay. I have 30 minutes to do this, and I hope I'll be able to finish within 30 minutes because, you know, when we start talking about science, sometimes, and we have a lot of scientists inside here, Disclaimer, I am not a medical doctor, but we have so many medical doctors in here. So if I speak or say anything medically and you don't understand me, kindly let me know, and then I will speak to my colleagues who are medical doctors to help us around. For this, I will start by acknowledging the PI of this project, Professor Honorati Masanja, who unfortunately is not here with us today because of other activities. But with me, I am together with Dr. Moshiro, who was the doctor, pediatric doctor within the project, but I'm also accompanied with Susan Makawia, who was our health economist, and Samuel, our data management. I think he is outside. So I don't know if I stand here, you can only see me, or I'll stand here because I am too tall and I'm thankful that I'm this tall. So as Leah has introduced, IMCI Plus, the criteria in IMCI, as we all know, is that it should be used for 2 to 59 months children with cough or severe difficult breathing. But for us in TIMCI, we added some other criteria, but because, you know, hypoxemia is common in non-pneumonia diagnosis. So particularly for this project, we added other criteria on top of the ones that were seen in IMCI. For example, I will not talk of everything, but for example, age. The criteria in IMCI is 2 to 59, but for us, we added some criteria for age. Example, for those who had less than 2 months, and this I will explain later where was it done. For those who were less than 2 months, we assessed other symptoms, and also we did hypoxemia. We did pulse oximeter measurements. And then if they were classified, if hypoxemia was less than 90 in Tanzania and Senegal and Kenya, they were referred. And if it was above 90, this was a classification according to other symptoms and signs. This is just an example of what we did to the normal IMCI guideline, and this is what we added. These were the criteria for pulse oximeter use and referral as were added within this project. For countries, India and Kenya, the criteria for pulse oximeter use was for every children, 0 to 59 months. And the criteria for referral, if a child had less than 90% SpO2, he was referred. Senegal and Tanzania, our criteria were a bit different. The pulse oximeter was done in all young infants, 2 to less than 2 months, pulse oximeter had to be done. And for 2 to 59 months, all children that had cough or difficult breathing or were classified with IMCI to have moderate or severe illness, meaning yellow or red classification. And our criteria for referral was 90 if the child had less than 90%. So I will talk of the measurement uptake of the pulse oximeter. How did we measure the uptake of pulse oximeter? First, we looked at the SpO2 documented by healthcare providers in paper-based records. As you know, in these countries, we have registers in the hospitals. So we were looking at these registers to see what the healthcare provider documented. This was captured by the research assistants in this facility through ODK. And then we did through SPA, standard service provision assessment, and this was a direct consultation observation. We had some clinical officers in these facilities who now observed if the care provider measured pulse rate or SpO2 or did not measure SpO2, and these were captured also by the healthcare, by the research assistant. And lastly, we did measure the uptake through CDSA, and this is clinical decision support algorithm that automatically captured if SpO2 was measured. Can you hear me now? Should I stand here or should I keep standing there? For us, not those online. Okay, I'll keep on standing here. So this was how measurement uptake of pulse oximeter was done in our research facility. Thank you very much, Mike. I can now go on standing here.
You just have to do both.
I have to do both, okay. Now, so I'll start with pulse oximeter uptake. I have to go back, and this is a bit confusing in a way. Sorry. So I'll start with pulse oximeter uptake in India and Kenya. And SPO2 was documented on a consultation card, as I said. And in India and Kenya, as you can see, pulse oximeter uptake rate was, if you look at this, sorry, this is not working well. Yeah. The point. Okay, so if you look at the SPA and RCT for India, you can see the uptake of pulse oximeter, which for SPA, this was indicated as 100%, as you can see. And for RCT, it was 94%, meaning everyone who was to be, where pulse oximeter was to be used for these children were used. And this was for the young infants, 0 to 2 months. And then for the older infants, you can see for the older children, it was 94 to 86% in both RCT and SPA. As I've said earlier, we measured pulse oximeter through 3 different things, and now I'll be showing this. For Kenya, the uptake was a bit different. When it was indicated in pre-post, as you can see the first slide, this was 78.4%. But during SPA, the research assistants documented that it was only uptaken 50%. And if it was indicated in SPA, it was 90%. And this was for young children as well as for the older children. So in Tanzania, this technology is a bit, okay. I point this way? Okay, thank you very much. This is another lesson learned. I pretend, okay, I'll be pointing at you, Mira. So in Tanzania, in Senegal and Tanzania, you can see the uptake as indicated for young infants as also as for the older children. When it was indicated within CDSA, it was 91.2%, as you can see there. I'll get this. It's only the beginning. We are here for the whole day. As you can see, for Senegal, it was 91.2% if indicated. And this was a similar percent of indication in pre-post, which was the uptake of 60% generally. And in Tanzania, as you can see, we have for RCT, SPA, for young as well as older infant. And in fact, when indicated was 96%. And if similar indication in RCT, the uptake was 60%. So adherence to steps during measurements, during the use of pulse oximeter. Most of the healthcare providers chose pediatric probes, I think for all of us who are doctors know. And adherence to the steps was, as you can see in this graph here, adherence to infection prevention measures was less or equal to 50%, less than 20% in Tanzania. IPC, meaning washing your hands before doing the measurements, was less than 20% in my country. And explanation given to the caregiver, if the healthcare provider explained to the caregiver what he was doing with the pulse oximeter, it was relatively low, 50 to 70% overall in all countries. But also good waveform obtained before reading, the 90%, this was very high, with exception in Tanzania, which was only 80%. But in other countries, as you can see, they performed the good waveform length was obtained very well, as you can see in the graph here. So what was the time spent on pulse oximeter use? For Kenya, the time flow studies, as Leah had explained before, were done in only 77. This was the population. And time spent was 0 to 1 minute to 29 seconds. And this was when there was no pulse oximeter use. This was in general. For Senegal, it was 1 minute and 29 seconds as well. And for Tanzania, it was 0 minute and 54 seconds. It means when the consultations were done. During pre-post now in Kenya and Senegal, and in control arms in India and in Tanzania, as you can see, it was 3 minutes to 21 seconds. In Kenya, in Senegal, it was 8 minutes and 16 seconds. This was when in pre and post control facilities, and in Tanzania, it was 4 minutes. Now, when the device was not used during the post in Senegal and Kenya, and in interventions arms in Tanzania, as you can see, now this was indicated that it should be used, but it was not used. It was 1 minute in Kenya, 2 minutes in Tanzania, and 4 minutes in 2 minutes in Senegal and 4 minutes in Tanzania. Post after in Senegal and Kenya, and this when it was used, it was indicated to be used and it was used. It was 3 minutes in Kenya, 6 minutes in Tanzania, and 6 minutes in Senegal, and 6 minutes in Tanzania. For the qualitative findings about acceptability, feasibility, and perceived impact of potential unintended consequences of the pulse oximeter, generally our healthcare providers accepted and perceived improved in quality of care, but lack of explanation to the caregivers. The healthcare providers were very, I can say they were very positive with the pulse oximeter. They liked it very much. However, this was not explained to the caregivers. As you can see, I indicated before, the caregivers did not get any information on when the pulse oximeter was used. As you can see, this code which says, so far for the pulse oximeter, it really helps you make proper diagnosis and accurate diagnosis. So the healthcare providers were very positive with the pulse oximeter. With regardless to that, they explained it to the caregivers. For the feasibility, the main barrier was time. Our healthcare providers complained that they used a lot of time to use the pulse oximeter. I did not say on the CDSA part, it's only for the pulse oximeter. And this was observed particularly in busy facilities and some difficulty in young infants who were agitated and who misbehaved, who were crying. So the time for using the pulse oximeter was also very high for these children, and this was a very big complaint. Some confused the use of pulse oximeter, the confusion, that's why also the time was very high. As you can see, one of the providers here is it is difficult to use it on every child in this primary healthcare. We receive around 200 and 250 patients per day. If we were to use the pulse oximeter on everyone, it would not be possible to treat all of them. So because of the time spent and because of the volumes in these facilities, some of the providers opted not to use pulse oximeter because of the workload. So estimated hypoxemia prevalence in TIMCI. As I said, for the pulse oximeter, we collected data from the registries, but also from the RCT pre and post and from CDSA. For this data, we are collected or documented from the registry as well, as you can see, RCT and pre-post. but also we collected data on hypoxemia prevalence in TIMCI through the CDSA data. And this was documented by the healthcare providers, and then we extracted the data from the CDSA. And this is hypoxemia prevalence. Hypoxemia prevalence, I think I'm doing well now with this. This was hypoxemia prevalence from the paper records, as I've said, from the registers, as well as from the CDSA data. And as you can see, for young infants in general, the SpO2 here, it was 0.4%. For those who had less than 90% SpO2 readings, it was 0.4%. And in young infant was 0.7, and in 2 to 59 months was 0.4. And for this was from the paper base. From the CDSA, it slightly increased, and those with lower than 90% or 0.5. For young infant, it's increased a bit as well to 1.3, and to 2 to 59 months, it was 0.5%. So we see with our CDSA data and the prevalence of hypoxemia, when we use CDSA, detection of hypoxemia among severe children was, I must say, increased or improved in some way. And these graphs are actually showing what I just explained on this. So we also looked at hypoxemia by subgroups, and this here I will particularly present data from Kenya. And for young infants in Kenya, hypoxemia by group was 1.6. For other children was 0.5%. For children 2 to 59 months, for those with cough and difficulty in breathing, it was 0.7. And for those with no cough and difficulty in breathing, it was 0.2. Now, for those with cough and difficulty in breathing, as you know, the IMCI now has the classification. For those who were classified with severe pneumonia, it was 6.7. For those classification red. Classification yellow was 2.2. And for those with cough and cold classification, this was blue, it was 0.3. And this was for no cough and those with no difficult breathing. As you can see, the IMCI, when it was green, it was 0.2, 0.1 when it was yellow, and 1.6 when it was IMCI red. So what are the key takeaways? Uptake, feasibility, and acceptability. As I've said earlier, pulse oximeter broadly was feasible and acceptable by the healthcare providers, regardless that the providers did not share or did not tell the the caregivers of what was happening, regardless that some of the IPC measures were not taken, but this was very acceptable and feasible. This was reflected by the general high uptake, as I've shown before. It was more than 60% in all countries, the uptake of pulse oximeter in all these research sites. So although we had variation between and within countries and over time, however, the uptake was very high. Additional workload was posed as a major challenge in busy facilities. The providers were not able to use the pulse oximeters in these facilities because, as I've said, you have 30 children lining up outside. All of these are waiting to be consulted by you, who is a doctor, and then you have a pulse oximeter there. So in some ways, you know, and you have to see all these children. Sometimes it was hard for the healthcare providers to use the pulse oximeter. For implication for approach and introduction should include criteria for use, possibility of task shifting, so that not only a single provider sees all these children all the time, but also we should have like those who are coming in the morning and then those who are coming in the evening to task shift. Or sometimes nurses would have been allowed to use the pulse oximeter because some of these facilities, it's only the doctors or the clinical officers who are allowed to use the pulse oximeters. So if we perhaps use task shifting, it will be helpful for us to scale up the usability of pulse oximeter. And with this, takeaways for hypoxemia. So hypoxemia was relatively low, but variation across countries, as you have seen, but similar to other severe signs in primary care. And this was particularly detected by CDSA. But hypoxemia may be lower than true prevalence. Very sick children not have been enrolled in the study. As you know, in some of our settings, if a caregiver sees that the patient, her child is very sick, they skip the pathway. Instead of taking the children to the lower facility, now they take them to the higher facilities, which might have contributed as well to very severe and sick children not being enrolled in the study. But also uptake and documentation by the providers, but also by the healthcare, by the research assistant might have had variation. That's why we see a lower prevalence. But also the lower prevalence might be because of the estimated influence by population and setting. For hospital-based estimate, it was up to 50%. For pneumonia IMCI subgroup, it was 9 to 23%, and higher among infants as per other studies, but we should also consider altitude when now trying to evaluate this, but also implication for choice of criteria. And for this, thank you very much. I will have 5 minutes for questions, and we were to co-conduct this session with Professor Masanja, but unfortunately he's not here. So I will wear his cut now. And now I'm Professor Masanja standing here. And I welcome you guys for questions for the next 5 minutes. Yes. Okay, perhaps we start here.
One thing we can call also to the stage,
yes,
COVID, Des, and Leah. And you can just stand here on the stage to help answer questions, etc.
Thank you very much. Now, finally, the questions won't be that hard.
Yeah. Okay, so I can pass the ball. Where should we start? We'll start from here in the front. If you say who you are, and which country, and the question.
So, great presentation. My name is Tisum Valo. I'm a pediatrician, associate professor in pediatrics from Malawi. I'm pretty sure this is covered, I just don't follow yet. So the device that was used for post oximetry, any specifications, how child-friendly is it? How is the probe user-friendly for children? Was it the same probe across countries? And is this something that's been validated for children as well in the past? Because obviously a probe for my thumb and a probe for a 2-month-old are different.
Okay.
Hello, I'm Marine Vignon from Alima, and I manage the AIR project. I have 2 questions. Thank you very much for the presentation. The first one is, I have a question about the time and the time when they use the pulse ox. And my question is, where did you introduce the pulse oximeter in the consultation process? If it was before or after the malaria rapid test, for example, if they use it. And the other question is about the hypoxemia prevalence. Did you adjust the result for the Senegal with 92%? Because it was like 90% everywhere. Thank you.
Do you want to respond first before we take the next?
Yeah, I'll respond to the first question. The different types of probes that were used, preferred by the providers. I can say specifically more from the side of India that we largely, there were the pediatric probe that was used by the pediatricians and by the physicians, by the doctors. And also, the other preference was if the site is a finger, for example, for a cooperating child, a pediatric probe was found to be very useful and they were able to. But if the child is not, submissive or he's irritative or something, then they used adult probe into the toe so that it is easier to manage. And that was also part of because of these learnings, that became a part of the learnings of this, of the to the providers in any subsequent trainings, that you can use these two sites. That was the experience from India.
Okay, probably just to add on that. Yes, we had the pediatric probe. We have all the probes, and we have the pediatric probe, which initially we thought it will suit the purpose of handling the neonatos, but it happened that it did not happen the way, because sometimes we think theoretically, but in the practical it becomes difficult. So all neonatos was very cumbersome, troublesome, and that was reported all over in most countries. So we had all the probes suiting our theoretical thinking, but in practice, it seems that even the pediatric probe did not work the way we expected.
And just to add, when it comes to during a consultation, if you're using a pulse oximeter, for example, and if a provider has to change a probe, that was flagged as a problem. They do not like it. So people like to be more simple, maybe. So we had, suggestions like, why don't you give the pulse oximeter that which is easy to switch, or even in single unit, multiple probes options are available. So, yeah, this was a challenge. 3 probes are there: the adult pediatric and neonatal probe. But for us, it was either the pediatric probe for a cooperating child and an adult probe in a lower limb on the non-cooperative children.
Thank you very much, COVID. I think we will respond to the second question, but online I should acknowledge Dr. Shali, who was the PI for India. She's also online with us, and I think she can hear us. And Dr. Shali, if you have anything, an addition, please just let us know and we will spot you. Okay, so to answer your second question, and then we'll take another round of questions perhaps for 5 minutes later, not more than 5 minutes, and then we'll finish. You asked where was the pulse oximeter introduced in these facilities. So for many of the facilities, like example in Tanzania, the pulse oximeter was staying with the clinical officer / the medical doctor. So within the consultation, it was before. Oh, that was the question, sorry. At what stage of the consultation? This now depended on the healthcare provider and when they wanted to use it. However, for those that were using CDSA, Clinical Decision Support Algorithm, the algorithm was very clear on when to do measurements within the algorithm. For those that were only using pulse oximeter, this depended at what time the healthcare provider decided, because they were not trained even if they were trained on at what time to use the pulse oximeter, but this was a decision depending on themselves on when to use the pulse oximeter during the consultation. I hope I've answered. Dr. Mjungu, perhaps, yes.
Yeah, basically due to the criteria which was given, especially in Tanzania and Senegal, then it was the decision of the healthcare provider to decide, after weighing whether this child fits the inclusion criteria for the use of the pulse oximeters. So as Grace has said, once he has started the consultation and determined that the child fits into the inclusion criteria, is when he will decide to use that one. It might have been different for the other countries, and for the Kenya, because it was used for all children, and probably it might be somewhat different.
Yeah, thank you. I'm Andolo Mheso, the TIMCI project from Kenya. Just to add on what my colleagues have said, I want to say in terms of whether the pulse oximeters were validated, we actually used UNICEF for procurement. So we went for the highest possible quality standards, and we used ACARE pulse oximeter. And I think the reports we have, they function well. We had no breakages compared to even what was procured during the COVID-19 pandemic. In terms of where pulse oximeters were placed, whether it was in the consultations or triage, this depended on the adaptation, country-specific adaptation of pulse oximetry into the IMCI. And for Kenya, it had been long decided that SpO2 would be a vital sign. So in this case, then pulse oximeter were placed in the triage before children could go to the consultation. But there was still an option of the clinician in the consultation room to also confirm. And I think just to say on this, that's why when she presented the service assessment results, it was found in Kenya that it was 50% because of the observation. But that is because that now speaks to the pulse oximeters that were in the consultation room, but majority of pulse oximetry taking was taken in triage, and therefore a research assistant in a consultation room would not have seen it being taken. And that is why you see it is higher in CDSA. Thank you.
Thank you very much. My name is Sabrina Chitaka from Uganda. I'm a pediatrician. My question was the prevalence of hypoxemia related to referrals? And then the second question, which is really short, was what was the influence of COVID-19 during the study? Thank you.
Okay. Thank you for the presentation. My name is Garba Mohammed Ash from Nigeria. I'm a pediatrician, actually. I'm just looking at this particular slide that actually speaks about the criteria that was used for different setting and also for different patients that have been used. Looking at India, Kenya, we're having for all children, and we set the criteria to be 90. While of course in Senegal, we're having 92. It will be interesting to see how this influences the actual likelihood ratio of really diagnosing and referring in terms of the outcomes, knowing fully that those that are having diseases other than pneumonia, pulse oximeter of less than 90 has been shown to be not a very fair criteria. So it will be fine to really see the comparison in this different setting in terms of likelihood ratio. Then of course, I also saw in the presentation that ability to apply the pulse oximeter is much better in young children, having 100% in almost across all the sites compared to oil. Is there anything that we can learn that actually make it more for the young one 100%, while in the other children we're having a bit lower value, even though the figure is not actual? Then of course, this is a little bit technical. Hypoxemia or hypoxia, which one are we really talking about? Thank you. Thank you.
Yes, we have time. Do I have time to ask? Okay, thank you very much. Thank you very much for the presentation. Excellent work. I have a couple of questions, more than 2-3 questions. Just one is that WHO introduced less than 90% SpO2 to be referred that child to a higher center. But you introduced a new category, which is less than equal to 90%. So let us know why you use this less than equal to 90%. Secondly, about the timing, the time showed very short mean time, but at the same time, the health worker complained about that they are using a larger time. I'm not sure how did you calculate the time and how health worker perceived the time for taking pulse oximetry. There are two different things, because you showed us less than 1% even as a mean time, which is surprising for me, because I have used these pulse oximeter and less than 1%. I don't know how did you calculate it. It's impossible to take pulse oximetry in less than 1% in young infant or even in children less than 5 years of age. Thirdly, you mentioned about PO2 uptake. How did you define this uptake? Because it's a very vague terminology, uptake. And lastly, you showed us a very low prevalence. That means in some of the cases, you have to perform 1,000 cases to have one hypoxemic case or hypoxemia case, which is very difficult for the policymakers to say that, okay, we need a pulse oximeter at a lower center, because once you perform 1,000 cases, then you will detect only one case. So why it was so low? Do we have anything about the standardization practices? Do we did did we perform something to standardize their practices? Because these are huge population of health workers. They are coming from different backgrounds. Some of them are clinical nurses, some of them are physicians, some of them are only a very low cadre of health workers. So we are assuming that their training is similar, their practice is standardized. So did we perform something during the research to standardize their practices so that once we have seen these results and we believe on these results, that the prevalence is low? So these are few of my questions. Thank you very much.
Can I take this question, Doctor? Am I audible?
She is available. Yes. Professor Shelley?
Yeah, can I say something?
Yes, yes. Go ahead, please. We hear you.
Very interesting questions, Dr. Yasser, and I'm sorry I couldn't be there physically to meet you and discuss with you. I think we did point out that the SpO2 cutoff, which WHO recommends and which
Perhaps, Professor, you should switch off the video.
Are different, but lines.
Okay.
Okay, good. Sorry. Is it better now? Is it better?
Better. Yes.
What I was saying was that we took the cutoff different from WHO cutoff for referral in hypoxemia because one of the African countries had that referral cutoff. We really understood what the WHO does recommend. But we took that, and I guess that did not hamper the result. But the other question which you said was the time taken for pulse oximetry. I think you are right. If you take the time from there, the other time we also have from the child entering to the child exiting and pulse oximetry in between. So if you take that time, it was longer than the amount of time attributed to putting it on the limb, taking the reading and putting it off. Now, there could be multiple unsuccessful readings also when the child cries and you have to put the oximeter again and then do it. So we can look into that data also and revise the timings as you're seeing. What you have rightly flagged as an issue which concerns me also is the low prevalence of hypoxemia, which we found. Now, what I feel is, at least from India, the measurement was done by doctors at PHC and CHC, and the sickest children perhaps went directly to the higher center. So there could have been a bias towards less sick coming for this RCT. That's all I can say of now. But yes, but what the lady before the question and answer was showing, in severe pneumonia also, it was 6.3% hypoxemia, which is much lesser than what we get in hospitalized cases. Now, mark you, the hypoxemia in hospitalized cases can be up to 20%, 23 to 25%. So we have to sit together and get a further understanding of this low prevalence of hypoxemia. Over to whosoever is taking it. Grace, is it you?
Thank you very much, Professor Shelley, for the best answers. I hope Professor Yasser is satisfied. We'll go to the next questions and then we'll hand it back to you if you have any more questions. So the other question was the timing. I think she has already responded. When was it introduced? It was already responded to. You asked, was it hypoxemia or hypoxemic? May I handle it? Yes, to Dr. Robert. He'll be able to respond hypoxemic and hypoxemia. Dr. Robert, please.
Thank you. I hope I can. But so I think basically when you do pulse oximetry measurement, you are looking for hypox or such percentage of saturation of hemoglobin. Now, whether you want to term that hypoxemia or hypoxia, I think these are words interchangeably used sometimes, but for this particular study, we have termed it as hypoxemia, meaning that there's partial pressure of oxygen in the hemoglobin could have been low because of the reading from the pulse oximetry.
Thank you very much. Are you satisfied? You're fine. Okay. You can see Dr. Moshiro later on and other doctors in the room if you're not satisfied. We'll go to the question from Uganda. And the question was prevalence of hypoxemia was related to referral. I will hand it to Dr. Leah.
So what we have been showing is one slide referring to hypoxemia prevalence in general. As you also have seen, as the referral rate was extremely low and lower than what we expected. And as I mentioned at the very beginning, we are running sub-analysis. We don't have a slide on that as of now, but the team is looking into it. So I can't really answer your question as of now, I'm afraid. There was another question related to neonates and that the uptake was very high among the neonatal group. Again, just to inform you, there was actually a nested study within TIMCI, which was particularly focusing on neonates. And this was led by Gillian Levine from Swiss TPH, and then a lot of colleagues here in the room and the different institutions. And again, we're waiting for these results. So there will be results specifically focusing on the neonates. And I think Gillian and the team can then provide you with more details on that. There's certainly a hypothesis, and when looking at the qualitative results as well from the studies, that healthcare providers said that for neonates, it is more difficult to diagnose them. They can't speak. They can't share their own complaints, right? And even caregivers have to often guess, what is the problem of my newborn? So the hypothesis could be that healthcare providers feel more confident when it comes to using the devices on neonates compared to older children. And we see from the qualitative results that some of the healthcare providers indeed said, particularly for neonates, I think it's very useful because it gives me more assurance of my diagnosis. So I hope it at least in part answered your question. And I'll hand over to you again.
Thank you, Dr. Leah. We'll finish with the last question, and this I will hand over to Dr. Mjungu. The question was on COVID. What was the implication of COVID during the study?
Thank you, Grace. Probably I will answer this from the implementation point of view, that COVID-19, it has both negative and the positive impact on the study. The negative side, it was on the during the assessment. It was the time when we had to start the assessment of the facilities where the study will be conducted, and the movement was restricted, and it was to change the modality of assessment. Instead of doing it physically, we had to do by phone. So that was the negative part of it. But on the positive part of it, LFT has to sensitize and to create awareness of what is the pulse oximeters, because it was easier to tell the community that, okay, we have the devices which helps it to detect the saturation, and then it was easier for them to relate with the COVID. So it was easier by them to take the message, but also even to the healthcare provider, because we have some healthcare providers who had never seen even the pulse oximeters. So during that time, it was easy even to tell the message to the healthcare providers. So those were some of the positive and the negative impact of the COVID-19 to the implementation of the study.
Yeah, just to add on what happened when the COVID-19 came in. So I think from the and pandemic was we should not be saying that there are good things of the pandemic, but yes. So sensitization about, as Dios has mentioned, that sensitization on the pulse oximeters as such increased. But again, and this was a specific issue for our country, that the government has actually deprioritized everything else during COVID, and I'm sure it was across. It came back in phases, but the availability of pulse oximeters, and with pulse oximeters, I would be saying the fingertip devices, not the pediatric appropriate devices. So a larger availability of fingertip pulse oximeters was made available during COVID-19 pandemic as a part of the COVID-19 response of the government. For the pediatric space, use of those and use of the fingertip devices are not necessary. This we have had our feedback from the users, the physicians and pediatricians, that those devices are not really as appropriate, as accurate as the what we were using in our project. So there was that shift, that challenge of having a fingertip device versus a pediatric appropriate device. That was a challenge that we had to navigate during the project time. And this was a challenge. We are still, because the availability of the fingertip devices is very common, it has been made, but for the pediatric specific devices, yeah, we are still navigating through those lines.
Maybe just to add to that, again, from a qualitative perspective, certainly the pandemic has influenced also this project. And as you all know, it changed our own care-seeking approach. Often we were not able to go to health facilities, leave our home, depending on context. And when Dr. Kovac was just speaking, it reminded me when I was visiting one of the sites, the TIMCI sites in India, there was still a string between the door of the healthcare provider. And the reason was that the caregiver coming with the sick child was not supposed to get too close to the healthcare provider. So actually the entire consultation was done in a distance, meaning also it impacted the clinical assessment because you were not supposed to touch the children. So I think all of this we need to certainly take into account, and there were a lot of different also contextual factors at play here.
Thank you very much, Dr. Lea.
Hi.
Should we?
I think we're gonna add, well, I noticed that we didn't quite answer the why 92% question, and I wanted to go to our colleagues from Senegal,
yeah,
to have them, because they made that decision. So.
Merci beaucoup. Je suis professeur par Mokhtar Faye, pédiatre au Sénégal. En fait, yes. It was English dominant. Yes. I will introduce French. Yes. Alors, je disais que, en fait, yes. Oui, je voudrais d'abord, avant de répondre à la question sur le seuil. Le seuil qui a été utilisé dans tous les pays, au lieu de inférieur ou égal, c'est plutôt strictement inférieur pour 90% ou 92%, plutôt que inférieur ou égal. Alors, la décision au Sénégal de revoir un peu le seuil vers le haut est une décision que nous avons prise en lien avec le ministère, parce que dans notre expérience, et ça c'est une expérience clinique au niveau de l'hôpital, on considère que lorsqu'un enfant arrive jusqu'à 90% de saturation, peut-être que la situation clinique est déjà assez altérée, que s'il y a d'autres signes de danger, il peut s'agir d'une situation qui peut être très grave, qui peut conduire à certaines complications qui ne peuvent pas être gérées forcément au niveau du périphérique, au niveau du poste de santé, et qu'avec les conditions de référence, il était plus prudent de remonter ce seuil-là à 92%, en sachant qu'il y a une grande différence entre le Sénégal et les autres pays qui est en rapport avec l'altitude. Parce que quand on voit le Kenya ou la Tanzanie, je ne sais pas trop pour la Tanzanie, mais pour le Kenya, on a des niveaux d'altitude qui sont complètement différents, ce qui fait que la prévalence de l'hypoxémie, même en utilisant des seuils différents, est beaucoup plus élevée au Kenya qu'au Sénégal. Et donc, nous, on considérait que si au Sénégal, on arrive à un taux de saturation qui était inférieur à 92%, il était plus judicieux de considérer cela comme étant une forme sévère d'hypoxémie et que ça devait motiver la référence, le traitement d'urgence et tout ce qui s'ensuit. Voilà.
Merci beaucoup. Thank you very much, Prof. I hope and believe every one of us has understood what he said. I also understood and I was nodding. So we'll have one more round of questions, 2 more questions, and we'll be done with this session and move to the next. Yes.
Thanks, Grace and team. Great talks and discussions. My question, I'm not sure whether this will be discussed later, but it relates to this area where there was a consultation actually last week around the measurement bias with skin pigmentation with respect to prevalence of hypoxemia. Thank you.
Thank you very much. Should I hand it to Mike?
I might need to take. Yeah, so that's something that hasn't come up in this meeting yet, is the bias for pulse oximeters when used on patients with darker skin. And so that is a piece that this project has added to our outcomes to investigate and actually really still looking at that. We had hoped by now we would have an answer in terms of what's causing that from pulse oximetry and maybe a remedy. However, it turns out that it's actually quite complicated, and it's a combination of many factors, including dark skin, but also motion, perfusion, some things like the thickness of the finger that the pulse ox is being used on. And so to answer your question about how does that affect the prevalence, or I think the answer is we're not sure. Because the initial research showed that pulse oximeters would often overestimate SpO2 in patients with dark skin by about 2%. However, after doing many tests on many different pulse oximeters, our partners at UCSF, who I don't think are online, have discovered that that is not uniform across the devices, and sometimes even underestimated by different devices. And so I think we're still looking into that. But the one of the takeaways is that the pulse ox is a useful tool, but often looking at it just once as a spot check can be less accurate. And then also looking at it as a tool that is providing one data point in a series of data points that is the clinical consultation is important. So maybe not looking at it as the decision-making factor, but one of many decision-making factors. So great question. And we do have ongoing work with our partners at UCSF, who are global experts in this. And so we can follow up. If anybody has questions, please continue to follow up with us. And as we learn more, we'll keep you posted on all this. Oh, and there's an open oximetry website. If you just Google UCSF, University of California, San Francisco, open oximetry, you'll find their website that has a lot of information about all of this. Thanks.
Thank you very much, Mike. We'll just take 1 or 2 more questions. And yes.
Okay. Please, I will speak in French. Okay. Je suis Elisène Drimbogui de la Côte d'Ivoire. Je voudrais savoir par rapport aux critères de choix des sites où le projet a été mis en œuvre dans les 4 pays. Je crois que dans la présentation du Dr Léa, elle a parlé des différents critères. Mais je voudrais savoir, est-ce que le taux de décès infantile a été pris en compte. Est-ce que l'aspect des infrastructures au niveau des structures de santé a été aussi pris en compte? Et puisque nous sommes maintenant à la fin du projet, je voudrais savoir quel a été véritablement l'impact par rapport au taux de décès. Mais pour le choix des sites, est-ce qu'on a aussi tenu compte de la densité du nombre des enfants? Voilà, au niveau peut-être des districts sanitaires ou bien des régions sanitaires. Merci.
Thank you very much for your question. And for those who speak French, you will correct us. The question was on death rate and mortality in general. And if we've taken into account that, I hope was during randomization, if I got it correctly. Dr. Moshiro, please come in here and help us chipping in on that because you also had the question. Can we pass the mic to him, please? And then I will also add on.
Let me just add on to what my predecessor just said. I'm Dr. Masunyo from Zambia, a pediatrician. It's good actually from the introductory presentation. This is an add-on to where we started from as IMCI. You heard the figures. When we started IMCI in 1995, globally, we were looking at 11 million deaths globally. Now we are at 5 million. And we know now that IMCI had an impact. So we are now looking for the last mile. What should we do now to reduce to 2 million? And TIMCI seems to be one of those directions that you have done, and it's a good study. So this question really is to just add on what he has said, that do we see mortality being affected? In Zambia, before IMCI, we had 119 per thousand. Now we're at 61. We are now targeting 26. So what is it that we should do in a policy direction? I was happy when I saw WHO here, because last time when we were in Kenya, we didn't have WHO. So for WHO to buy into this, what should we tell them?
Prophet Samoshiro, and then we take it to Dr. Yasser.
Yes, regarding the selection of the facility, so the first thing that was considered was the number of patients that were attending in this facility. Remember, this was the primary healthcare facilities. So for example, in Tanzania, we had to make sure that at least these facilities recorded attended at least 30 patients per month. And facilities that were not reaching those numbers, they were not selected. Issues with the mortality, as far as I understand, we did not really look at the records previously of the mortality. Rather, the mortality was estimated or was presumed based on the available literature. And if I remember correctly, there were assumptions that the mortality will be around 1.3%, I think. But I think this will come more in the next sessions in the afternoon, where we present the results, and there will be more information on how this was achieved. Yeah.
Thank you very much. And to you, Dr. Yasser. One more question.
Yep.
Before that question, perhaps Dr. Yasser should respond, and then we'll come to you with that question. Thank you. It's to you.
Okay.
Yeah.
No question. Okay. Thank you very much. Two important things which I would like to mention it here, as mentioned by Zambian colleague, that we have reduced the mortality in under 5 during the last 20-25 years by using IMCI strategy. It's not only tools, it's a whole strategy how to treat acute illnesses in children less than 5 years of age. Introduction of pulse oximetry would help to reduce further the mortality, because we still facing 5 million mortality per year in under 5, which is, but my question is again, when we introduce pulse oximetry, there are some basic questions which are still not answerable with this research. First is, which child actually need pulse oximeter? If we see from these results, very raw results, I would say, because we haven't digged into what actually, where should we do the pulse oximetry? There is no response at the moment. We don't know, because if we see the prevalence overall, you have to perform 1,000 tests to get one case. So why we use pulse oximeter at the lower centers then? It's a useless. Why should we introduce in the IMCI? It's useless. As you mentioned that even health workers is saying that it is taking too much their time. So why they should spend their time when they have to find only one case out of 1,000? So that's another thing. The second important thing is cost. When you go to the policymakers and ask them to introduce this pulse oximeter, you need to put the cost, not only the equipment tasks, training, maintenance, and then lastly, the link between the facility and the hospital where the oxygen is available. That's also very important. We don't know whether that link is available at present or not. Secondly, if it is available, is it functional or not? And lastly, that even we refer them, will they reach the hospital to get the oxygen? So there are very unknown or unanswerable questions here before we say that we are ready to introduce. Yes, you can put a pulse oximeter at these facilities, but believe me, if it is not effective in terms of mortality or in terms of improving the child's survival, nobody will use it in the next few years. And it will be a one equipment which is lying in the facilities and nobody is using. So be careful. These are very useful results, and we will take care of these results. And these results actually give us some direction that whether to use these very important device at the primary level facility, or do we need something else to save these children who are hypoxemic, who need hospitalization, who need oxygen for their improvement. Because without oxygen, medical oxygen, if a child is hypoxemic, without medical oxygen, it will not be treated. There are few cases where there are like a borderline, which can be improved because of there are some measurement errors at the facility level. That's why I ask about the question about standardization of their practices, because in this research, it seems there are not, because there are physicians, there are health workers, there are clinical officers, there are nurses. So these are all different cadres. So a very important question for all of us to think very carefully that when we are giving this task to a health worker who is sitting in a resource limited setting, with a very, very few facilities over there, once he or she detects a hypoxemic child, what will be the next step? That is the most important. Identification is important, but action point against that identification is the most important point. And if we say only detect, that's it, this is useless, because it will actually stop them to treat that child which was previously treating with antibiotic. Now we are saying just refer that child because of the hypoxemia. And without having a good referral pathway, it's impossible to do this. So thank you very much for that.
Thank you very much, Dr. Yasir. We'll take one more question from this end.
And as I slowly walk that way, I want to say that was a preview for Yasir's session tomorrow. Thank you, Yasir. I also want to say this is great discussion. Thank you very much. And I want to say for prevalence, I think we didn't enroll very, very sick children that were obviously needed to be referred. And so I'm going to hand it to our, please say your name and where you're from.
Thank you. I'm Dr. Mokore Orishe Amos. I'm from Nigeria, the Ministry of Health. My question is for clinical judgment, where will be the best place to situate the use of pulse oximeter? Will it be beneficial to put it as part of the danger sign or as part of the assessment process for COVID? Thank you.
Thank you very much for that question. I'll hand it to Dr. Moshiro to respond, and then afterwards, one more comment and we'll be done with this.
Thank you. I'm not sure if I have the right answer, but I think you've heard even different countries had different ways of utilizing the PASOKs. So for us in Tanzania, we recognize that probably the risk of hypoxemia is towards those children that present with cough and difficulty in breathing. And that's why that was one of the criteria, because if you were to use it to all the children, it would have taken more time. And as Yessa said, you would detect a fewer number of children, and probably that is not productive. So to me, I think still you need to put it as part of the assessment of the danger sign. Once you see that particular child has certain signs and symptoms that leads you to need the input of whether the child has hypoxemia or not. That is my opinion, yeah.
Maybe to add to that, and thank you very much for your question. Again, when looking at the qualitative results, we can see very clearly there is a knowledge due gap. So healthcare providers, many of them set pulse oximeter, clinical decision support tools. If I'm using them, I know I'm improving my care. But at the same time, and also on the slides, many of them said, time is my major obstacle in using it. And this is also leading us to the question, and I think we can't really give a clear-cut recommendation as of now, but whether we should actually consider task shifting. And we could also see, particularly in the context of India, where we conducted a pilot for the CDSA, here in the context, we had medical doctors who were supposed to use the devices. And it's, again, something to consider. Maybe it reduces the burden on the healthcare providers actually conducting the consultation and having to do a lot of tasks, asking a lot of questions, examining, referring, diagnosis, treatment, etc., to consider the task shifting prior to the consultation. But again, not yet a clear-cut answer, but it certainly leads us to at least asking ourselves if that could be an option to make it more acceptable and feasible in context.
Thank you very much, Dr. Leah, and I will handle it over here for 2 minutes comment, and then we'll wrap the session.
Okay, thank you for again recognizing me. The discussion is very interesting, and I can see the passion we are having. Being a clinician, I'm just looking at this. Again, it has to be context specific, different context, different setting. This may be actually applicable in different level. Let me actually take Nigeria, for example. We have an IMCI document that has actually undergone several reviews to really make it contextual. We have provisions for the very sick children, even those that are sick, and referral are not possible because of the existing reality. And of course, guidelines are there. I'm looking at this tool as an add-on, so to speak, a supplement, a complementary tool, rather than probably looking at it as one magic bullet that will do and revolutionize the whole actually management of childhood illness. It's the value that we're going to really see. And that's why I'm saying contextualizing this is very key, rather than looking at it as something that can just revolutionize and start bringing results and saving lives. Again, cost-benefit analysis of life saves, we all know their limitations and what that actually translates into in terms of but there are quite other values that you have as a clinician and also patients that have been seen. How many unnecessary referrals have actually been probably averted because of the fact that the assessments say otherwise? Again, looking at those ones. So we need to look at this in a more broader and context-specific than to really think that we can actually have a conclusive evidence that will say, okay, useful, not useful, and at least we are in it. And I really commend you based on what you said to achieve. Most of them has actually been achieved, and so many questions have now been coming up, which I believe that people can go into it with the view to answer these questions. And again, congratulations. That's just my.
Thank you very much. And indeed, we received the congratulations because a lot was done. And for this, thank you very much for this session. Thank you for all for participation. Thank you for the questions. And I will repeat saying, if there were no questions, it means we were not understood. But questions were there, it means you understood. And for this, thank you very much. Could you clap for us? We did a good job.
Thank you. You did it for me. Thank you for a very rich and dynamic discussion. So I'm very pleased now to introduce to the stage Professor Papa Mukta Faye. He's a professeur titulaire de pédiatrie, University Sheikh Anta Diop de Dakar, Senegal. And sorry with my French pronunciation. Oh, do you prefer?
Yes. Okay, I'll have a computer. This is full. I will speak in French.
Yes.
Understand?
Sorry.
So, je voudrais vraiment remercier PAF pour l'organisation de cette réunion de restitution et tout le plaisir. Et dans le cadre de ce projet, depuis 2019, 5 ans, il y a eu beaucoup d'expériences positives, aussi bien au niveau de la recherche qu'au niveau de l'implémentation. Et donc, j'ai eu le plaisir, dans le cadre de ce projet, de travailler avec notre institut qui est le Centre d'excellence africain pour la santé de la mère et de l'enfant, dirigé par le professeur Ousmane Diaye, de travailler avec le ministère de la Santé du Sénégal, représenté par le docteur Birane Bout ici, et le docteur Ndoye également, qui travaille dans un des districts où le projet a été implémenté au Sénégal. Donc, nous avons également travaillé en étroite collaboration avec PAF et bien sûr avec Suisse TPH, représenté par Dr Léa, qui a coordonné tout ce qui est recherche dans le cadre de ce projet. Alors, moi, je vais vous parler d'un des outils qui a été utilisé dans le cadre du projet, qui est... alors, I would like to il faut que je sois sur les mêmes diapositives. Voilà. Alors, l'outil qui a été utilisé, c'est le CDSA. Alors, le CDSA, c'est Clinical Support Decision Algorithm, qui est un algorithme de décision clinique qui, associé à l'oxymètre de pouls, on constitue les deux outils, d'où le nom TIMCI. Alors, c'est un outil digital, le CDSA, qui permet d'avoir des propositions pour la prise en charge du patient, mais ces propositions vont être, disons, adaptées à chaque patient en prenant en compte un certain nombre d'éléments. D'abord, tout ce qui est evidence-based, c'est-à-dire que tout ce qui est recommandation dans le cadre de ce CDSA provient de données qui ont été prouvées par des études scientifiques. Les informations également ou les propositions vont dépendre des connaissances, des aptitudes, de l'expérience du prestataire. Donc, plus le prestataire a un niveau élevé, plus cet outil va être utile dans le cadre de sa consultation. Et puis, ça va dépendre, bien sûr, des informations du patient, que ce soit des informations en rapport avec les antécédents, avec l'examen clinique ou avec l'histoire médicale. Alors, comme vous le savez, c'est un outil d'aide à la décision. Et dans le contexte de digitalisation globale du système de santé, de dossiers patients informatisés, cet outil peut être utilisé soit seul, soit associé à un dossier médical patient globalement. Mais dans le cadre du projet, bien entendu, on l'a utilisé seul. How to move the... OK, alors, comment on est arrivé à cet outil, à ce CDSA? Alors, d'abord, il a été question d'en définir le contenu. Et pour ce qui est de ce contenu, il a fallu partir des éléments existants. Les éléments existants, c'était quoi? C'était l'APCIME ou AMCI de l'OMS. Mais en plus de cette PCIME, on a rajouté tous les autres documents de référence, que ce soit des documents de référence de l'OMS, tels que par exemple le tri, évaluation et traitement d'urgence, ou étape en anglais, d'autres recommandations internationales, mais surtout d'autres documents de base au niveau national. Par exemple, au Sénégal, il y a un document que nous avions élaboré avec le ministère de la Santé, qui est le guide pratique de gestion des urgences pédiatriques. Et ce guide a été, ou les informations, les recommandations de ce guide ont été largement utilisées pour définir le contenu clinique, parce qu'il fallait déjà définir un contenu clinique. Et dans notre cas, par exemple, en plus des diagnostics classiques qui étaient dans notre algorithme PCME sur papier, donc AMCI paper, nous avons décidé avec le ministère, avec les prestataires, de rajouter un certain nombre de diagnostics pour étendre les possibilités de prise en charge du prestataire au niveau des soins de santé primaires. Alors, une fois que ce contenu a été défini, il a été traduit en logique, algorithme décisionnel, par un processus de développement qui était très technique, en consultant le ministère de la Santé régulièrement sur des questions précises. Et ensuite, la prochaine étape, après avoir obtenu le contenu définitif, a été d'avoir une validation technique par le ministère de la Santé dans le cadre d'un comité qu'on appelait le comité technique de survie de l'enfant, où il y avait des pédiatres, des médecins de santé publique, des partenaires techniques et financiers, pour être tombé d'accord sur un contenu final de cet algorithme qui va représenter notre PCME ou notre AMCI. Ensuite, l'algorithme, bien entendu, devait être développé sur le logiciel et puis testé avec des scénarios cliniques. Nous avions, avec SwissTPH, élaboré un certain nombre de scénarios cliniques qui couvraient à peu près la majeure partie des pathologies qu'on pouvait rencontrer au niveau des soins de santé primaire. Et enfin, ça a été couché sur une tablette. Et pour les prestataires, et avant l'utilisation, avant la version définitive, on a testé cette application au niveau de quelques postes de santé, 1 à 2 postes de santé dans chaque pays, pour voir les dernières, disons, les derniers ajustements à faire pour avoir cette version définitive. Et donc, finalement, qu'est-ce qui a influencé le contenu du CDSA? C'est bien sûr les documents de référence, qu'ils soient des documents nationaux ou des documents internationaux, les guidelines, mais également c'est l'épidémiologie locale. Est-ce que voilà, le paludisme constitue un problème? Oui. Est-ce que l'infection à VIH? Est-ce que la drépanocytose? Donc, tous ces éléments ont été pris en compte dans chaque pays pour adapter un peu le contenu. Bien sûr, on a pris en compte le niveau d'implémentation, les sites où ça devait être implémenté, quelles sont les possibilités, par exemple, pour le laboratoire, est-ce qu'il était possible de faire un test diagnostique, est-ce qu'il était possible de faire une glycémie? Et donc, tout ça a été adapté. Mais un des éléments importants était quand même le niveau des prestataires, parce qu'il fallait avoir un contenu que les prestataires pouvaient être capables d'utiliser avec beaucoup d'aisance, beaucoup de facilité. Et donc, dans le processus, souvent, on avait des experts qui étaient des infirmiers, notamment au Sénégal, et qui donnaient leur feedback par rapport à quel contenu était adapté au niveau primaire, quel contenu n'était pas adapté, quel contenu était trop compliqué pour le niveau qui était considéré. Et donc, ça nous a permis, comme vous le voyez ici, de passer de cet algorithme en papier, donc la version papier, vers cet algorithme électronique sur la tablette. Et bien sûr, ça a eu des implications dans la formation sur la PCME ou sur AMCI, avec une intégration qu'on a dû faire sur aussi bien le contenu, puisque le contenu des recommandations est extrêmement varié, mais également sur le modèle de formation, parce qu'il fallait non seulement former sur le contenu, mais également former sur l'utilisation de l'algorithme et l'utilisation de l'outil électronique. Alors, I don't know. So, just pour, I don't know where is the, okay. Now. Comment avancer le diapo? Alors, juste pour donner un exemple, est-ce qu'on peut démarrer la vidéo, please? Because je ne peux pas démarrer la vidéo. C'est juste pour donner un exemple de comment ça fonctionne, l'algorithme. You can click here. Alors, donc, vous avez très rapidement l'évaluation initiale ici. Alors, ça part très vite avec tous les éléments. Il y avait d'abord l'enregistrement, ensuite il y a l'évaluation initiale, les complaintes, tous ces signes qui étaient pris, les mesures, le poids, la taille, le périmètre brachial, le rapport poids sur taille, la température, la mesure de la SpO2. Ensuite, vous aviez, au niveau de l'examen, vous avez les signes de danger qui étaient évalués et à chaque fois, vous aviez un bouton information qui pouvait vous ramener aux informations qui sont utiles. Toujours dans cette consultation, vous avez, alors c'est très rapide, vous avez tout l'examen concernant tous les appareils, l'histoire médicale concernant les problèmes cardio-respiratoires, les problèmes de peau, digestifs, donc toujours cardio-respiratoire, cutané. Et puis ensuite, après la consultation, vous aviez la phase test, c'est très rapide. Cette phase test où vous aviez en principe, le principal test qui était possible de faire, c'était le test malaria. Et après le test, on passe à la partie diagnostic. Et cette partie diagnostic comprend également plusieurs parties. Donc, il s'agissait en fait d'abord de faire une proposition, c'est-à-dire que l'algorithme à la fin va proposer un certain nombre de diagnostics et le prestataire avait la possibilité d'accepter ou de rejeter ce diagnostic. Ce n'était pas imposé, mais c'était proposé. L'autre option également, c'est que s'il y a un diagnostic auquel pense le prestataire et qui n'est pas pris en compte, proposé par l'algorithme, le prestataire avait la possibilité d'ajouter un diagnostic, soit sur une liste déroulante, ou bien en inscrivant manuellement ce diagnostic. Et à la suite, on va aboutir à un diagnostic final, ou bien une association diagnostique. Et toujours dans cette partie diagnostique, you can go with the video, dans cette partie diagnostique, on peut avoir certaines informations sur le traitement, est-ce que tel traitement est disponible, sur les posologies, sur les antécédents, est-ce que l'enfant a pris de la vitamine récemment, est-ce que l'enfant a été vacciné complètement? Donc, toutes ces informations vont aboutir finalement à un résumé. Et ce résumé, c'est aussi bien une proposition d'ordonnance très, très détaillée. Je ne sais pas si je peux avoir, c'est statique. Une proposition d'ordonnance qui était assez détaillée, mais également des conseils sur la prise en charge, des conseils nutritionnels, etc. Et des conseils sur le rendez-vous. Voilà. Ok, là, j'ai le bon sens. Et donc, au moment de drafter, voilà ce que nous avions un peu sur cette version Excel. On a fait beaucoup de va-et-vient avec SUS-TPH, avec le ministère. Est-ce qu'on garde tel diagnostic? Est-ce qu'on retire tel diagnostic? Si on garde tel diagnostic, quels sont les critères diagnostiques qu'on va retenir pour dire, par exemple, que c'est une maladie fébrile très grave? Quels sont les critères pour définir cette maladie fébrile très grave? Donc, les critères diagnostiques. Ensuite, les options thérapeutiques qui pouvaient être retenues en fonction du contexte, en fonction de la disponibilité des médicaments, la décision de référence ou pas, voilà, et la classification. Bien sûr, on avait une façon de classifier les diagnostics en fonction du tableau clinique. Ah, donc, finalement, on a cet algorithme qui est l'IPORT, qui prend en compte toutes les étapes diagnostiques. Donc, depuis l'enregistrement jusqu'à la recherche de signes de danger, les mesures de base. Vous avez également, bon, il faut que vous avez les mesures de base, les mesures de consultation. Donc, à la suite de cette première phase, Un peu difficile de naviguer entre les deux. Donc, voilà un peu les étapes du diagnostic depuis l'enregistrement. Alors, dès qu'on reçoit l'enfant, on a la possibilité, s'il a une maladie très grave ou bien une urgence vitale, d'aller directement vers la prise en charge avec l'algorithme qui proposait vraiment une documentation sur la façon de prendre en charge. Par exemple, si l'enfant vient dans un coma profond, il était possible d'aller voir comment profond et d'avoir des indications sur la prise en charge. C'est une fois que cette urgence vitale est prise en charge qu'on pouvait aller sur le cours de la consultation, depuis l'enregistrement avec les données de l'état civil, les signes d'urgence qui vont ramener également à la prise en charge en urgence, les mesures de base, poids, taille, température, SpO2, c'est ici qu'on les faisait, pas ici, mais en fonction des signes cliniques, et la sélection du motif de consultation qui va nous amener dans un des groupes de consultation, dans un des groupes de motifs de consultation, et ensuite on pouvait, en fonction du motif de consultation, continuer la consultation avec l'anamnèse spécifique, l'examen clinique, les examens complémentaires pour aboutir à une classification en rouge. What did I do? It's not me. Ah, ok, d'accord. Et donc, on avait cette classification comme dans la PCME, rouge, jaune et vert, qui permettait de donner une idée sur la prise en charge, est-ce qu'il fallait référer, quand il fallait revenir, le détail sur la prise en charge, le traitement avant référence ou le traitement lorsque l'enfant n'était pas référé. Alors, ce qu'il faut dire, c'est que en Inde, le CDSA n'a pas été utilisé pour plusieurs raisons, parce qu'on s'est rendu compte lors de l'étude pilote que il y avait très peu d'adhésion à l'utilisation du pool oxymètre, un taux d'adhésion qui était entre 6 et 8, entre 38 et 14%. Et puis, en fonction des sites de prise en charge et en fonction des prestataires, on avait des taux d'utilisation qui étaient entre 25 et 50%. Donc, le projet, on s'est dit que dans ce contexte-là, c'est sûr que le CDSA n'allait pas être utilisé. Donc, en Inde, donc, il n'y a pas eu d'utilisation, d'implémentation de ce CDSA lors du RCT. Alors, sur le plan qualitatif, les gens pensaient que c'était vraiment précis, avec une bonne interface, et que ça améliorait la précision. Mais le principal problème en Inde, c'était le temps que ça allait prendre et puis les problèmes techniques que pouvait induire l'utilisation de ce CDSA. Et puis, parfois, les données sur les médicaments, sur les traitements, ne collaient pas avec ce qui existait réellement sur le terrain. Alors, qu'en est-il du taux d'adhésion? Alors, comme Léa l'a expliqué, dans l'étude, on a fait ce qu'on appelle une service provision assessment. Il s'agit ici pour l'assistant de recherche de venir observer la consultation du prestataire. Et donc, lorsqu'on voit les résultats du SPA, il y avait une bonne adhésion, un bon degré d'utilisation du CDSA, aussi bien au Kenya qu'au Sénégal, avec une moins bonne adhésion en Tanzanie. En Tanzanie, principalement parce qu'il y avait souvent le CDSA qui n'était pas présent dans la salle de consultation. C'est-à-dire que le prestataire, au cours de sa consultation, assez souvent, n'avait pas le CDSA présent. Donc, ce qui fait que le taux d'utilisation et le taux d'adhésion étaient retrouvés faibles. Et donc, on peut voir ici qu'en fonction des pays, par exemple au Kenya, qu'en fonction des facilities et des semaines, qu'il y avait une variabilité en termes d'utilisation. Cette diapositive montre que, en fait, l'adhésion ou l'utilisation dépend essentiellement du prestataire, parce qu'on voit que dans un même pays, certains prestataires vont l'utiliser beaucoup plus souvent que d'autres prestataires, avec un niveau d'utilisation qui va rester constant. Bon, le niveau d'adhésion ou d'adhérence, je ne sais pas quel est le bon terme, en tout cas, le niveau d'adhérence au Sénégal a été beaucoup perturbés par l'existence de cette grève. Et donc, vous voyez que ici au Sénégal, les zones où il y a du vide correspondent en fait à des périodes où les prestataires étaient en grève. Donc, dans certains postes de santé, lorsqu'il y avait la grève, les prestataires mettaient de côté tous les outils, que ce soit l'outil électronique, le CDSA, ou alors l'oxymètre de pouls. Et donc, en Tanzanie, on voit qu'également, il y avait un taux d'utilisation qui était assez constant, mais qui était plus faible que dans les autres pays, en tout cas notamment plus faible qu'au Kenya. Alors, quelles sont les principales raisons de... yes, was not... donc, ça, ce sont les données de la consultation au Sénégal où on voyait qu'il y avait des zones où il y avait très peu d'utilisation, voire pas d'utilisation du tout. Et comme je l'ai dit tantôt, c'était lié à l'impact de la grève des prestataires, qui était une grève assez féroce, où ils refusaient totalement d'utiliser les outils. Et qu'au Kenya, en Tanzanie également, il y avait une faible utilisation, mais qui était assez constante dans le temps. Alors, quels sont les principaux symptômes recueillis, en tout cas les principaux motifs de consultation durant la consultation avec le CDSA? On voit que, comme classiquement, la toux et la fièvre restent les symptômes dominants. Mais puisqu'on a rajouté de nombreux diagnostics, on voit que d'autres ont également une prévalence qui est assez importante, notamment les problèmes cutanés, qui peuvent aller jusqu'à 15% des consultations, les problèmes gastro-intestinaux en fonction des pays, la diarrhée, par exemple, qui peut représenter jusqu'à un quart des consultations, notamment en Tanzanie. Également les problèmes abdominaux, souvent des urgences chirurgicales, en tout cas des problèmes digestifs ou abdominaux, qui peuvent être retrouvés à peu près dans 10% des cas. Au Sénégal en particulier, on a eu beaucoup de cas disons, de problèmes ORL, jusqu'à 10%, qui pourraient être classés également dans les problèmes respiratoires. Alors, l'autre élément qui était important à savoir, c'est quel est le temps pour utiliser ces outils. Donc, là, on a des données du time flow qui a été réalisé dans les 3 pays. Donc, on voit que globalement, quand on voit les résultats du Kenya et de la Tanzanie, de base, la consultation durait déjà très peu de temps. Et que l'introduction du CDSA et l'introduction du CDSA plus oxymètre de pouls, plus on a d'outils, plus le temps de la consultation va s'allonger. Et on se retrouve avec le CDSA à des temps au Kenya qui vont jusqu'à 7 minutes, CDSA plus pulse oxymètre jusqu'à 9 minutes. Pour le Sénégal, ça partait de 8 minutes de base vers 13 jusqu'à 21 minutes la consultation. Alors que pour la Tanzanie, on est à peu près entre 4 minutes de base, 9 minutes avec le CDSA et 14 minutes avec les 2 outils. Alors, ce qui veut dire que le problème du temps de la consultation est un problème essentiel lorsqu'on va vouloir passer à l'échelle l'utilisation de ces outils. La particularité au Sénégal, c'est que très souvent, on avait des postes de santé où le taux de fréquentation était plutôt faible, où le prestataire avait le temps de faire sa consultation, ou même on a des postes où il y a 2 prestataires, l'un ne s'occupe que des enfants de moins de 5 ans et avait plus le temps de faire cette consultation. Ce qui n'était pas forcément le cas peut-être dans les autres pays. En tout cas, en Inde, on s'était rendu compte que c'était absolument impossible d'avoir autant de temps pour la consultation. Donc, ça, c'est un élément qui était très important à prendre en compte. Alors, l'autre élément, c'était l'apport des outils dans le respect des recommandations de la PCME. Parce que l'un des éléments importants qui ont conduit d'ailleurs à la mise en œuvre du projet, c'est que les recommandations de la PCME, de TIMCI, n'étaient pas bien suivies par les prestataires. Et quand on voit les résultats, on voit que l'adhérence à la PCME était déjà faible de base au Kenya et en Tanzanie, Alors qu'au Sénégal, déjà de base, on avait un taux d'adhérence qui était très élevé. Même si certaines mesures n'ont pas pu être prises en compte parce que les mesures ont été faites lors du triage, alors que la SPA se fait pendant la consultation. Et donc, avec l'introduction des outils, on voit qu'il y a au Sénégal, donc, puisque le taux était déjà élevé, il n'y a pas eu d'amélioration de l'adhérence, et que dans les autres pays, on a eu une légère amélioration, mais on pourrait faire mieux. C'est-à-dire qu'on passe le taux d'amélioration de l'adhésion ou de l'adhérence à MCI a été très faible, même s'il y a une légère augmentation. Donc, le contexte qu'on ne pouvait pas savoir avec la grève, quel est l'impact de l'outil sur le respect des recommandations de la PCMO. Alors donc, il reste vraiment de la marge pour améliorer le respect des recommandations au cours de la consultation PCMO. Alors, dans le SPA, à certains moments où un caregiver était interrogé, ce qu'on appelle exit interview, voir quel était le ressenti par rapport à la consultation. Et donc, globalement, les accompagnants ou les caregivers ont une expérience qui était positive de l'utilisation du CDSA par les prestataires, avec même une amélioration du Kenya et de la Tanzanie. Globalement, il y avait une bonne perception sur la qualité des soins, notamment lorsqu'on utilise le pulse oxymètre et le CDSA. La conception étant que l'adjonction de ces outils ne pouvait que améliorer la qualité de la prise en charge. Yves, les données qualitatives, c'était, comme je viens de le dire, une impression vraiment pour les prestataires ou pour les familles et pour les prestataires qui avaient une amélioration de la qualité des soins, que pour même certains, ça leur a permis de réactiver leur connaissance, de mettre à jour leur connaissance puisque le contenu clinique a été mis à jour. Mais le principal problème, le principal challenge a été le temps, parce que ce qu'on n'a pas dit, c'est que le temps, c'est pour l'utiliser, le CDSA, mais en même temps, le prestataire devait faire le recueil des données classiques sur le registre. Donc, c'était un double travail. Et il y a un peu, peut-être, du temps à gagner lorsqu'on va passer à la version électronique paperless. Peut-être qu'on peut encore gagner un peu de temps. Alors, in English. So for the CDSA, apart from also helping you come up with an accurate diagnostic and management, there is a part of learning. Yes, because you select the complaint, it directs you on the next step. So then at the end, you get to learn how to manage the condition. Plus, there is a reduction of overprescription of, I would say, the antibiotics. C'est un prestataire qui dit ça. Ça permet vraiment d'orienter, de guider la consultation. Ça permet d'aider pour le diagnostic. Ça permet également de restreindre les prescriptions et d'éviter la surprescription, notamment la surprescription d'antibiotiques. Du point de vue de notre prestataire, qui est plutôt négatif, le book has become slower, especially as I'm the only one doing the consultation. Vraiment, I do everything myself. When I have a patient, I take their height, weight, and temperature. On top of that, I make the recordings on the tablet and then on the register. Donc, le double travail. What's more, we sometimes hear some carers complaining outside saying, this one's too slow. Yes. Donc, c'est vraiment les ressentis négatifs de certains prestataires. Alors que du point de vue des caregivers, plutôt positif, I have to admit that they know that they are doing, that what they are doing, it's not the health facility that's closest to me because I travel by car to get there, but I trust what I do. Ah, yes. I have to admit that they know what they are doing. It's not the health facility that's closest to me because I travel by car to get there, but I trust what they do. That's why I always go there. They have quality tools and care. Et donc ça, nous, on l'a perçu, hein, il y a des parents qui se passaient le mot en disant, dans tel poste de santé, ils ont de nouveaux outils, il faut y aller puisque la consultation va être de meilleure qualité. Donc voilà un peu. Donc pour résumer, on peut dire que dans le contexte de cette étude, et selon nos données, le CDSA reste quelque chose de très acceptable, d'envisageable, et qu'il y avait une perception d'une amélioration de la qualité des soins, aussi bien du côté des prestataires que du côté des populations, mais que le principal problème reste la barrière du temps que prend cette consultation, étant entendu que dans le projet, le prestataire, je le répète, a utilisé aussi bien la version papier que la version électronique, ce qui faisait un double travail. But time pre-post control time, c'est ça, c'est ce que je viens de dire. Il y a une faible adhérence aux indications, aux recommandations de la PCME, de AMCI, aussi bien advised land dans les groupes contrôle. Mais ce qu'il faut dire que ça, c'est un problème de formation, de suivi et de supervision. Et que ce n'est pas forcément le projet qui allait régler ça, mais il fallait vraiment qu'on insiste sur la supervision, sur le fait que les prestataires puissent respecter les conditions, en tout cas les recommandations de AMCI. Donc, il y a une perception de l'amélioration de la qualité de soins pour les prestataires, mais également pour les caregivers. Et qu'il y a une amélioration modeste des indicateurs et qu'on a encore de la place et de l'opportunité pour améliorer un peu le niveau d'adhérence, le niveau d'adhésion des prestataires. Et ça, comme je l'ai dit, au-delà du projet, ça fait appel à tout le système de santé, tout le système de formation, de suivi et de supervision de nos prestataires au niveau des sites de prise en charge. Donc, voilà ce que je voulais partager avec vous sur le CDSA, donc l'algorithme électronique. Et donc, je voudrais à présent appeler Andolo et Olga here pour un peu le panel, les discussions, et nous sommes ouverts à vous. Ok, le programme va changer. Andolo. Ah, you're here. So, je peux avoir un big, voilà. Merci. Donc, merci. Je pense que vous avez tous peut-être une expérience, notamment avec les autres projets, de l'utilisation de la tablette lors de la consultation. Vous avez également une expérience du contenu clinique dans ces outils, parce que comme vous le savez, comme vous l'avez vu ici, dans TIMCI, on a fait le choix de mettre un contenu clinique très renforcé qui va au-delà des diagnostics habituels. Peut-être que dans d'autres contextes, dans d'autres projets, on a eu à utiliser des algorithmes simplifiés et peut-être que vous avez une expérience par rapport à ça. Donc, nous sommes ouverts à des questions ou à d'autres commentaires. I should need to translate. Do you have any question?
Good morning. Je vais parler en français également. Moi, c'est Dr Pape Biran Bouch. Je suis pédiatre, chef de division survie de l'enfant au ministère de la Santé du Sénégal. Alors, j'ai eu la chance de participer à ce projet, pas en tant qu'agent du ministère de la Santé, mais en tant que pédiatre au niveau opérationnel, donc au niveau des hôpitaux. Ça a été vraiment une expérience très, très enrichissante parce qu'au début, c'était une formation sur l'oxygénothérapie, sur l'utilisation de l'oxymètre de pouls. Ensuite, c'était participer aux ateliers d'adaptation du CDSA en fonction du contexte du Sénégal. Donc, utiliser les documents de référence. En plus du guide des urgences pédiatriques et du livret PCME, nous avons également utilisé les documents, normes et protocoles du Sénégal parce qu'on les a élaborés. Et après cela, j'ai été affecté au ministère et en tant qu'agent du ministère de la Santé, j'ai participé à tout le processus du TIMCI, depuis les formations des formateurs, la supervision des agents, l'évaluation sur le terrain jusqu'à la dissémination. Donc, ça a été une expérience vraiment enrichissante. Et les points clés que nous avons notés, c'est surtout la réduction de façon drastique de la prescription abusive d'antibiotiques qu'on faisait dans nos pays, mais également l'importance du CDSA dans la pratique quotidienne des infirmiers, en tout cas des prestataires qui l'ont utilisé sur le terrain. C'est vrai que la grève nous a un peu handicapés dans la recherche, dans la mise en œuvre de cette stratégie, mais c'est une stratégie que nous allons continuer, que nous prévoyons même de mettre à l'échelle. Donc, on a commencé un travail de réflexion sur la mise à l'échelle de ce TIMCI. On avait commencé dans une région, mais on va passer pour les 5 prochaines années dans d'autres régions et peut-être plus tard sur toute l'étendue du territoire, en utilisant et l'oxymètre de pouls et le CDSA. Voilà, merci.
Merci beaucoup, Dr Biran, pour cette belle contribution. Effectivement, au Sénégal, il y a eu une étroite collaboration entre le ministère, l'université, la région médicale dans la mise en œuvre du projet. Effectivement, ils ont beaucoup participé à faciliter ce projet. Et effectivement, au Sénégal, peut-être qu'on est, on est très, je ne sais pas, en tout cas avec le ministère, comme il vient de le dire, il a été décidé d'étendre l'expérience dans d'autres régions médicales, puisque sur les effets bénéfiques par rapport à l'antibiothérapie, le ministère a été très, disons, enthousiaste pour renouveler l'expérience dans d'autres pays. Donc, peut-être qu'il y a d'autres questions ou sinon, est-ce qu'il y a d'autres questions? Peut-être il y a une question derrière auquel pourrait répondre Olga ou Andoulou. Ah, allez-y.
So, once again, my name is Tisum Vala from Malawi. So great work on the CTSA, and I think a couple of slides have shown that it does improve some adherence. But unless I missed it, you reported low IMCI adherence in 2 of the 3 countries, and now we're bringing an additional 2. Maybe to re-inquire, it was mentioned just briefly, how do we think, and we is anybody in the room, we can improve adherence to additional tools if the already existing IMCI has lower adherence? If we're getting a step further, the baseline was actually not optimal yet. How are we considering how to address that? Is it through further consultations? Is it through further research? Is it just monitoring and evaluation? How are we trying to think through if we're using an additional tool, if our baseline wasn't optimal in the first place? Thank you.
So, you want to respond?
Thank you so much.
So, you can present yourself.
Thank you much for the question. One of the things to start with is recognizing how we introduce new things in our facility. We start first of all by training one provider or a few, yet in a facility, you could have more people who are working. In this regard, when whoever you trained is not available, sometimes the tool may not be used. So one way of improving the use of introduction of these tools is to make sure that as many people as possible are conversant and are using the tool. Saying this, in Kenya, we recognized during the project implementation that there were days when the devices were not being used. So when we interrogated, we found those who we trained, when they were away, then the tool will be kept aside. We went back, did mentorship, sensitization, and that improved gradually the use of the tool. So involving more people in the use of the tool is one way that could improve uptake and adherence. The second part of it is actually providing, support in terms of continuous, monitoring and encouraging people. But there should be a different way of how to do it. And in Kenya, we did supportive supervision, monitoring, and evaluation using the existing structures, so that is not something that is added, it's something that is in the system as it always exists. So we used the supervisors who are linked to the facilities that we are using. We trained them as a TOT, and they were able to follow from time to time. The commitment by the leadership to show that this is something they want to happen in the facility, because we recognized when the county health management team came in and required facilities to use the tool, there was also improvement. Thank you. Hand over to Olga.
Okay, thank you. Just to add on that, I think another important aspect is ensuring that, just like Dr. said here, we have on-job training, because we know that most of our facilities, one challenge that we faced in Tanzania was that we had a lot of staff transitions. So you'd get staff who are trained, then within a short period of time, they are moved to a different facility, then new staff come in. So what we thought was the best way forward, and what we did, we ensured that those new staff who are coming in, they were properly trained. And during our supportive supervision, we would encourage them to train each other so that everybody in the facility has the knowledge. I might be on shift and maybe I've not been trained, so I won't be able to use the tools. But if my colleague has oriented me and maybe do the supportive supervision, I've been oriented more. So OJT was also very important. I think another important thing to make sure that staff are using this tool is to ensure that most of our, for example, what we did in Tanzania, we had our HMIS, which is HMIS Book 5, for documenting the OPD consultation. So because this is a tool that is already existing in the facility, we didn't want to come up with something new. What we did is just adapted the available columns and ensure that pulse oximetry was part of the measurements that was being done. So in that way, we got people to make sure that it is taken, because they have to document it. And if it was not done, we would want to know why was it not done. Maybe I had a lot of staff, maybe a lot of patients, maybe, or the tool was not working on that day, the pulse oximeter was not working on that day. So we'd follow up and see on how we can build the capacity, or maybe support, maybe the battery was broken or the pulse oximeter was broken. So using the tools that are available to make sure that these important measurements are captured, it would also make people to use those tools. So that was...
Merci beaucoup, Olga. Effectivement, c'est très important, comme on l'a dit, au-delà de l'utilisation des outils, il est très important que le processus de formation, de suivi et de supervision soit les plus efficaces possibles. Parce que non seulement il fallait faire la formation en atelier, mais immédiatement après, en tout cas au Sénégal, il a fallu aller sur le terrain, appuyer les prestataires, faire un suivi post-formation pour améliorer un peu l'adhérence et l'utilisation de ces outils. Je voudrais également annoncer qu'en ligne, nous avons Fenella Bayonne et Gillian de Swiss TPH qui ont beaucoup contribué à l'élaboration de ce contenu, à la mise en œuvre du CDSA et qui pourraient également répondre à vos questions. S'il y en a d'autres, sinon on pourrait également leur donner la parole pour une éventuelle contribution. Ah, il y a une question. Ah, allez-y, monsieur. Vous pouvez vous présenter.
Okay, thank you so much. Can you hear me? Yeah, so because I speak for first time, I should introduce myself. My name is Richard Silumbe. I'm working from Clinton Health Access Initiative, Chai, Tanzania. So that's great work that I've seen from these interventions that PATH and allies are doing. And I'm so interested with this digitalizing the how we can support healthcare workers to provide accurate work. I have a few questions regarding this work, especially for CDSA. First, please correct me, maybe because of interpretations, maybe I missed it. You presented that in Tanzania, the CDSA uptake was not good because it was not in the consultation room. I heard that sentence from the interpreter. So I just want to understand what's happened that to make CDSA to be low in Tanzania, and that definition of not in the consultation room. Second, I was also interested to see whether this tool, and correct me if I missed it, it can be done, it can be functional even at offline, or it's only internet-based at all time. And the third one is just want to see how if we're about to scale up, how it can be scalable in Tanzania, because now we understand our focus as a country, particularly in Tanzania, is just to integrate all the systems, just to have like a one way, which can have visibility, ministry and stakeholders, they can have visibility on the existing systems. So how is it interoperable with existing systems so that we can have these informations easily with one credentials and we can access all the information as we are going to introduce these ones? Thank you.
Merci. Je voudrais peut-être, avant de donner la parole éventuellement à Olga ou à Dr Robert, juste préciser que ce que nous avons dit, c'est pas que le CDSA était mauvais en Tanzanie, c'est qu'on parle de taux d'adhésion, c'est-à-dire du pourcentage de consultations qui ont été faites avec le CDSA. Et que le constat a été que lors des SPA, c'est-à-dire lors de l'observation de la consultation, que plus souvent que dans les autres pays, la tablette qui permet d'utiliser le CDSA était moins présent, était plus souvent absent de la salle de consultation. Donc, vous comprenez que si la tablette n'est pas sur place, le prestataire ne peut pas l'utiliser. Maintenant, pour quelles raisons il y a eu cette moindre présence de l'outil en Tanzanie, ça, je ne pourrais pas répondre. Peut-être que Olga ou Dr Roberts pourraient aider également par rapport à la mise à l'échelle. C'est un outil qui ne nécessite pas d'avoir Internet au moment de la consultation. Simplement, les données sont stockées sur la tablette et elles sont synchronisées et envoyées vers le serveur central. Dès qu'il y a une connexion Internet, on peut synchroniser et envoyer les données. Donc, il y a un stockage au moment de la consultation, et donc on n'a pas besoin d'être connecté, d'avoir une connexion Internet pour pouvoir l'utiliser, mais les données sont stockées et synchronisées une fois que la connexion est établie. Donc, maybe Olga ou Robert can, or Dr. Andolo. Okay.
CDSA consultation room for them to use. So in the case of Tanzania, when the research assistants during service provision assessment sat in the consultation room, they didn't see the provider use it. But again, the CDSA, which may not have been mentioned, was also available in the room in some instance, but it was not actually also being used both in Kenya, Senegal, and Tanzania. An aspect of attitude is something else that we also need to focus in. So it is availability and good to use and people willing to use it. So that's the context in which we defined it. The second is, as you mentioned, offline, it can be used offline, and you only need online when you are synchronizing information. The aspect we are talking about interoperability, if the systems now are in place. In terms of just to talk about scale up, not which was also in Tanzania, but which also affects other countries that were involved in this project. One of the things I think, I don't know how other countries are operating, in terms of digital tools for consultations, they have not been widely used compared to tools for financial, collection of financial, and even for mere information collection. So this is also something that, for example, in Kenya is something we are now introducing in improving quality of service assessment. So what the project has done is to also generate lessons that people can use to introduce these tools in terms of service assessment and improving quality. But to speak to what Kenya intends is that we now have digital health platform, which is piloting how digital tools can be used to improve service provision. And there would be tools probably on maternal immunization, which will be housed in the ministry. And you'll have a one-stop where you can upload several modules, which you can then use and do assessment. So that is also under pilot. And the issue you spoke to about interoperability is one of the issues we also faced in the project, because providers had actually to use the tool and also to do manual things to transmit information the way they usually do. So those are being explored in the digital health platform to see how interoperability and various tools where we have a one-stop shop and where the continuity of using tools, because there's also a challenge. You use it on a sick child. In lower facility, you're the same one who is also seeing an adult, so you switch to, manual. And that is what is happening. Over to Volkan.
Okay, thank you. I think for the question of low uptake, some of the points have been mentioned, but I think interoperability again also is one of the reasons. Because just giving an example, you come to a facility, we are already understaffed, as we know, and this provider has a lot of children he's seeing. He also has to see adults. And then at the same time, they also have a lot of register. You have to register that patient. You have to use the HMIS Book 5. Then you have to also enter the data into the CDSA. And at the same time, you also have to write prescriptions. So that could be one of the reasons, again, why there was maybe low uptake, because people felt, and we've also seen in the results, that it was a lot, some of them felt that it was a lot of work for them. And maybe the best way forward is in the issue of scale up, like you've said, just the issue of interoperability, because we have the facility people and they're having a lot of systems to use at the same time. So people have to jump into different systems. But if all this was brought together and all there was interoperability and it was just one tool for the providers to use, I think the adherence would be much higher.
Merci beaucoup. Nous allons prendre peut-être 2 autres questions avant le déjeuner. Tout le monde. So, allez-y, vous avez le micro. peut-être que Fenella ou Gillian, s'ils veulent peut-être intervenir, on peut leur laisser un peu de temps, éventuellement, s'ils sont en ligne, si elles sont en ligne. Allez-y.
Elisandre de la Côte d'Ivoire. Merci au professeur Faye pour sa brillante présentation. Je voudrais revenir sur l'aspect de la contrainte du temps concernant l'utilisation du CSDI. Je crois que le temps, l'aspect du temps est très important dans nos hôpitaux. Et je crois qu'au cours de votre présentation et même des présentations précédentes, en Inde et en Tanzanie, pour 172 sites, il y a eu 157 667 enfants qui ont bénéficié du projet. Au Kenya, au Sénégal, pour 39 sites, 50 580 enfants qui en ont bénéficié. Je voudrais savoir, est-ce que le temps a été un inconvénient dans la mise en œuvre du projet par rapport à l'utilisation de l'outil? Et si oui, je me dis que durant 5 ans pour la mise en œuvre du projet, les 4 pays se sont certainement rencontrés pour faire un partage d'expérience. Est-ce que cet aspect-là a été évoqué pour voir comment il faut améliorer l'utilisation de l'outil?
Merci. Je pense que c'est une très bonne question. Je pense que le temps est un élément important à prendre en compte lorsqu'on va vouloir passer à l'échelle. Mais les expériences sont très différentes en fonction des pays. Si je prends l'exemple du Sénégal, comme je l'ai dit, nous avons suivi avec la mise en œuvre. D'abord, pour rectifier, quand on dit 50 000 qui ont été prises en compte dans le projet, c'est dans la recherche. Mais dans l'implémentation, c'est beaucoup plus que 50 000. Par exemple, au Sénégal, on avait 60 postes de santé qui faisaient l'implémentation et 20 qui faisaient la recherche. Et même dans les postes de recherche, il y a des enfants qui ont pu bénéficier des outils, mais qui n'ont pas été pris en compte dans la recherche. Donc, l'impact et le nombre d'enfants qui ont été pris en compte dans le projet est beaucoup plus que ce nombre-là. Ça, c'est les données des études pré-post et du RCT. Donc, je disais que le contexte est très différent en fonction des pays. On a suivi certains postes de santé au Sénégal où l'afflux de consultation n'est pas énorme, comme je l'ai dit, où le prestataire, dans les postes de santé, on a 2, voire 3 prestataires, où on peut même avoir un prestataire qui s'occupe de la consultation des enfants qui est plus ou moins un peu spécialisé dans la prise en charge de ces enfants. Dans ces postes de santé-là, on s'est rendu compte que c'est bien faisable et que même après le projet, les prestataires ont continué à l'utiliser systématiquement sans aucune autre contrainte autre que celle faite par le district dans le cadre du suivi-évaluation. Donc, dans ce contexte-là, c'est parfaitement possible, c'est parfaitement faisable et ça va être d'autant plus faisable si on arrive à enlever de ces tâches la version papier. Parce que dans le temps, comme je l'ai dit, il faut inclure non seulement l'utilisation de la tablette, comme on est dans un système où c'est la version papier qui reste la version officielle, il fallait en même temps remplir tout le registre des symptômes jusqu'au traitement. Et donc, il fallait remplir les deux fonctions. Donc, ça c'est des éléments qui peuvent permettre d'améliorer un peu le temps, mais dans notre contexte, c'est parfaitement possible, mais dans le contexte de l'Inde, par exemple, les autres vont compléter, les peut-être, on se rend compte que vu le flux de consultation, le nombre d'enfants qui sont vus, c'était absolument infaisable, ce qui a été montré par l'étude pilote que nous avons présentée tout à l'heure. Peut-être que Léa veut compléter par rapport à ce point.
Thank you very much, Prof. Faye. Maybe to add on your question, and I think this is indeed a very important observation, time was an issue. I think we need to ask ourselves 2 questions. One is, how could we potentially reduce time? And obviously, this should be done, or IMCI guidelines should be followed, and it takes time. So as we had been discussing before, one option could be, for example, to do triaging before the consultation, for example. So to save time of the healthcare provider who's then supposed to use the tool. So that's one way. I think the other way is we need to ask ourselves, all right, with such an intervention, we are adding a burden to a healthcare provider because the burden is it requires more time. How can we make their life easier to reduce this type of burden by maybe helping them with other tasks, such as avoiding double entry, for example? How can we reduce other pain points as part of their consultation they have in order to make this burden of additional time more acceptable? And this probably requires some behavior change interventions, but it also requires us to think through the context of the consultation. What do they all have to do? And maybe how can we reduce some of the other perceived burdens to make this burden more acceptable? I hope I could get my point right, but I think you can approach it from two angles, and it's something we certainly have to think about. And I hand over again to Prof. Fai.
Sorry, we have to.
Et donc, l'autre élément important, c'est également l'engagement du prestataire, parce que, et donc, en fonction des prestataires, on va avoir certains qui vont l'utiliser, d'autres moins. I don't know, we can have one more question?
No more questions, sorry.
No more questions. So just a few comments from...
Yeah.
Yeah, thank you so much. I think the issue of time comes up consistently. And I think, just to be frank, it's not only on IMCI. Anything you will add additionally to what our provider is already doing has a time element. But I think for a sick child or any patient consultation, we also need to ask ourselves, what is the minimum time a clinician can spend with a patient to give quality care? And if we say you are using more time, against what standards are we measuring? Because I think, just to be frank, what more time consumed here is measuring a process 1 minute against a process which you require maybe 5 minutes to have a proper consultation. If you want to use a minute in a process of medical, assessment, treatment, investigation, you would not even have asked question, Professor. So I think one message we need to get here is when we introduce anything to take time, but what is the minimum time a provider should spend with a client to provide quality assessment, treatment, and counseling? If we're talking about 5 to 3 minutes, we are not yet at it.
Okay, and maybe one more addition, or maybe 2 or 3 additions. I think the first thing is staff attitude. Because we also learned that there are people who, some people just don't want to do it. They don't have a reason, but they really just don't want. They have that fixed mindset that this takes a lot of time and all that. But the ones who manage to change their attitude, and later on they'll be like, oh, so this actually works and it doesn't take much time. And I think also practice. We also saw that people who use the CDC a lot, after time, they saw that it was not taking that long because they had internalized it and it was very easy. And another thing is feedback. We also realized that you'd tell people, give them all these nice things to use, but you don't give them feedback, how they're performing, or maybe what is the impact. So what we also did was that you were giving them feedback, visualizing the data that we collected over a period of time, and then they'd see that, okay, we've made an improvement, maybe this is where we're lagging behind. So giving them that feedback also helped to change their attitude, and they use the tools in the ones who really did well. Thank you.
Thank you. Je pense qu'on va s'en arrêter là. Et les autres questions, on va peut-être pouvoir en discuter en coulisses pendant le repas. Nous vous remercions vraiment de votre attention et de l'intérêt que vous avez porté à cette session, et bon appétit à tous.
Merci.
Je rends la parole à Angela.
Yes, thank you. Welcome back, everyone. I'm pleased to welcome you back from a very nice lunch. And I'm also very pleased to invite Dr. Grace Malu back to the podium. Our star.
Yes, that would be helpful. Thank you very much. And once again, good afternoon, everyone. Good afternoon. I think we are now, our stomachs are full. So I think the questions will also be enough because we have full stomachs. And so this afternoon, I will continue with the presentations, and now I'll take you through severe disease referral, as well as severe outcomes in the TIMCI project. Thank you. Thank you, Mike. And I am professional now with this. So severe disease classification in TIMCI based in IMCI classification for both young infants and older children. For young infants, the classification included possible serious bacteria infection or very severe disease, severe jaundice, severe dehydration, and low weight of age. For older children, 2 to 59 months, severe classification included very severe disease, severe pneumonia, severe febrile disease, severe complicated measles, as well as complicated severe acute malnutrition and anemia. So severe diagnosis in TIMCI and healthcare provider agreement, and this was based on CDSA. For those who are new to CDSA, CDSA was clinical decision support algorithm that was developed to be used within the TIMCI study that included the criteria from IMCI and other expanded criteria as we showed in the morning. So around quarter of young infants and 3 to 5% of 2 to 59 months children met criteria for severe diagnosis in CDSA. However, healthcare providers often disagreed with severe diagnosis more than non-severe diagnosis. And this table shows classification and agreement as based on CDSA. And as you can see in Kenya, it was 23.3. This was CDSA proposed that these children have severe diagnosis. And for HCP agreement was 74.4%, meaning out of 23%. And these were for 0 to 2 months children. For Senegal, it was 23.2, out of which 40% agreed, accepted that this was severe complication. And for Tanzania was 41%, and out of this 52% agreed. Similarly to what we can see from 2 to 59 months. And as we can see in Tanzania, it was 5.5% proposed by CDSA. And out of this 5%, 59% accepted that this was a severe diagnosis. So most frequent severe illness for young infants, it was PSPI. I think let me quickly go back so that you can grab this well. Possible severe bacterial infection. Thank you very much, doctor. That is a bit hard for someone, a layman like me who is not a medical doctor. So possible serious bacteria infection. Aha, we're back here. So for Kenya was 10%, Senegal 19.6%. Severe jaundice, Kenya 1.3, and Senegal it was 0.9, and Tanzania 0.6. And non-IMCI, severe abdominal pain, problem, severe eye infection, and severe skin infection. This was not calculated because it was not part of our calculations, and it was not part of what we wanted to explore in CDSA. For children, complicated sum, severe acute malnutrition, Kenya was 1.1%, Senegal 0.5%, and in Tanzania was 1.3%. For severe pneumonia, Kenya was 2.4%, and for Tanzania was 1.4%. Now let's go to urgent referrals. So for urgent referrals in randomized facilities in RCT and pre-post randomized in Kenya and in Tanzania and India, and pre-post in Kenya and Senegal. These events were too rare and lower than expected. And generally, there is no significant difference in urgent referrals. Urgent referrals were those referrals that were done within the 24 hours after, not 24 hours. If, yes, when a child is diagnosed, perhaps has hypoxemia, and then they require to be referred, these referrals were very, very low in the study, not only in Tanzania, but also in Kenya and Senegal. And there was no significant difference, as you can see in box plot here, but also as you can see in some percentages there. Like, for example, India, it was 1.9%, and these were only 30 children that had to be referred. And this was for the pox arm, and for the control arm, it was 0.4. Well, if you look at Senegal, it was 0.2 for the pox and CDSA arm, and it was for the control arm or the pre-post, it was 0.4. So the take-home message here is that there was no significant difference in referrals. Did I go back? Okay, I'm mastering this. Okay, so for referral among hypoxemic children, and here I want to acknowledge the question that was asked by the doctor from Uganda. What was the prevalence and if these children were referred? So here are the answers for this. For India, it was 0.7%, only 11 children out of 1,582 children. These were hypoxemic for those who were referred. So for 0.7%, it was 54.5% for 0.2 months of age. For countries like Senegal, if we look at it, we can see it was 1% hypoxemic, and then the referral was 55.6%. Literally, you can say that the referrals among hypoxemic was high, although hypoxemia was not detected as much as we wanted to, but these children were referred. As you can see in Tanzania, for 0 to 2 months, it was 0.5, 12 children, and out of these 12 children, 8 children were referred. So meaning those who were who had hypoxemia or who were hypoxemic, I'm sorry I mixed between the two wordings, but I think you understand it, 67% was referred. Similarly to for 2 to 59 months, we can see out of 46 in Tanzania, 46 out of 93, 46 were referred, and this was 49.5%. So in TIMCI, we assessed outcomes beyond the primary care in TIMCI, and this, as we said in the morning, it was done in all RCT and pre-post, and we did this by phone follow-ups. Dr. Yasir asked in the morning what were asked during these phone calls, and these are the answers, as I said in the morning. So the phone calls were done repetitively. So they were calling the healthcare, the research assistant was calling the caregiver more than once during times of the day. So in order to be able to find the caregiver if the first attempt was not possible. In Tanzania, as I said, we had an alternative mechanism if no phone call was, if the caregiver did not have any phone. We used community healthcare workers who now visited these visited the houses and then gave the phones to the mothers, and then we were able to speak with the mothers with this way. But also we had research assistants who went to these homes and did a physical follow-up. For those hospitalized, we attempted to obtain further detail on admission and outcomes, and this was done during a service provision assessment, but also for every other child that was hospitalized, we followed them up to see where they ended. And here I must say, due to our health system, this was also challenging because you will follow a caregiver, you follow a caregiver today, they said she was admitted. Perhaps I have a child who was admitted. But literally, when you go to these hospitals, you don't find the records for this child. So it's something also that we have to work on because of our health system, also because of the type of the caregivers that were enrolled. So for qualitative assessing outcomes was through in-depth interviews with purposively selected caregivers within the range of caregivers that we had, and who had feedbacked to us what was the outcome of their children. So we talked about referrals, but now the completed referrals. And completed referrals were low among children referred. So the healthcare provider referred a child. The caregiver now had to take the child to the referral facility. This was very low, as you can see with the graph, but also as you can see with the plots. And overall, there was no significance in these referrals. So meaning there were the number was too low for those who were referred. And several factors play here, including the ones that we got from the healthcare provider saying, sometimes I don't refer the patient because I look at the caregiver and the caregiver is not even well enough to go to the next facility. So what I have to do is to just write some drugs and perhaps send them home. So the referral was also based on several kind of things. Even for those who were referred, the caregivers told us the decision for me to take my child to the next facility does not only depend on me. It also depends from my husband. My husband has to say yes. Sometimes even the in-laws have to say yes, you can go to these referral facilities or you cannot go. So the decision for referral and the outcome for referral has a lot of things involved. A lot of factors plays in, and it's not only because of this particular study. Let's go to primary hospitalization. Afterwards, you'll have to clap for me because I've mastered using this. So within 24 hours and with referral on day 0, this was what we refer to as primary hospitalization. And here also events were too rare than expected, and there was no difference between pulse and pulse oximeter and CDSA with control facilities, but also in pre-intervention for those who did pre and post-intervention. And as you can see, we could not even get risk differences because these events were too rare. You can see we have not estimatable, because these events were too rare for not only 0 to 2 months, but also 2 to 59 months. Severe complication by day 7. For severe complication here, we have death, hospitalization without referral, hospitalization with referral, but less than 24 hours after, not less, after 24 hours after day 0. And here also, events were too low and very rare than expected, 0 to 3 or 0 to 7% in control arm. And our assumption should be 1.1. But this assumption was not met. But slightly higher risk of severe complication, even in POX and CDSA arms in India and Tanzania as compared to that in control arms. And this is science. We have to have a lot of answers for this, why there was this kind of results in our intervention arms and not in the control arm. But no difference across period in Kenya as well as in Senegal. Severe complication by day 7, hospitalization without referral followed by death contributed most to the events and trend intervention arms. We also did sensitivity analysis to evaluate different definitions of delayed hospitalization from day 7, from same day to day 7, and there was no any substantial modification on these findings. But also additional analysis that we did suggested that more unreferred children attend hospital than referred children, but also trends towards higher hospital admission for those with referrals. These were additional analysis that we did and suggested that. And now let's look at severe complication by SPO2 group. And severe complication, as we could also tell, was generally higher among hypoxemic children. And as you can see, we have intervention control arm, we have intervention arm, POX and CDSA arm. And I think these are two somehow small, you cannot see, but the general take-home message here is that among those who were hypoxemic, severe complication was high for those who were hypoxemic, and this was expected because even medically, right? Daktari, thank you very much. Okay, from the qualitative findings now, major challenge facing caregivers in decision-making, I think I also said arrows. For example, one of the caregivers in Tanzania said, he is the father of the child. He must therefore make decision that we should take him somewhere. I cannot do anything without him making the decision because I am beneath him. This was a caregiver in Tanzania. But also in Kenya, one of the caregivers said, I wanted to send him to the referral facility, but the problem is money. So it's not only the decision-making, but also the resources to go to the next level of facility, which contributed. And as I've said earlier, referral contribution for lower referral rates was not only because of the healthcare provider, but also what was happening at home and things like that. The other quote from Tanzania, again, they say, her grandmother and her sister older have gone through a lot and they have already given birth. I mean, they make decision like advising me that this child needs to be taken to the hospital. So you might find that a healthcare provider has referred the child to the next facility, but when you reach home, the grandmother says, this is just a normal kind of disease. You know, as in our settings like Tanzania, similarly to India and Senegal, the grandmother can say, okay, let's start using herbs, you know. You take a few ginger and all this and you say she will be fine. These are all part of what contributed to the referrals. Other reasons for referrals not to be as low as we've seen were because the healthcare providers felt capable to manage illness at the facility, but also perception of illness that was not severe, as you can see with this post. Sometimes the ECDSA, meaning CDSA, may suggest that you refer a child, even if you could manage them yourself. I think this also brings us back to where the healthcare providers did accept what was suggested and not accepted. So however it guides you to make referrals. Sometimes you may choose to ignore the CDSA decision and manage the child yourself if they don't show any danger signs, especially for children aged from 2 months to 59 months. So you can see the CDSA has suggested that this child should be referred, but because of what you clinical and medical people call clinical acumen, empirical diagnosis, perhaps, which is very much used in our settings, the healthcare providers did not refer the child. Like also this one, there was a day when a child came in, although CDSA indicated low oxygen, I decided not to refer the child because I observed that the child was breastfeeding well. So referral was not only because of what CDSA suggested, but also based on how the provider fell on that particular day. And these are the key takeaways, outcomes beyond the primary care. Are subject to many contextual challenges, as I've mentioned, in the health system and more broadly. We can not only look at these only facilities, but there are a lot of challenges that comes with it. Referral, completion, and hospitalization were very low, and these were influenced by prohibitive costs, as I've mentioned, logistics, autonomy, decision-making power, or quality of care at the hospital. Severe complications were rare, but slightly higher in intervention arm in RCT, perhaps because of increased detection of severe illness or because of challenges in capturing referral advice on day 0, resulting in possible misclassification of events. But we've also seen that severe complications were higher among hypoxemic children, and reinforce the importance of addressing wider health system and contextual issues, as one of the doctors said before, in order for us to be able to use these devices effectively. And for this, I thank you very much. I would now like to welcome Professor Moshiro, and I think Fen is also joining us online. She's already online. And now it is the best time to take questions. And please, you're welcome with your questions.
Any questions? I see Andolo has a question. Not a question.
Yes, you can have a seat, and thank you very much for those who provided seats for us. Please have a seat.
Yasser, you're going to kick us off here.
Thank you very much. Great presentation. You mentioned that the referral, the number is very small for and even those who refer, I don't know what is the meaning of complete referral. So please explain it, that one also. And the meaning of, like I see 50%, 54% in young infant, is it accepted referral or it's actually the health provider advice for referral? Right. So that's another thing. Thirdly, mortality among those who were hypoxemic, but they were not referred by the health worker, or they were referred but not reached the hospital, that completed referral. So do we have that data also? Thank you.
Thank you very much for your questions. I should start. Should we take any other questions before I respond? Or
go ahead and respond to that.
Okay, so I'll respond to the first question, then I'll pass to Dr. Moshiro and Profai for the next question. And if Fen is also online, I'll pass this to her. So for those who we say referred but did not, the referral was completed. As I said, we collected data by phone calls as well as physical follow-ups. So this was also one of the questions we asked. Did you receive any referral? Did the healthcare provider refer you to other facilities? And if the mother said yes, we continue asking, did you go to this facility? And they say, no, I did not go to this facility. Or yes, I went to this facility. So the referrals, and I must say, we only ended at the referrals from the healthcare providers. We did not follow these patients that were referred physically. We only did phone follow-up and physical follow-up. We didn't go to this facility to see if the caregiver who was referred came. This was only reported by the caregivers. So the completion of the referral was from the caregivers as we received the report from the caregiver. And as you can tell, a mother sometimes cannot even differentiate if referral means going to the next facility, or if she even understood the research assistant about referrals. I hope I've responded. Thank you very much.
Yes, just to add what Grace has said, so the referral was actually collected at 2 points. First was the exit interview after the consultation. So the research assistant would ask the caregiver, what have you been given or what have you been advised? So that is the first point. And then the second point is during the phone call. Now we have the information that this patient was referred. Then we would ask if they have completed that referral. And this is because in the primary healthcare, the health system in Tanzania, we do not transport patients, or we do not refer patients. The hospital does not report. So the patients have to complete referrals themselves. So when they leave the facility, you are not sure if they are actually going to the next facility or they are going back home. And that's why sometimes we refer it as, completed referral, accepted referral, because it is the caregivers themselves that make that decision. Are they going? They have been told to go, but, they have to make that decision themselves if they are going or they're not going. So likewise with the hypoxemia, it's the same thing. They've been detected with hypoxemia, and then they're asked to go to the next facility. And it's the same whether they might go or they might not actually complete that referral. We also tried to do what we call, or to trace those patients who were referred to the next facility. We contacted the facility that we knew they were acting as referral points. So we are doing something called hospitalization, where we were looking for patients if they did complete the referral, if at all they were hospitalized. And it was a bit challenging obtaining this information, but we do have information on hospitalizations as well. Yeah.
Yes. Juste un mot pour dire que effectivement l'un des objectifs primaires, c'était de capter cette information sur la référence. Mais il y a deux notions, c'est-à-dire que ce qui était important dans le cadre du projet, c'est de voir si l'utilisation des outils faisait que le prestataire allait faire plus de références. C'est la décision de référence. Maintenant, il y a une confusion entre cette décision de dire, du prestataire de dire « je te réfère dans une structure de niveau supérieur » et qui est différente de l'information, est-ce que finalement cette référence a abouti à une consultation à un niveau supérieur ou bien à une hospitalisation à un niveau supérieur. Là où il y a la confusion, c'est que certains prestataires peuvent avoir pris la décision selon les données de l'examen clinique, selon les données des diagnostics qui ont été confirmés, peuvent avoir pris la décision de référence, mais puisque pour des raisons logistiques, pour des raisons financières, pour des raisons de disponibilité de l'ambulance ou pour des raisons de décision par rapport au mari, cette référence finalement ne s'est pas faite et que probablement que tous ces cas-là ont été enregistrés comme des cas non référés, alors que ce qui était important, ce n'était pas que la référence soit effective au niveau du centre de référence, mais plutôt que c'est la décision. Est-ce que les outils, l'utilisation des outils pouvait amener le prestataire le jour J à mener, à prendre cette décision de référer plus que par rapport à la non-utilisation des outils. Et puis l'autre difficulté qu'on a eue, c'est que, comme ils l'ont dit, hein, le suivi des enfants référés à l'hôpital, est-ce qu'ils y ont été, et s'ils ont été, quelle a été l'évolution, tout ça a été très, très compliqué à suivre par téléphone et ça a été en tout cas une des difficultés, le recueil de toute cette information autour de la référence au cours de l'étude.
So before we move into the next question, Gillian from Swiss TPH also had a comment.
Thank you. I just wanted to clarify a couple of points. One being that the original referral decision was captured, as Dr. Mashiro and Grace mentioned, based on the report from the caregiver at the exit interview immediately following the consultation, but that also included whether a referral was documented in the registry at the facility, and either one was considered a referral. So whether it was documented in the registry or the caregiver reported that they had been referred, it was considered a recommended referral. That's separate, of course, from the acceptance of the referral, but either the report or the registry was used for that original referral classification. And then to Yasir's question about acceptance, that would be still from the denominator of all those who were referred based on the registry or the caregiver report. But ultimately, that may have underestimated some referrals that would have been given had caregivers or had providers not already known that it might not have been feasible for that referral to have been accepted. So, for example, in the clinical decision support algorithm arms and periods, there was a question for young infants about whether the referral was feasible or not feasible if it was indicated by the ECDSA. And it was between 30 and 60% for whom criteria was met for urgent referral that they determined that it was not feasible to implement that referral. So they may not have even decided at that point to refer regardless of the indication from the criteria. Thank you.
Thank you very much, Gillian. Yes. Before we go into questions in the room, there's a question online from someone called Boris. So it's two questions. Are there any free healthcare policies in the TIMCI countries? And the second question is, do you have data about oxygen therapy at hospital level stratified by SpO2 value? Same question about death.
Thank you very much. I will start with the second and then go to the first. So we don't have data for the hospitals and the SpO2 availability in these hospitals. This was beyond TIMCI, but this data could be perhaps obtained from DHSI2 in our health system. Perhaps we can obtain this data. But also there was a question on free medical care. This, I think, is context-based, and I'll speak for Tanzania, and then I'll pass it to Profai to talk about Senegal. And I think India also has different. So for under fives in Tanzania, they should be treated for free. However, the free has some question marks, as you know, as we all know. Yes, it is for free. The government pays for everything. But, you know, things like transport to this facility is not free. The caregiver has to take the child by themselves. But sometimes for even the free care delivery, sometimes the healthcare provider, these facilities don't have enough drugs. So the caregiver has also to go buy the drugs away from the hospital again. So yes, it is for free for under 5, but as you know, with a lot of other contextual challenges. And I'll pass this to Profai.
Alors, sur l'oxygénothérapie, comme on l'a dit, hein, on n'a pas pu recueillir vraiment cette information puisque les enfants, en tout cas, les enfants qui ont été hospitalisés pour lesquels on a pu retrouver le dossier, les informations sur l'hospitalisation, ils ont été pris en charge avec de l'oxygénothérapie en fonction de la SpO2 pour la majorité. Je n'ai pas le pourcentage en tête. Étant entendu que dans le projet, on avait identifié, donc PAF avait identifié des sites qui étaient des sites de référence et qu'il les avait un peu renforcés en termes de matériel, en tout cas de consommation pour l'oxygénation. Et donc, la plupart des enfants qui ont été référés pour lesquels on a pu retrouver les traces de cette hospitalisation ont pu être prises en charge. Mais il faut dire que les informations sur la prise en charge au niveau des centres de référence ont que tu as un peu répondu, c'était gratuit pour les enfants de 0 à 5 ans dans le cadre des soins de santé primaire au Sénégal et peut-être dans les autres pays également.
Thank you. Thank you very much. I think you had an additional.
Yeah, I had an addition just for the first question that you responded regarding information on oxygen availability and SpO2 use. So before we started the study, all the facilities that were deemed there will be like a referred facility, we made sure that they had oxygen. So these were health centers, all the health centers that were part of the study, they had oxygen. If there was no oxygen, then we made sure that that facility was capable of offering oxygen. But for the dispensaries in Tanzania, usually they may, or most of them, they do not have oxygen, but then they don't keep patients or very sick patients, they have to refer. So whether we have looked at oxygen availability and SpO2, that could be done probably in these health centers where oxygen was available, but we haven't done that yet. Yeah.
Thank you very much. We can take more questions, and I think we have a question here.
Yeah, and I'll just add, maybe our colleagues from Kenya and India could add in the chat if there's someone online about the free healthcare systems, or we can come back to that question.
Yes. Thank you.
Okay, Professor Garba.
Thank you for the presentation. Revisiting the referral again. I'm afraid, even though the last speaker online, your colleague wanted to actually, if you gave some more light, if you said that you limited the data collection of providers' referral to exit interview, probably that may have contributed to the very low referral rate. You know, we're talking about referral rate of 45.5 and 25, I guess, 0.7 or so among those with hypoxemia. And if you collected this data from exit interview, certainly it's going to actually report a very low value. I think the best source of is to see whether the documentation from the provider actually diagnosed this as hypoxemia or severe cases, and whether indeed the health worker has initiated a referral. That could have been more, because of course, having a referral of severe cases to really fall to lower than 40, even though 40 is a good number, among severe cases is a bit worrisome. Let's, again, 25.7 for those that are. Then the other thing I have is that the assumptions that we had initially, that this particular intervention is going to actually lead to complete referral, is very obvious. It was quite ambitious, because we realize that complete referral, as you do say, is really a complex process that involves so many things beyond just putting a gadget and, of course, thinking that gadgets will actually do that. But again, looking at the prevalence of hypoxemia, which continue to be low across all sites, I'm just having a rethink. Where are these severe children that are having severe cases? Where are they? Are they at home or are they somewhere? I mean, because it's obvious they are not at the primary health facility where we conducted this study. Is it that they are at home, or they are maybe from home they are going straight to secondary facility? This is something to really think about. And again, for investment purposes, are we deploying this tool at the right place? Or probably perhaps it can do better at secondary facilities. That's my thought, when I see this work. Thank you.
Good questions.
Thank you very much. Just to add regarding referral, I think our colleague Gillian from online, she said exactly what you were proposing, that, or what you're saying. We obtain referral information from exit interview and records of care from that particular facility, in addition to phone call follow-up. And then once we had that information, that patient was referred to the next level facility, would have that name of the facility that patient was referred to. And we made an attempt to trace that particular facility to see if that patient actually arrived in that particular facility. So quite a number of methods were used to trace the referrals. And I agree with you, the completion of referrals, it's very complex, and there are quite a lot of things that come there. But on the issue of prevalence of hypoxemia, and where are these
l'hypoxémie, ou alors où sont ces enfants qui sont très malades. Une chose que nous connaissons, par exemple, ici en Tanzanie, si vous avez un nouveau-né et qui est malade, le personnel soignant a tendance d'aller directement aux grands hôpitaux. C'est pour cela que le nombre des enfants dans notre étude est très inférieur. On peut avoir cette hypothèse que c'est la même chose pour les cas graves, parce que c'est un enfant qui est très jeune, donc il faut repenser encore une fois dans les endroits ruraux, c'est pas facile parce que ces grands hôpitaux sont souvent très loin. Ce qui cause c'est que vous
think
devez
that probably, we know in the primary health care, there are less patients who have severe disease, but depending on where you are, if they have access nearby to a hospital, then most likely that is what exactly they would do.
Thank you very much, Dr. Mushiro. I think we have a question at the back.
And you? First, Freddie, then you.
Thank you very much for sharing very exciting findings from your study. I think I agree with the previous speaker about the numbers of hypoxemic patients being quite low. I still think that pulse oximetry is needed at that level so that you're able to identify those who might actually be hypoxemic. My three questions. The first one regards severe disease. You had a slide that presented a comparison between severe disease as identified by the clinical decision support algorithm and healthcare professionals. What I didn't understand is what was the motivation of that comparison? Were you trying to see whether the two agree with each other or not? And in that case, I would have loved to see the analysis where the denominator is the same, that the healthcare practitioners reviewed the same patients. So the slide you showed only focused on those that the clinical decision support algorithm had diagnosed. So the health, basically there was a bit of selection bias, but I don't know if, yeah, I see you're nodding. I think you get the slide I'm referring to. The second question is on hypoxemia versus the other issues that the patients might have had. How did the study basically integrate all the other issues that these children typically present with? For instance, if the patient was hypoxemic but had other call them conditions or other severe signs and symptoms, how did the study capture that? And also, until now, I've not understood whether the study participated in treating or in recommending treatment and how that affected the conduct of the study. So in a nutshell, how did the whole idea of screening for hypoxemia still look at the patient as a whole, the child who comes sick and they need treatment, whether it's hypoxemia or not? And with regard to that, there was another slide where you mentioned unreferred patients versus referred patients. Yeah, I didn't get the other part. If completed hospitalization, I didn't understand that statement. Unreferred patients were better at completing hospitalization than referred patients. If you can elaborate, it was on one of the slides and it wasn't clear. And then as far as severe, because I see that the numbers of severe disease are higher than the numbers that were referred. So who was referred? How did the health workers decide who should be referred? Was it based on what the facility can do, or was it based on other reasons? Otherwise, thank you very much for this study.
Thank you very much. Thank you very much. I think we should take that and then we can move to other questions. If you, okay, we can, Mike, I think we can
We'll
take the.
Go ahead and answer that. And then Ambrose had a question.
Okay.
And then over
Okay,
here.
so Julian, I think, is online and she would like to respond to the first question and then we will add on. Julian, if you can hear us.
Thank you, Grace. Yes, so to clarify that slide that showed the severe disease classification based on the clinical decision support algorithm, the second part of that was not compared to a physician, that was compared to whether or not the healthcare provider decided to refer that child or not, or accepted that classification. So the severe disease classification was based on the criteria within the guidelines for each country, translated into the clinical decision support algorithm that included the IMCI classifications for severe disease, but it also included hypoxemia in either age group, and it included other severe disease classifications aligned with the guidelines in each individual country. So it was both based on IMCI severe disease, hypoxemia, or another severe disease based on the country's national guidelines. That first column on the left-hand side was, were they classified as having severe disease, just based on what criteria they met within the clinical decision support tool. That second column, there was a question within the clinical decision support tool that allowed the healthcare provider to say whether or not they agreed with the classification that was found based on criteria they had entered. So a healthcare provider still always had the decision to accept what the clinical decision support tool proposed to them, to add a different classification or to change the classification in order to give them the autonomy as they're providing healthcare worker. And so that right-hand column was how often they agreed with that classification, not compared to any sort of outside consultant or physician who was observing the consultation. We didn't conduct that in the study. So that's to clarify that. And then let's see. In terms of the slide that you were asking about for clarity on the unreferred versus referred and completed or not completed. So amongst children who were ultimately referred at that first consultation, the caregiver could decide that they would consult and follow through on that referral, or they could decide not to follow through on the referral. If they completed it within 24 hours, then we considered that it was or the same day, we decided that it was a completed referral. If, however, they didn't seek care within that first day, and then later they sought care, that would have been considered an additional hospitalization, but without a referral, because it was outside of the window of that first original referral. For those who were not referred, so the healthcare provider did not at that enrollment consultation refer them, the caregiver still might have decided that they thought the child required additional services, and they can still choose to seek additional care at a hospital or another clinic on their own without a referral. And what we found is that that was still quite common, that even those who were not referred sought care elsewhere, but that amongst those who had a referral from that primary consultation, they were more likely to ultimately be hospitalized at that follow-up care seeking visit than those who sought care and weren't referred, and ultimately were less likely to be hospitalized, which we think is some proxy indication of an appropriate referral. That was the rationale around using that criteria.
Moi, je voudrais juste, par rapport à ce point, encore une fois, l'objectif, c'était de voir si on pouvait avoir une augmentation du nombre du taux de référence. Simplement, ici, la référence, c'est une décision du prestataire. Alors, ce qui s'est passé, c'est que on a eu beaucoup par rapport à la classification habituelle spécimen, on a eu beaucoup de cas, plus de cas que d'habitude de formes graves, de maladies fébriles très graves ou d'hypoxémie. Et ce qu'on a constaté, c'est que pour ces formes graves, pour ces cas graves, le prestataire était moins souvent en accord par rapport au diagnostic. Et c'est pour cette raison que tous les cas d'hypoxémie et tous les cas de formes graves, selon le CDSA, notamment par le prestataire, puisque la décision lui revenait finalement. En d'autres termes, il y a eu des cas d'hypoxémie sur la base de la SPO2 que le prestataire n'a pas considéré comme étant suffisamment grave pour justifier la référence, puisqu'il avait la liberté de le faire. Donc, si on se mettait du point de vue juste de l'apport des outils sur ce qui ôte une décision de référence, on aurait pu avoir une augmentation de référence. Mais comme l'ont montré les résultats, beaucoup de prestataires ont gardé ce jugement clinique qui, selon eux, devant un cas qui était jugé probablement comme étant grave selon le CDSA, lui a jugé que la situation pouvait encore être gérée avec un traitement habituel à domicile. Ça, c'est pour une partie. Pour l'autre partie, c'est des cas qui auraient dû être référés, vu la situation clinique, mais pour des raisons de logistique, d'ambulance, de décision, du mari qui n'est pas là, de problèmes familiaux, n'ont pas pu vraiment être référés. Et donc, ce qu'on n'a pas comme vraie information, c'est que sont devenues ces formes supposées être graves et qui n'ont pas bénéficié d'une référence urgente pour être hospitalisées. Est-ce qu'il y a eu des cas de complications sévères lors de l'appel à J7? Cette information, peut-être qu'on ne l'a pas capturée à 100%, puisque l'objectif de l'appel à J7, c'était de voir que sont devenus normalement ces cas. Donc, globalement, on a eu beaucoup de problèmes sur la captation de cette information sur la référence, parce que, comme on l'a dit également, on était, par exemple, au Sénégal dans un contexte où il y avait la grève, où les services, les postes de santé étaient souvent non fonctionnels, ce qui fait que, en fait, les formes graves dans la phase post-intervention avaient tendance à aller directement à l'hôpital. Quand on a un nouveau-né qui a une détresse respiratoire et qu'on sait que dans le poste, il y a souvent un arrêt de travail ou en tout cas une grève, les gens vont faire le choix d'aller directement au centre de référence plutôt qu'au niveau du poste de santé. Tous ces éléments ont pu impacter un peu sur ce taux de référence qui n'était pas très élevé en post-intervention.
Thank you very much, Profile. We will take only one question and we'll be done with this session. If you have other questions, we can talk later.
Yeah,
One more question, please.
Prof. Ambrose.
Thank you, Grace and team. My question is regarding this observation of higher severe outcomes in the intervention arm. In the context of a trial, which this was, you're basically saying this intervention was harmful. And Grace, you raised some points around why this might not be the case. And I think it's useful for us to effectively, because it has implications on this entire meeting and discussions around scale up and so forth. I wonder whether you could also, because I could think of a few other possible explanations. Loss to follow-up. Could there have been differential loss to follow-up among those who were in the intervention arm who might have died? I know early on the figures suggested that follow-up was actually quite high, but if I recall, it was close to 10% for India and somewhere around 3% for Tanzania, the trial sites. These appear like low numbers, but for rare events such as the ones which we're reporting on here, severe outcomes, they could actually sway the results in one direction. You can imagine a patient who dies would be less likely to be reachable, or their caregiver would be less likely. It's a plausible explanation. The other thing is around baseline imbalances. For a cluster randomized trial, there could be a risk that those who were in the intervention arm might have been systematically different from those in the control arm. Was there an effort to examine those both at the cluster level, but the individuals who were enrolled as well? And then I have another point, but maybe if we
Thank you
just
very much.
perhaps comment on those first.
Yes,
Thank you.
Mike.
I'll just say something real quick. Prof. Ambrose, you get, is there a Kiswahili saying for the elephant in the room? Is there in English we call, because that's, I think, the elephant in the room. The adults, our hypothesis this morning that I mentioned was that we would identify and refer more children and we would reduce the severe complications. So we didn't do that. In fact, it went up even just slightly. So Prof. Ambrose, thank you for bringing that up. I think this is a good thing to discuss. And now, Grace.
Thank you very much, Prof. So I will respond to the first question that you said, perhaps the intervention brings both more harm because the intervention facilities, we see severe outcomes in intervention facilities as compared to the control facilities. First, I should say this was a pragmatic trial. For harm, we did not introduce anything apart from CDSA and pulse oximeters. So for harm, this might, in some way, we escape that. But also, I should say that findings from the qualitative interviews report that sometimes, you know, if you bring something new in these areas, even at home or somewhere, everyone wants to see the new thing. Everyone wants to go where there's a new thing. So there was a tendency of the pathway to care for some of the caregivers to change and visiting more the facilities that had interventions. Remember that you have CDSA and you have pulse oximeter. Even for like to check my child, he's seen by a tablet, not by only mere words. So probably we are assuming the severe cases seen in these intervention facilities was influenced by the pathway to care that has changed for some of the caregivers. We could not account for this quantitatively. These are only a bit of the qualitative interviews that were done. And you can imagine, as in Tanzania, we had 100,000 children and we ended doing 60 qualitative interviews. So this cannot be the final word, but this is one of the assumptions that we have. How their health-seeking behavior was more in the intervention facilities as you compare to the control facilities. There are so many other explanations for that. This is one of the explanations that we can now think of, and it is also by some of the courts in the interviews where the providers, the caregiver said, oh, they can go facility because now they have new, my child will be seen with a phone. You know, a tablet, they refer to phone. And then my child will also have an opportunity to be measured. Some measurements will be taken from the hand. This might be one of the explore. But apart from that, we did not explore any further to see why we only see severe children in the intervention facilities. But we are confident because this was a pragmatic trial, so we did not bring no harm in these facilities.
Yes, I mean, I agree with Mike saying that it's a very big elephant. So there could be so many explanations. And one of the things we also thinking, it could be that, for example, in the interventions facility, the children that were detected with severe disease, they only receive pre-referral treatment, for example, and then they were referred, but eventually they did not complete that referral. While in the control facilities, these children were treated completely and sent back home with a full course maybe of treatment. That is one possibility. We thought about it, but it's very difficult to prove it. But that's one of the things that, you know, came into our mind, like why would we have a poor outcome in intervention while the intervention that we were implementing was just CDSA and pulse oximetry.
Thank you very much. And I think this is the end of this session. If you have any further questions, we'll be sitting around and we'll be happy to take your question more. But with this, thank you very much.
Thank you very much to the panel. Okay, a reminder to please put any questions you have on the post-it stickers. I think there's one there that you should find on your tables, because there were many more questions and we only have one question at the back. So I'm sure there's a lot more, or one question there. So please put any questions, comments, thoughts on those post-it stickers, because we will look at them. So your view will be addressed. Okay, for the next session, which is on antibiotic stewardship and cost effectiveness, I'm pleased to welcome back Dr. Robert Mushiro, who's pediatrician and head of neonatal unit at Muhimbili National Hospital in Tanzania. And he's there. And also Susan Makawia, who's research scientist at Ifakara Health Institute in Tanzania. So Susan. Yeah. So Susan will address the second part on cost and cost effectiveness. So over to Dr. Robert Mushiro.
Thank you very much.
Do you prefer this?
No, this is fine. I think you can all hear me. The slides, can we have the slides? Okay, let me try this. How do I move forward? Ah, okay. And this is okay. Okay, thank you. So a little bit on antibiotic stewardship. As we know, CDSA was, we thought, or we wanted it to be part of a way of reducing prescription of antibiotics. And antibiotic stewardship is nothing but ways to measure and improve the use of antibiotics by both healthcare provider, but as well as caregivers. And in low middle income countries, it is estimated that children under 5 receive up to 25 courses of antibiotics during the first 5 years of their life. And we know that the use of antibiotics has a long-term consequences, including susceptibility to infections later in life, and immunological and metabolic complications. But also, we know that overuse of antibiotic contributes to antimicrobial resistance, to which more than 1 million deaths are attributed annually, and these 20% of these children are under 5. So how did we capture antibiotic data in this study? So in countries where they were implemented randomized control trial, and those with who were implementing pre-post studies, we captured this by research assistant documenting the prescriptions that the caregiver had at the time when they were exiting the health facilities, or capture the medication in hand that the caregivers obtained from these facilities. But we also had structured questions that were asked to the caregiver if they had received or not an antibiotic, and if they did receive, what type of antibiotics they were receiving. We also collected some photos, as you can see, of antibiotics that were actually prescribed, as well as free text that was entered into data collection tool, but that information was not included in analysis of what I'm going to present right now. So antibiotic prescription at day 0 in both RCT, and pre-post studies, there were no difference in antibiotic prescription in the pulse oximetry and CDSA arm versus control in Tanzania. So in Tanzania, both arms were the same. However, we saw a lower antibiotic prescription post-interventions in Kenya and Senegal. And this is breakdown of main antibiotics that were prescribed in both 4 countries. So we see the first line, amoxicillin is the most common antibiotic that is prescribed across all 4 countries. But we have cotrimoxazole, for example, in Kenya, as well as Tanzania. That is the second most prescribed antibiotics. Otherwise, drugs like metronidazole and erythromycin, we still see that are being used in these primary healthcare facilities. We also capture antibiotic data using the CDSA, and the CDSA, after the healthcare provider has used to enter clinical symptoms, it proposes medication based on the diagnosis that was suggested by the CDSA. And this diagnosis could even be added by the healthcare provider if he thinks the initial diagnosis that were proposed were not inadequate. And after, the CDSA will then indicate also the available medications. So the provider could actually agree or disagree or even add the medication that he or she thinks that the patient should be given. And this is what we see that the CDSA antibiotic recommendation was between 15 to 25% only of children that were attending the primary care level for those diagnoses that meted the criteria of requiring antibiotics. And this was later, for example, in Tanzania, healthcare providers added 15% of time, added more antibiotics. And for the studies, for the control, for example, pre-post and RCT, in Kenya, we had up to 83% of children being prescribed antibiotics before the intervention, 62% in Senegal, and in Tanzania, 67%. And this changed after the use of CDSA, where in Kenya, there was a reduction of antibiotic use of up to around 30%, reduction of around 20% in Senegal. And as I said earlier, in Tanzania, there was no change in antibiotic prescription in intervention studies, in the intervention sites. There was variation in Tanzania in terms of antibiotic prescription by region. And these are the 3 districts that the trial was conducted. And you can see that almost all the facility, almost all the providers were actually adding more antibiotics compared to what was actually suggested by the CDSA. So, however, there was a variation, and from 43% of some of the facility prescribed antibiotic only 43 times, up to 86%, some of the facility healthcare provider actually prescribed antibiotics. And during the qualitative data analysis, trying to analyze why there were antibiotic prescribed or what was the really reason for this, some of the provider provided some of the information that is quite interesting. So for example, one said, I can't lie, when a caregiver visits the facility, they want their children to be given a lot of medication. Not only children, even grown-ups, if you treat them and at the end you tell them to go drink plenty of water, they do not understand. They want to be given a lot of medicine, antibiotics, and injections. If you do that, they will come back to the same facility next time they are sick. But there were those providers who actually appreciated the intervention or appreciated how the CDSA helped them. And one said antibiotics like amoxicillin were previously used differently, but now with the guidelines, i.e. use of CDSA and the use of pulse oximeter, it has brought changes, ensuring that a child receives the appropriate dose. Another one say the use of antibiotics on children has reduced because most of the time when somebody comes with a fever, we would give them antibiotic, but now we have reduced giving children unnecessary medication. However, as I said, in Tanzania, we did not see this reduction, but we saw the reduction of antibiotic in Senegal and in Kenya. Another one said sometimes it occurs when you log into the tablet and look at the child's condition. Oh, sorry. And you look at the child condition, there's a difference. Some of us who have worked for a long time have experience with some things and say that I am adding this to the child. For example, in the case of medicine, you just can't leave the child. You will have to give her medication. So I think there were other providers who, felt that they could not let a sick child go home without medication or antibiotic, even though using IMCI algorithm, they were not supposed to prescribe antibiotic. Another one said, you find it, the CDSA tells you maybe just give Panadol, but the baby is warm. Even if you touch him, it's hot. Even you ask yourself, if I just give Panadol to this baby, I don't have tests to examine him here to know if it is bacterial infection or viral infection. I don't have. Now, if he has a bacterial infection, how will it be? Infants, as I said, their condition change rapidly. When he comes out of here and his condition changes so much at home, how will it be? So I think there were providers that were trying to reason, thinking also probably some of their patients came from far and they felt very unconfident not to prescribe something for them to go home with. So reflecting this, CDSA promotes adherence to assessment and management by guiding healthcare providers through consultation with child-specific recommendation. However, the ultimate decision by the healthcare provider whether or not to prescribe is very complex and is influenced by the provider, the patient herself or himself, contextual and other implementation factors. So the key takeaways from for the issue of antibiotic stewardship with CDSA: very high antibiotic prescription rates in all countries, higher among the age group 2 to 59 months than in young infants. The CDSA has demonstrated impact on reducing antibiotic prescription in Kenya and Senegal, but not in Tanzania. Some suggestion of improved appropriateness from a qualitative study, as I read here, and further quantitative analysis are underway to try to see if we can get more information from the data that we have. But there is also substantial differences in prescribing behavior that is seen between the facilities. And this highlights the urgency of addressing antibiotic stewardship through added antimicrobial stewardship efforts, including targeted mentorship. So with this, I would like to call Susan Makawia to take us through the CDSA and pulse oximetry cost analysis. Karibu.
Good afternoon, everyone. Yeah, I want to commend all the previous speakers who have been speaking since morning. And just to say that my presentation in the cost evaluation of the TIMCI intervention, and I just want to say that I led the costing study in Tanzania, data collection, also some analysis. But this afternoon, I'm happy that I'm presenting the study results for all the study countries. So I would like to start by saying that the cost evaluation was done in the two arms of the whole study. And then the aim was to evaluate the cost of using pulse oximeter alone, but also pulse oximeter combined with ECDCA. All this in primary care facilities and also compared to standard of care. Time framework for collection of cost data is started August 2021, but also until April 2022. But I would like to say that there are many rounds of data collection for the various studies, but for this particular study, it was only the aim was to collect data at one point in time, so in one quarter, and then the following quarter was just maybe to feed into information which we did not manage to collect in the first quarter, in the main quarter of data collection. Sorry if you did not hear, but I'll raise my voice from now. So for Tanzania, for example, specifically the costing study and costing data was collected in the third quarter, and in the fifth quarter, we decided to collect more information, which we did not manage to collect well in this main phase of data collection. So regarding economic data collection, this slide, you have seen it, I think you presented it very well, but I'll just add some things, or maybe just to repeat some of the other things quickly, that not all countries followed the same study design. As you saw, you have Tanzania and India following randomized controlled trial, but Kenya and Senegal, pre and post study designs. And you have 3 arms in Tanzania, but only 2 arms in India. And this data was collected mainly in primary healthcare facilities and in some hospitals. But the aim, and this is the emphasis I want to make in this slide, that the main aim to collect data from primary facilities, to collect data, the cost data, for example, for consultation and tests, but also from hospitals, to understand how easy is it difficult for families to go to the hospital if the child is severely ill, and to understand some other cost barriers. So this was the aim of collecting this, the data in these 2 levels of facilities. So we have the framework of collecting costing data, which we used, and I'll just, in the next slide. This is the framework, and looking at it, we are trying to think of it as different ways in which the intervention affected costs. So we have different components, for example, equipment, training, treatment, other diagnostic tests, hospitalization, and also country deployment of CDSA. And I'll go one by one. To start with, for example, the cost of equipment, this was just purchase CDCA and also pulse oximeter, and the number of units for purchase depending on the level of facility. And the cost for this was amortized over a 3-year period, assuming that pulse oximeter and this CDCA lasts for 3 years. Coming to training, you have, it was mainly for the health workers who are going to implement the intervention in the facilities. So this required them to get, for example, per diems, because the training, for example, in Tanzania, in fact, in all the 3 sub-Saharan countries, they did in-person training where it required they receive per diems, and also the training was 7 days. So 5 days IMCI refresher training, and 2 more days for the tools, ECDC and pulse oximeter. The per diems vary between countries, but they are considered very expensive. For example, Senegal, you have $55 per day per participant, but Tanzania and Kenya around $110, depending on the guideline of the country. However, even if they were very expensive, but the training was considered very important because it was not very easy for someone who is not trained in IMCI to use ECDSA. So even with this expensiveness, but they were important and they were carried out. But in India, they did online. It was not in person. So we'll see later on how the costs went. Okay. Regarding treatment, I'm going through this framework. So I've talked about equipment and then training. Now I'm going to treatment costs. I'm going one component after another. So regarding the treatment cost, the main costs which were monitored and in which change was observed was the use of amoxicillin antibiotic in sick children. This is what I think it's following what Professor Moshiro just presented regarding antibiotics use. And you see in these three countries, the use of antibiotics is different. For example, before intervention, you have 70% use, for example, in Kenya and the similar case in Senegal. But you have the WHO recommendation. I think Yasir touched about this, that the recommendation is 30% of those children who come and present fever and should be prescribed to children who are really severely ill and maybe they potentially have bacterial infection. They should be given antibiotics. But you see, after the intervention and by the recommendation guideline, after the use of ECDCA in Kenya and Senegal, they experienced reduction and drop in use of antibiotics, which to them was a cost saving, but you'll see later on how the costs went. The drop in Tanzania, Samoshiro highlighted that the drop in use was not quite as much, and it was a little bit in CDSA, but not in the pulse oximeter arm. So going to the other diagnostics, which is another component of cost, which was considered in the analysis. So we use sick child data, and in the three countries, the most common diagnostic test was for malaria, and it varied according to season and region. So after the intervention, there was no big change in diagnostic tests because still 50% of these kids were being tested for malaria if they presented fever. But in Tanzania, after the intervention, you see some interesting findings. Some other tests started being used, which were not commonly suggested by healthcare providers, like, for example, urine analysis and stool tests. Now with the intervention, they are being performed. And this findings show that the introduction of CDSA was prompting healthcare providers to think of other tests, which is good, that it uncovers some other kind of severe illnesses in children. So coming to hospitalization component, of course, severe pneumonia was used as an indicator of condition for hospitalization. And the aim was to get various information or various aspects of costs when a child is hospitalized. For example, cost of oxygen, ICU, but also we also wanted to understand the cost which families incur when they have a severe child going to be hospitalized. So this cost was captured, which is household cost, but it was captured at the hospital level. We asked such questions: how much, like the cost of meal, cost of transport, some other costs like cost of salaries were obtained from the literature because it was they are not publicly available, especially in Tanzania, but also cost of equipment, maintaining the buildings, etc. The last component of cost is cost of deployment of the CDCA, and the costs were in two. There are two kinds of costs: fixed costs, which each country incurred, like estimated to be 8,000, sorry, US dollars, but this one, the fixed cost was not included in the analysis, but just highlighting it. And the fixed cost was for developing the algorithm, having workshop in the country to understand the guideline, doing some pilot tests within the country, also changing codes, identifying savers, for example, and also potential people to run the system and monitor things and stuff. You know, these are technology things. But the recurrent costs of the CDSA is the one which was included in the analysis of costs. And it included running of savers. And as you know that this system, the government normally have their systems for collecting data, but this was a standalone system. That's why, because even the savers, they had to, I'm not a technology person, but I know you can understand. They had to identify savers for putting those data and what. So it was a standalone system, just to summarize. So the recurrent cost for running those savers, storing data, uploading, updating the tablets, whatever, those kind of stuff. So the costs were, by each country, it was 60 facilities. So the cost was high. And this data was obtained from the Swiss, because I think they did this. Now let's go to the results, because what I have just covered is regarding the costing framework. Now we are going to the results. So the results I'm presenting here, we have separated the arms. We have the arm of pulse oximeter and the pulse oximeter with ECDSA. And you have, for example, the first part, the left, I think that's the left, even for your side is the left. So the left there, you see India and Tanzania. So we have included the arms, data from the arms, which for India is pulse oximeter and also Tanzania. And this side, because Kenya and Tanzania had the pulse oximeter and CDC, so you have them in this other side. So it basically summarize cost component changes and the unit is in dollars per 100 children tested. Senegal is not included here, but we'll see it later on. But on the left side, the pulse oximeter only, you see training and the equipment as the bigger blocks in terms of costs. And also you see a little bit of increase in diagnostics, especially in Tanzania, a little bit, not too much. And also increase in hospitalization. And with pulse oximeter, this is what you expect to see, because what it does is to identify sick children who clinically will not be identified by the healthcare worker, and then for hospitalization. And on the right-hand side, you have this pulse oximeter, and you can see the costs being driven higher by the yellow bars, which are basically the cost of pulse oximeter, the cost of ECDSA. Now, looking at that, you have the red blocks in Kenya below, but those ones, given the discussion we've had regarding the antibiotics use, in Kenya, there was a decrease in antibiotics, which was promoted by use of CDCA, and this almost offset the use, the cost of the incurred on CDCA. I think that point is clear. There is a question you can just ask after the presentation. And then so this is like a cost saving, the cost saving, because they spent also on ECDSA, but given that the reduction in use of antibiotics, which was a cost saving to them, sorry. That's why you see the cost, overall cost is going down compared to Tanzania, because in Tanzania, we did not have that much reduction in terms of use of antibiotics. But even still with this, the POX CDSA arm, the bigger blocks also are training and equipment as well. And looking at this, you see the cost in health centers is less than in health in dispensaries. And the reason is that bigger, high level facilities like health centers, they have higher loads of patients. So if you spread the cost across a number of a large number of patients, then it goes down. So going to the net cost per child. Yes, this slide here. You see the net cost per child tested were very low in Kenya, 16 US dollars, but in Senegal, you see this amount. The reason is that in Senegal, this intervention was implemented in the lower level, not the health centers, because the health centers, they're already using pulse oximeters. And these lower level units, they see very few patients. For example, you see there was like five child being seen using pulse oximeter in this health spot per week. So it was very few numbers, but they have all this investment, which they spend on very few patients. That's why you see the lowest country, the country which had the lowest net cost per child was Kenya, and then Senegal, but also Tanzania. You see, like the bars, we follow Senegal. So the cost in Senegal is around 400, almost 400 US dollars per sick child, which was considered very much high. In India, you can see the costs, they are below, but it's hard to compare with the other sub-Saharan countries, because India had a little bit of a different context, and the difference is that the 7% of the health system rely on private, and only like 30%, which is public, and public is not quite often used. I think the Indians will tell us more about that, and because the fact that very few patients go there, it's like you go there when you don't have an option. So it's considered of low quality, the public healthcare facilities. That's why you see the cost behaving like that. So what are the key lessons we learned from the cost analysis? Sorry about this. Yeah, the key lessons per country. So India was different. They did not provide IMCI training. All they had is the online sessions, as I said from the beginning. So they did not provide per diems, which these other countries experienced. And it was COVID at that time. So the training cost in India was very low. But in Kenya, there's this distinguished feature of supported supervision, which helped which helped providers to adhere to the recommendation of the CDC. That's why you see that in terms of there is reduction in antibiotics usage, as you've heard about it. And that's why their cost net cost per sick child was very low. In Senegal, there was strike. I think one presenter said they talked about this. And as I said, the intervention was in small dispensaries. That's why they see very few children. That's why their cost behaved like that. But in Tanzania, the explanation for our findings, we say that we have the lowest per capita income of the 4 countries. And now there are still gaps when you are implementing such an intervention, which it's required to fix some other things. That's why also the cost was a little bit high. So to conclude, pulse oximeter can be used and it assists to identify severe disease. But if families are not able to comply with the recommendations to refer, health benefit may be reduced. Because yes, there is this policy that under 5s, when they're sick, they can get services for free from the facilities. But that's in theory. In reality, that's not happening. You see children going to the facilities, they don't find they are seen by the doctor, and then when they are required to perform a test, they are told that you cannot perform this test here. You have to go to another facility or maybe to a mission hospital to do this. So this is cost to these families. So, and as you have heard, I think Grace was talking about this, that the families are really, yes, they are they're being referred to go to higher level facility, but going to the referrals is something else. There are a lot of factors around that. And just say that these health costs mean a lot because they are high in terms of when you're talking about rural facilities, rural households, for example. The costs may be very high compared to the daily earnings they are getting. And the last conclusion is that if you focus the intervention in big health centers with a big volume of children, it is going to be feasible to implement, but it's difficult to implement in this especially in rural parts of these countries. And just to say that we're not at the point of saying that it's very, very expensive to do it, but I think it can be done. I think it's just a way of looking how it's going to be done, where maybe first to start introducing it and then the rest of the areas can follow. So thank you for listening. This is the end of the presentation.
Okay. Thank you, Susan. Thank you, Mashira. So we have maybe 10 minutes for questions, and kicking it off. Actually, I'm going to go here first, if you don't mind. Okay. And then Sabrina. Okay.
Okay. Thank you for the presentation. Mine actually goes to the antibiotic stewardship, looking at this tool as an intervention. If you look at the antibiotic stewardship and trying to really see this intervention as a way of changing the behavior of prescription, you're dealing with individual prescribers. And your unit of analysis is actually facility. Basically, from the charts you show, most of these changes are at facility level, trying to really see those ones. And knowing fully that the primary participants, which are the prescribers, the clinicians, they may be at different level or stage of behavioral change. Maybe if you look at the theoretical model, which shows that there are pre-contemplation, contemplation through to determinations. In what way does really this intervention really address these different stages? As we all know that it varies and of course may have an influence. I'm saying this because I felt we should be a little bit careful to really, especially where we're having so much benefit in terms of what you have. Only in Tanzania that you have a really marginal improvement in terms of how this may have provided. Then, of course, also this kind of analysis of effectiveness of analysis is actually on the view of the so-called intention to treat analysis that you usually do, which if you look at it from the conservative viewpoint, the assumptions that anybody that has not been exposed to the intervention may not necessarily do the desired behavior, which of course, with this era of information, you agree with me that that may not have been. So how have you actually factored this to really make this finding more acceptable and applicable to us? Thank you.
Thank you. Do you want to respond?
Okay. Thank you for your question. I think it's a very interesting question. We did not really analyze, or at least until now, we have not been able to analyze based on the individual, because you are right, some of the facilities have different cadres, for example, that are attending patients. So it will be very interesting to see, the behavior of prescription based on the different levels of the cadres. But I think The interesting part with the CDSA, if you ask me, is that it really takes the actual IMCI algorithm and actually shows that to the provider that, you know, this syndromic approach, if you have really in front of you a patient with these symptoms, this is the most likely diagnosis that you have. And if this you agree, then this is how you treat. And I think the basis of this is that previous studies have shown that the adherence to the guidelines is very low. And I think we have also presented, right, even with the introduction of CDSA did not really help much in terms of making the providers to really assess the patients according to the IMCI algorithm. I think that would be really the catch if we can really make our healthcare providers follow that algorithm according to what it recommends. Because I think studies have shown that if we are able to follow that, then we improve outcome, but also we will not have as much as antibiotics being prescribed as we do have right now. I think you are and our data to that level that you were looking for, but we are still conducting more analysis on this and probably will be able to say something about it. Yeah.
I'm here. Thank you so much for the two presentations, very informative. My question to the antibiotic stewardship presenter is, was there any effort to correlate correct diagnosis and the use of antibiotics, especially since if we are looking at syndromic management, the likelihood of a provider to at least do something in front of a mom or dad was both that do something, you know, give amoxicillin, give an anti-malarial. And yet we also know that amoxicillin is becoming increasingly resistant to most of the community-acquired diseases. So I just wanted to know if there was any effort to make correct diagnosis versus.
They are inappropriate use of antibiotic. It is not inappropriate use of antibiotic because nobody is implementing IMCI in control group. If they implement IMCI in control group, there would not be an inappropriate use of antibiotic most of the time. It may be in some of the cases, yes, but if you implement IMCI, it would be an appropriate use of antibiotics. So in terms of CDSA, I would say it tried to implement the IMCI through this tool. It's not, you can do it on a paper also using the same because you are using IMCI. But having said that, we need to implement, because this is a strategy, we should implement all the component of this strategy, not only one component, only assessment, not only treatment, but counseling is a big part of IMCI. Follow-up is a big part of IMCI. And I haven't seen that one also in that. So for me, we have a very poor control group. That's why we have such a things happening in intervention. If we have a good control group, which is like implementing 80%, even 80% of IMCI, the result would be different. So it's my request to all of you to think very carefully that we are comparing with another thing, which is very poorly designed control group. There is nothing giving erythromycin or something like antibiotic copromoxazole in Kenya. I don't know. Amoxicillin is still the first line drug. And this is based on a huge research that amoxicillin is still the first line of drug for pneumonia cases. There is a lot of research on that. It's not like somebody is sitting in one room and saying, give amoxicillin. There is a huge research behind that. Where is that? Where is that? Is it published? It is population-based resistance or a hospital-based resistance. Yes, So it's a different, we are talking about here as a population-based. IMCI is in a population. We are implementing at a primary level care. We are not talking about hospital-based. Severe cases in hospital, we know that their treatment is different. So here also, the control group, we don't know whether IMCI was implemented in control group. It seems from your presentation, especially Robert, your presentation is wonderful because it showed us other aspects of IMCI. And I think IMCI was not implemented in the control group. And it was better implemented in intervention group with CDSA. That's all from my side.
Thank you, Yasser. Real quick, but we did do training for IMCI in the control arm, but again, that's it. Yeah. Yeah. Any comments?
Just comments. With regards to the design, I mean, in the initial design that they presented, it was very clear to us that in different cells, they define it very clear. If you look at the cells that has the tools, it is actually like IMCI plus the tools, you know, depending on whether you have the pulse oximeter or the clinical decision. That's one of the cells. Then you have a second cell that has probably just the pulse oximeter and of course the refresher training based on IMCI. Even in the control group, they have refresher treatment for IMCI. And my assumption is that if you have refresher training for IMCI, the requisite job aids for IMCI will have been provided in the so-called control group rather than just refresher or do nothing. The assumption that if you do a training for IMCI, you deploy the relevant paper-based tools, including the. So, and that's has been my thinking, and that's the way I thought the result is being interpreted. If not, then of course, we're having a very woolly defined control, and that's not something I think.
I'm going to hand that back to the panelist defining that for us.
Yes. I think the gentleman that spoke the last said it all. This is how we did it in both in Tanzania and in other countries as well. So, for example, in Tanzania, in the both three arms, all the providers did got a initial IMCI training, and they were all trained the same way, and they were trained at the same time. And then the facilities that had these extra tools, the pulse oximeter and the CDSA, they got extra 2 days of training of the particular tools only. So I agree that if we implement IMCI with all its complement, we're going to get a good results. But the issue is, we know the issue is with the adherence with the whole algorithm of IMCI. I think that is the catch. How do we make our providers follow all the strategies, as you say? And if we are able, or if we are able to come up with something that can make them follow that algorithm in a best way, then probably we don't need any other things to come on top of that. Yeah.
Thank you, Dr. Michelle, just to add on what you have said, that if we can have something which will help our healthcare providers to follow the algorithm, then probably the outcome would be better. In Tanzania, we had something to learn. Fortunately, it happened when we were implementing this project. We had another similar project using the same modality or the same algorithm, which was also being implemented somewhere in the other part of the country, but with different context of setting. For us in TIMCI, we are trying to implement the project in the real world. I mean, trying to follow the guideline from the government, the supportive supervision. We imitated the government's set of monthly supportive supervision. So it was not that much strictly supportive supervision. But on the other way, we had another project. Fortunately, the coordinator of that project is here. He might also say something. which we are again implementing the clinical disease supportive organism, but with very strong supportive supervision to insist in the behavior change. So the result is different from what we had. And probably it was the same also happened in other countries where you see the reduction of antibiotic in Kenya and Senegal, which was slightly became reduced. So the context of implementing and how strongly supportive solution can be can change the whole thing. So probably Dr. Chacha can say something.
Yes, thank you very much, Dr. Mjunga. I was trying to raise my hand, but unfortunately, I think what we are seeing here, we've been discussing about, number one, the use of the IMCI. Number two, we've been discussing about the adherence of MCI. Under normal circumstances, you go to his facility. When we were planning for the study, before that, then I'll speak, you go to a facility, you ask if there is an IMCI, they will tell you that there is no IMCI here. Then you just check, just in case if you might have it. They pull 1, 2, 3 drawers, you find an IMCI in the drawer, hidden somewhere. Some of the people, they actually have it on the table, but they don't even know that this is IMCI. So when we were implementing the same, the Epoch Plus, the same CDSA, we performed, in addition to, in both control and intervention, we were also doing a very close mentorship. We call it mentorship. We were looking at the dashboard. If we see any spike, for example, of the increase in the antibiotic prescription in facility A, then we go there, we actually check, then we discuss what is it, why did they prescribe antibiotics, is there anything that they're worried about, is there a possibility to reduce the antibiotic prescriptions, and all these things. And then we had trainings after some time again. But the mentorship that we're providing, it was very, very strict. It was set within time. So we nearly rotated in every health facility after a certain period of time. And in us, we also observed we compared between the control facilities and the intervention facilities that they had the tool. And we saw the antibiotic prescription dropping to about 47% in those facilities. Now, again, what we had 2 phases, the randomized control trial. When it was over, then the first 2 was to implement the tool in a close to programmatic level. And we are still looking into this data, but we actually saw that the antibiotic prescription again increased to the facility that did not have that close mentorship. I mean, from 27, it was 23%, then it increased to about 40, some facilities up to 60. Then we implemented another mentorship program where we, among the same facility, using the tool, but some facilities were mentored and some facilities were not mentored. So those facilities that again received the mentorship, the antibiotic prescription dropped quite significantly. Now, this tells us that in order to achieve a good adherence to the tool, we need a very close mentorship to this facility, to healthcare workers, to be able to achieve what we're looking for. And when we talk about the adherence of the tool, in my opinion, I think the CDSA comes in because it helps for the health facility staff to adhere, to follow the steps of the IMCI and be able to manage the children. Now, the problem comes because the tool also allows them to either accept or reject and then have their own opinion, which in my opinion, it is fine because these are not robots. They're clinicians. They're trained clinicians. They also have to make a decision because the patient is in front of them. So we have that. I think in a nutshell, we need mentorship. And there are other factors actually that come to play to be able to see the effect of the CDCA tool. Thank you very much.
Okay, maybe two more questions and then we'll go to break. There's lots of hands up.
Good afternoon. It was good presentation, but actually for me, what I wanted to say has been preempted by the two previous speakers, in the sense that when I listen clearly from the morning, one thing I see clearly here that we have to follow IMCI 7 modules. But what I'm seeing here is, for example, module Council of the Mother was not done very well in this study. The issue of referral, the issue, again, comes back to the issue which my predecessor just said, to say, for you to see results in IMCI, 60% of facilities have to be implementing IMCI, and then you go up. At the beginning, when we started implementing IMCI in the 90s and early 2000, there was resistance on IMCI because of the issue of syndromic diagnosis, to say classify. The doctors, as the doctors, we didn't like that. So we pushed it down through our throats. And eventually, the other issue was the issue of prescriptions. Nurses were not allowed to prescribe. The same amoxicillin, we had to change our guidelines from our regulatory bodies, and now nurses are the ones who are prescribing amoxicillin. So I'm not surprised to see what I'm hearing here, but that can be reduced if there's mentorship and supervision. So I'm not surprised to hear that. But for me, my take-home message is, for this presentation, as I came from Zambia, is how do I influence policy? We have to be very careful to say, this study, when I go back to the ministry to say, let's do this, it has to show that spark to make a difference. But where we are still stuck at 60% implementation, and we already see that there was an effect on mortality. So I don't know what I should take home as a message. Number two, on the cost study. When you are doing the cost study, you should compare with how much does it cost to train an IMCI trained person. That's one of the things actually you should have looked at, not comparing the same apples. So already we have IMCI training, and we have moved from 14 days training, abridged the IMCI because of the cost of the IMCI. So now that you are doing this one, how does it compare to the real IMCI abridged course?
Thank you.
Thank you for the opportunity. I'm Omokorelisi from Nigeria, Federal Minister of Health. So now, one of the major problems with the paper-based IMCI is the issue of data. So for the CDSA, concern how were you able to manage your data? Do you have a separate data, or you incorporated the data you are getting into the national DHIS in those respective country? And if that is the case, if you have a separate data and separate server for the CDSA, will it be possible to incorporate to align your data into the national DHIS? Thank you.
Okay, back to our panelists, and I think we'll probably take a break right after that.
Yes. So maybe Dr. Mjungu can help me with the CDSA, but I think we had a different server with the CDSA, right? It was not integrated in the government HMIS system, so that is managed separately. So the plans, if there are plans to integrate it with the HMIS for Tanzania, for example?
Okay, yes. So initially, when we had the discussion of ensuring that we have the co-creation and the implementation together with the government, when I presented the idea of using the government server, the direction was a very bright but sensible one. The ICT director from Ministry of Health, asking me a simple question that Mjungu, we have several researches going on in the country. Now, suppose all those researches will ask the Ministry of Health to have their data to be integrated into the MOH server. So really, I thought it makes sense. So for that, he said, okay, you go on with your research. And when you have the results, I know the government, it is on the move of seeing how it can integrate the digital platforms into health systems. And when that time comes, it's the time of talking about the integrating all the various servers into the government. And after we have talked about the interoperability of the systems. So when moving forward, that is the way forward that after the government has finalized, after it has harmonized the interoperability of the systems, is when that discussion of integrating the servers will be taking place. But as for now, it is still a research-based sort of, and it is ended by the research organizations.
And we should have introduced Kevin, the data manager from University of Nairobi from Kenya, who is perfectly positioned to answer this question for Kenya.
Yes, thanks, Mike.
Just in time.
So just to add more to what Dr. Ria said over here is, so for the paper-based records, we captured data using a collection tool, ODK. So, and that was set up on a separate server. And then for CDSA was also a different service altogether, and we set that one up differently on a separate server. So, and then lastly, on the integration with DHIS2, I think Andolo might be in a better position to respond to that. So maybe we can give Andolo a mic for that.
Yeah, I think I mentioned in the morning that in Kenya, the Ministry of Health is in the process of looking at how do we integrate digital health tools in the health sector. They have set up what we call Kenya Health Digital Health platform, which is doing a pilot. And what they want to have is what they call a super highway, where you can get all patients' information at one time. So we've had a discussion with the Directorate of Digital Health, and the information is they're allowing various digital solutions to be carried out in the country. And then when it comes to the aspect of integration, they'll evaluate all these tools and see which one works. But then they want to have what we call Superhighway 1 module, where you can log in and retrieve a tool that you want to use for assessment of a child. And that is the space where we think when time comes, we'll have to push CDSA. Thank you.
Okay, Susan?
No, it's just this comment which, I mean, the question which he asked, how it goes to training and IMCI, given that from this discussion, we see that IMCI is very, very important. And also, I mean, refresher training is important. Given that I presented the slide on the cost component, but I think this question, given that I said in the beginning that the analysis is still ongoing, so we're taking it as a comment that we'll work on it, and in the next presentation, we'll be able to, I mean, put it clear that this is how much it costs by each, I mean, training.
Okay, thank you. So one last comment from Senegal about the data integration, and then we'll take a break. And I'm glad to see everybody woke up. This is great.
Hello, I am Mansour. I am the country lead, TIMCI country lead from Senegal. Je vais parler en français. Voilà, donc merci beaucoup pour les différentes questions. Donc je voulais juste dire que tout au début du projet, donc le CDSA n'était pas considéré comme un outil d'information sanitaire. En fait, le but du CDSA, c'est pas de procurer des données sanitaires, mais c'est d'aider les prestataires à la prise de décision clinique, donc de les guider pas à pas dans le diagnostic et le traitement des enfants qui sont âgés de 0 à 5 ans. Maintenant, avec les discussions qu'on a eues, sorry. Okay, sorry. Okay, with the discussion which we have with the minister, que nous avons eu avec le ministre. Okay, okay.
Everybody ready?
Okay, that's fine. Got it.
Go.
OK, merci beaucoup. Donc, je voulais dire que tout au début du projet, donc le CDSA n'était pas considéré comme un outil d'aide à la décision, comme un outil d'information sanitaire, c'est-à-dire un outil pour collecter des données, pour les partager, mais c'était plus pour aider les prestataires donc, à faire le diagnostic et donc le traitement des enfants. Donc, c'était plus un outil d'aide à la décision clinique. Maintenant, peut-être par rapport à l'expérience du Sénégal, donc avec les discussions qu'on a eues avec le ministère de la Santé, donc à travers la division de l'information sanitaire et la DSME qui s'occupe de la santé de la mère et de l'enfant, donc nous avons pu mettre en place un formulaire PCME+. Donc ce formulaire-là donc, a permis de traquer les informations donc, pour le projet. Maintenant, dans le cadre du passage à l'échelle, il est prévu que ce formulaire-là donc soit intégré dans le formulaire R20.
Has to be integrated in the platform of HST. These are
La mesure de la saturation d'oxygène, l'oxygénothérapie et d'autres indicateurs qu'on a identifiés donc, dans le cadre de la mise en œuvre du projet de manière consensuelle avec le ministère de la Santé. Même au Sénégal, c'est le problème qu'on avait, hein, parce que pour beaucoup de districts ou en tout cas d'acteurs, ils pensaient que le CDSA est forcément un outil pour faire des rapports, pour partager des données, alors que dans le concept du projet, c'était plus un outil pour aider les prestataires à, donc, comment dirais-je, à établir un diagnostic efficace, donc en rapport avec les directives PCME et d'autres directives. Voilà, donc c'était ça, juste ça que je voulais rajouter. Et maintenant, par rapport à la diminution de la prescription d'antibiotiques, je pense que rien que pour ça, donc le CDSA mérite d'être utilisé parce que de plus en plus, on parle de la résistance aux antimicrobiens. Et si on fonce vers ça, si il y a une certaine résistance aux antimicrobiens, donc nous fonçons tout droit vers un vide thérapeutique. Et ça, je pense que personne ne le souhaite. Merci beaucoup.
Thank you. Okay.
Thank you, everyone, again for such a dynamic and insightful discussion. Thank you very much. A quick clap for that session, like this. And we've got a 15-minute break, and so we'll be back at 5:45. Okay, we're going to start now. Welcome back, everyone. And I'm pleased to announce the last panel of the day, which is a general discussion panel with Mira Emmanuel Fabola, who's Deputy Director for the TIMCI project with PATH. And she'll be joined by Dr. Malu, Dr. Mashiro, and Professor Masanja. Oh, no, he's not there. And Professor Faye. So welcome back. And over to you.
Can we have your microphone? Welcome back, everyone. I hope everyone is feeling revived. I know there's lots of questions, so I'm going to start with 3, and then we can continue around the crowd and keep going for as long as we'd like to. Grace is not so sure about that. So Grace, my first question is for you. We saw from the qualitative data that providers often indicate that caregivers gave pressure for treatments and complained about long wait times, which had an impact on actions around both prescribing and using of the CDSA. Do you think the influence of caregivers on healthcare workers as related to this pressure can be addressed in part of the sensitization and education of caregivers? And what kind of approaches would you recommend? Yes.
Thank you very much, Mira, for catching me off guard, because actually we're not prepared for this part. But I'll try my best to respond, and then I'll give also to the audience. Perhaps they'll have something to. So the question is, if I think the caregivers influence in some kind of way the decisions that the healthcare providers made, and if doing it a bit differently, what kind of approach would I use? First of all, I would say it is true that the influence of the caregivers during the study was there, as we've seen on the results, although this was not quantified enough because We only collected qualitative data on this, but as you know, we cannot get away from this. Everything has some sort of an influence, although it is in the health system. So if it is a different approach that I will use, first I would say the design of TIMCI was very, for me from my end as a scientist, was a very good design, pre-post and RCT. The community engagement that we had done were also okay. Path did a very good job with community engagement. For the influence of the caregivers and a different approach would be, as you know, the world is evolving and now we are moving from designing research as ourselves. Now we have what we call human-centered design and a co-design. One of my friends is an expert in that and she's looking at me. So an approach that I will use if it was designing this differently was human-centered design and a co-design approach where all the caregivers will now have a few, perhaps representatives of the caregivers will have a chance to sit down with the healthcare providers and the research scientists and decide on the methodology, or I call it implementation strategy, which kind of strategy could be used for a study like TIMCI. Path did a very good job with community engagement and they used community health workers. First, they used CSOs, but then CSOs in Tanzania particularly did not do very well. And then they started using community engagement, community healthcare workers. I think this is the approach that we will also continue using because as you know, now we're advocating the use of community healthcare workers in Tanzania. So I will design some sort of, first I'll start with a IRA strategy that includes the caregivers, the community healthcare workers, the healthcare providers, the pediatricians and the scientists, so that we can come out with one strategy that will be used in order to make the study to have different results, perhaps. This is what I can say.
Thank you, Grace. Prof. Bashiro, from your experience in conducting field visits and observations of health workers at the facilities, what would you say are some of the strengths of the TIMCI implementation approach, and what would you say are some of the areas that might have led to the unexpected results? What, in your opinion, could be further strengthened to fill some of the potential gaps which have been identified?
Thank you very much. A bit of a complex question in a way, but I think in terms of the TIMCI implementation, from the moment we started developing the algorithm for the CDSA, I think all the stakeholders were involved, including the Ministry of Health. I remember some of the initial meetings that we had with the Ministry of Health, and then we had with experts of IMCI in trying to make sure that the CDSA included all the algorithm. And for Tanzania, I think we even added some of the algorithms that were a little bit outside the IMCI, you know, realizing that it's not only children under 5 that are actually consulted in this primary healthcare facility. So I think from the start, you know, high level involvement and then involvement of the experts to try to make sure that CDSA is comprehensive enough. And then to the level that Dr. Grace was speaking here, involvement of community health workers. I think that's what really made the TIMCI a bit strong. And for the part of the evaluation that was conducted with IHI, again, the community healthcare workers were key in linking the caregivers to our research assistant and to the healthcare facilities. What we could have done differently, well, depends, but I think I remember, you know, it's selection of the facility and make sure that you are capturing the whole population is important. Now we are thinking probably that we missed some of the patients who had severe disease. So I think if you next time you want to do it again, probably would think more and possibly involved high-level facilities that it's nearby this community, probably it would have helped so that we also try to at least catch all the patients who have possibly severe illness and try to make sure that you're not leaving anyone behind. Yeah.
Thank you. That's really helpful to hear. And my last question is for you, Prof. Phai, and then we'll head over to the crowd. Many of the measures and care qualities, such as routine measurements of temperature, weight, and overall complete IMCI assessment, were higher in Senegal in baseline than in the other countries. We also observed a lower antibiotic prescription rate at baseline in Senegal. However, many of the measures over time from pre-intervention to intervention indicated either small changes or even in some cases declines in indicators we hoped would improve. What would you think were the main reasons for that, and in what ways would you mitigate these challenges?
Merci. La particularité du Sénégal dans le cadre de la PCME, un instant, hein. Je pense que la particularité du Sénégal, comme l'ont montré un peu les résultats, notamment dans la partie pré-intervention, c'est que la PCME, donc AMCI, était à un niveau, disons, de mise en œuvre, d'utilisation qui était déjà beaucoup supérieur, largement supérieur aux autres pays. Et cela pour plusieurs raisons que peuvent confirmer mes collègues. Hein. C'est qu'il y a disons, un programme au niveau des districts sanitaires de suivi, d'évaluation, de supervision, qui fait que chaque prestataire au niveau du poste de santé a un point focal au niveau du district qui est responsable de sa supervision et régulièrement s'assure que le prestataire fait bien la PCME, respecte toutes les étapes, prend toutes les mensurations voilà, en tout cas, colle le plus aux recommandations de la PCME. Et donc, je pense que ce travail de supervision, de formation également, parce qu'il y avait eu beaucoup de formations chez les prestataires sur la PCME, des formations qui ont été répétées, et on a même eu parmi les prestataires des sortes d'experts en PCME qui sont eux-mêmes devenus des formateurs. Donc, tout ça pour dire que chez les prestataires infirmiers d'État, beaucoup se sont approprié la PCME et ont vraiment voulu la mettre en œuvre. Maintenant, les limites que nous avons eues, c'est que ça reste du personnel paramédical, ça reste des infirmiers. Et donc, par rapport à certains diagnostics, à certaines situations cliniques, il y avait forcément certaines limites. Ce qui a fait qu'on n'a pas eu d'amélioration notable en phase post-intervention, c'est d'abord le fait qu'on partait d'un niveau assez élevé avant l'intervention. L'autre élément que tout le monde a évoqué ici, c'est qu'en phase post-intervention, ben justement, ça a coïncidé avec le démarrage de la grève. Et donc, la grève a un peu tout chamboulé chez nous parce que dans la période, durant les périodes de grève, les prestataires décidaient volontairement, parce que le syndicat l'exigeait, de ne pas forcément utiliser les outils, de ne pas, ou même s'ils utilisaient les outils tels que le CDSCI, ils ne transmettaient pas les informations. Donc, on a cette période strike qui a fait qu'il y a eu vraiment beaucoup moins d'engagement des prestataires. Et ce qui a fait que, bon, on a eu beaucoup de mal à interpréter l'impact de l'intervention sur, en tout cas, sur l'adhésion à MCI et sur bien d'autres points par rapport à l'étude. Probablement que s'il n'y avait pas eu la grève, on aurait eu un profil et des résultats qui seraient très différents au Sénégal, malgré qu'on a eu quand même un certain impact sur, notamment sur la prescription d'antibiotiques.
Excellent. Thank you for your answer. I know that there are lots of questions remaining in the crowd based off of the last round. So maybe we can start answering questions unless anyone has something they'd like to add. No? And feel free to ask questions, not only of the panelists, but the rest of us that have done the research as well. So if you have any country-specific questions, feel free to ask. This is what happens when you take coffee break. We have one right there.
Merci. Bonsoir à tous. Je suis Dr Diango Claudine, la directrice des soins maternels et infantiles en Côte d'Ivoire, au ministère de la Santé. Je voulais remercier tous les panélistes. Et ma question s'adresse spécialement au Sénégal. Compte tenu du fait que la PCME est très avancée au Sénégal, j'avais voulu savoir si, à part la PCME clinique, ils ont aussi intervenu au niveau de la communauté. Parce qu'en Côte d'Ivoire, la PCME est très avancée. Nous aussi, la PCME, tous les 113 districts ont des points focaux en matière de PCME, au niveau des 33 régions aussi. Mais nous avons fait une délégation de tâches de la PCME aux agents de santé communautaire et qui sont sous la responsabilité des DD et puis des infirmiers chefs des centres de santé. Donc, je voulais demander s'ils sont aussi au niveau de la PCME communautaire.
Alors, je ne sais pas si je pourrais complètement répondre à cette question. Ce que je sais, c'est que dans les postes de santé, il y a des agents de santé communautaire et que ces agents de santé communautaire, souvent, au cours de ne font pas la consultation PCME, mais ils peuvent participer à la prise de constante ou à la phase pré-consultation. Peut-être que le ministère de la Santé est là, représenté par le docteur Mbouet, il peut répondre à cette question sur la PCME communautaire.
Merci beaucoup. Effectivement, au Sénégal, on travaille beaucoup sur la PCME communautaire. On a un guide de formation, on a le guide également du prestataire, le guide de l'agent de santé communautaire pour la PCME, avec toutes les directives qu'il faut au niveau communautaire. La dernière version date de 2017. On est en train de travailler pour remettre à jour le guide pour cette année ou l'année prochaine, mais on sait qu'il n'y a pas beaucoup de changements entre-temps. Voilà.
Yeah, thank you very much. Oh, I should introduce myself. So I'm Chacha Mango. I work with the National Institute of Medical Research, and I am the coordinator for another study called Dynamic Study, which also uses the EPOC Plus tool. When Dr. Grace, you're presenting, actually noted the difference in antibiotic prescriptions, reduction in antibiotic prescription between Tanzania, Kenya, and Senegal and India as well. And actually, what surprised me is that in every other country, there was a bit of the reduction, but not in the country, not in Tanzania. Yes, sorry, in the country, because it's my country. Yeah. So I would like Lil to know, I mean, from your perspective, I actually explained here some of the things that we were able to be done. I would like to know from other countries what was done. I do understand that the culture of prescription of antibiotics, I went to a certain facilities and every child who was attended received cotrimoxazole, every single child, regardless of their diagnosis. They must have cotrimoxazole. So these are the issues of culture of clinicians. But what actually happened in other countries? I would borrow the experience from UNC because that was interesting.
Pour la prescription des antibiotiques, la prescription de base est également très élevée au Sénégal, hein, surtout au niveau des soins de santé primaires, au niveau des postes de santé. Il faut dire que les recommandations de AMCI ne doit pas forcément, même sans le CDSA, ne doit pas forcément conduire à une surprescription d'antibiotiques, mais le problème est l'interprétation. Je prends un exemple. On avait dans la nouvelle classification avec le CDSA+, avec le CDSA, on a ce qu'on appelle maladie fébrile ou maladie fébrile très grave. Donc, le prestataire, lorsqu'il se trouve devant un enfant qui fait de la fièvre, en général, l'exploration ou l'examen clinique ne le pousse pas à chercher des critères de gravité qui font qu'il va prescrire un antibiotique ou dont l'absence va faire qu'il va s'abstenir de prescrire un antibiotique. Alors, l'utilisation de l'algorithme, en tout cas, quand on a fait les formations et qu'on a fait les supervisions et les tests au niveau des postes de santé, on s'est rendu compte que l'algorithme, lorsqu'il y avait de la fièvre, par exemple, poussait le prestataire à rechercher d'autres éléments de gravité tels que l'état général, l'existence d'une adodopathie, l'examen de la gorge, autant de choses qui, lorsqu'ils sont négatifs, lorsque l'examen est négatif, aboutit à la recommandation de ne pas poursuivre, de ne pas prescrire un antibiotique. Et cette recommandation était logiquement perçue par le prestataire. Alors qu'auparavant, on était devant la situation d'un enfant qui fait de la fièvre. On fait le test palu. Ce test palu, le malaria test, ce test est négatif. Devant une fièvre, test malaria négatif, le prestataire n'avait pas la possibilité cliniquement de pousser un peu plus les explorations, de pousser un peu plus l'évaluation pour avoir des critères de gravité ou l'absence de critères de gravité qui pouvaient lui permettre de façon sécurisée de ne pas prescrire cet antibiotique. En tout cas, dès qu'on a fait les premières supervisions, les premiers tests chez les prestataires, c'est eux-mêmes qui spontanément ont dit oui, d'accord, on est d'accord pour ne pas prescrire d'antibiotiques parce que malgré la fièvre, on n'a pas trouvé un autre facteur qui pouvait, un autre signe de gravité qui pouvait nous pousser à utiliser ces antibiotiques. Et donc, je pense que l'effet est réel. Et ça, qu'on a fait même avant d'utiliser l'algorithme, spontanément, le prestataire, sans être influencé. Parce que ça, il faut le dire, on n'est pas allé en leur disant non, les antibiotiques, c'est pas bien, il faut arrêter de prescrire les antibiotiques. Ça n'a pas été le débat. On a parlé des diagnostics de façon globale, des traitements de façon globale, et c'est eux-mêmes qui ont adhéré à l'orientation à laquelle aboutissait l'algorithme. Alors maintenant, peut-être que je vais vous passer la parole pour voir quelle est la différence avec la Tanzanie. C'était ça la question initiale.
Hein? Thank you, Profi. Actually, there's no big difference in Tanzania. The algorithm was followed as the same. Everything was done according to IMCI. We did not go out there and tell them not prescribe or prescribe. But as you all know, changing behavior is not a small job. It's something that requires time, also requires someone to say yes or no. So some of these findings, we do not have, we did not have power to change them. This is how they happened. But also, as I said earlier, our our caregivers influenced in some way. We did not show some of the courts where the care providers told us, you know, when a caregiver comes to the facility, they expect to go home with some drugs. If you don't give them any drugs, it is a problem. It's as if you've not treated them in a way. So this in one way or another might have influenced the use of antibiotics in the countries. As I've said, use of antibiotics and all this, it was beyond us. We did what we could, and these are the results that just came out. And I think it's also on the health system. It's part of the health system challenge that we should also be addressing and trying to change behavior. I know in 10 years to come, if we sit in the same room, our antibiotic prescription would have been lower, will be lower by then, because at least perhaps we would have changed the behaviors of the prescribers. So this is work in progress. It's not something that will happen in an overnight. Even for the countries that have been able to achieve this, I don't think if it was something that was done overnight. But now the good thing about this project is that it has showed that we have a problem and we need to address it. I think I've answered.
Thank you, Grace. Yes. So you want to add to the answer? Then we have another question, and then a question online, and then in the room.
Thank you very much. I'd love to add what Grace was just saying, and I think we haven't really talked about behavior change enough. There was someone in the room earlier who said, all right, so what should we do now? What should we do better? And how do we do it in our country? And I'd love to respond to it because particularly from the qualitative data, we do have some insights and we have some clear recommendations from healthcare providers, but also caregivers. I would like to remind all of you when it comes to behavior change, and there are different models out there, but there are actually three main elements. The first is to create capability. The second is opportunity. And the third, motivation. And I think these three pillars are really important: capability, opportunity, motivation. And we asked caregivers and healthcare providers during the interviews, and we said, what would you like to see when it comes to such an intervention? What did you like about the intervention? What would you like to see differently? And actually, they gave us some very clear recommendations, and I think we should really consider them. In addition to a lot of the sub-analysis which is happening right now when it comes to the quantitative data. In regard to the capability, the healthcare providers said, we really love the training. In many of the countries, they really said, we like it, but we would have loved to receive low-dose, high-frequency training, meaning in the facility, 1, 2, 3 minutes training on a regular basis and having ownership around this training. There were a few people, they said, I was cascade trained in the facility, but I feel left out. And I think this is really important. So low dose, high frequency training is one option. And they gave us this recommendation. So we should really listen. Second is opportunity. This means enabling environments. And again, they said time is an issue. We can think about either triaging or maybe employing more staff or using lay people to do the triaging, for example. But also we need to make sure that medicine is available, referral is available, if that's the advice they should give to the caregivers as a result. And the last is motivation. And I think, again, here, they gave us some very good recommendations. Motivation can be given through mentorship. And again, they said supportive supervision was really appreciated as part of the project, but we want more, we want it closer to us, we want it regular. And we want to know when they're coming, and ideally every day. So again, I think this is also resonating with the dynamic project. Mentorship is important and something wished for. And it can be done quite cost effectively, for example, through WhatsApp groups. And we may also want to consider some sort of a reward system. If you're using it, you get A, B, or C. You become a champion. It could also, again, be for free, something for free, a free system. But we could also think about maybe adding and integrating it into the performance assessment. And instead of looking at the number of children you're treating, maybe look at the health outcomes and give a reward to healthcare providers having good outcomes in their clinical practice. So just to summarize this, again, this is modules of behavior change. And I think this entire intervention had a huge component of behavior change for both healthcare providers and caregivers. And when we look at the qualitative data, at least, we have some very clear recommendations from lived experience. And I think we need to make sure that we listen to it. And I think it's not very difficult, actually, to implement the suggestions they've given us. So I'd love to stop here. We have a lot to tell. So if you have more questions related to the qualitative, there are more people. But just to throw it into the room, because there were some questions related to that.
Thanks, Leah. Some very insightful findings that we had. I'd love to hear the Kenya perspective. So Kevin in the back, if you wouldn't mind bringing him the mic.
Oh, Kevin.
Yeah, so in the Kenyan context, what happened post-intervention was that we had two like defining let me call them seasons, where we had the early intervention period and the late intervention period. So initially, when the interventions were introduced, the uptake was not very good. So Mr. Ndolo and our project leadership, that is Professor Machoki and Francis, sat down and they came up, they brainstormed on the way forward. So initially, when they were training, we trained the healthcare workers first on the interventions and the IMCI guidelines. But later on, with support supervision, I think with the presentations there, you saw that support supervision helped to ensure that the research flowed the way it was supposed to flow. But in the late intervention, we took the support supervision to the facilities, and they went to the actual facilities and trained everyone, including the subordinate staff, to give the intervention ownership in the facilities. Because initially the ones who were trained, like let's say if one healthcare, because the training was supposed to be cascaded to the other health workers in the facility, the ones who were trained, like the intervention was being used when the ones who were trained were at the facility. But later on, when they are not there, there was that claim that this intervention belongs to a certain healthcare worker. So there was no ownership between like other staff, healthcare staff in the facility. But afterwards, that support supervision, everybody, like it didn't have to be that specific healthcare worker that went for the initial training that used the intervention. After training all of the staff at the facility, you'll find that now every single day when you check the reports, when you check the data coming in, you'll find there are no gaps, or the gaps have reduced. So that really helped with the uptick of the interventions. Thank you.
Thank you, Kevin. I think Ndolo has something to add from the Kenyan perspective.
Yeah, just to add on what Kevin has mentioned, what also worked was the introduction of the project. From the many in-country assessment, service provision, and the rest, and even within the region, people had seen, IMCI not being implemented well. Dangers are not assessed, irrational use of antibiotics. So when we floated the idea of a project using step-by-step approach, the leadership was very supportive of this because it saw as a way that IMCI could be used effectively and it could improve. So that is one of the things that worked well. The second thing is that whenever we had supportive supervision, and even when the county had supportive supervision, there was an entire meeting of a particular county health management team just to see how the results are moving on, and they were encouraged. So whether you are part of the county health management team implementing child health project or not, but just as a team member, you are aware of the TIMCI project and you went out to support. The other thing I just want to mention is we also brought all the facilities implementing IMCI together through online meeting. We had an online meeting every month so that these facilities could amongst themselves share the experience and also provide a solution. So they could challenge each other whenever an issue came up and how the management was being done. And through that way, there was cross-fertilization and improvement across board. Thank you.
Thanks, Ndolo. I now have a question for Matthew Black, who is online, if you are still there with us. We saw during COVID and right after enthusiastic prioritization of financing of oxygen ecosystems, including pulse oximetry among global donors and agencies. How do we sustain that level of financing and attention to ensure equitable access in the long term? And what role do you continue to see for Unitaid and the Global Oxygen Alliance, which Unitaid co-leads? And Matthew, we can see you if you have an answer for us. Welcome back.
That was a very long and complex question that I was trying to capture, as you were saying. Thank you. So, yeah, I think, first of all, I'm going to, because I've been very quiet today, just to say thank you, everyone, for the deliberations. And I've been, with my colleagues, we've been eagerly following the conversations today. So nice for you to spark me up with a question for me. I think one thing we've learned from this project and the AIR project, which I know some of the people who are involved in the AIR project are participating online, and you've talked about them earlier. But one of the things I think we've really learned is that the role of pulse oximetry fits as a piece of the jigsaw and fits as a very important component. I think it was maybe the question answer towards the end of the last session, where one of the participants was mentioning about how you can have all these new tools, but you need to make sure that they're used correctly, and you need to make sure they're used as part of a strong system if you want to have impacts in terms of severe health outcomes. I think the phrase he used was that we'd been quite ambitious in placing severe health outcomes as an outcome of this pulse oximetry project. But I feel like a lesson we're learning is to be more holistic moving forward in this approach, and to make sure that the approaches we take do look, maybe rather than looking at a specific tool, look rather at how benefits can be made for entire health systems. So obviously the context of pulse oximetry, as I was saying in my opening remarks this morning, was changed greatly by the COVID pandemic and the awareness that was made globally about how oxygen systems had really been ignored for so long, and how critical they are, not just to the COVID response, but how critical they are to health systems in LMICs in general. So that was one way in which Unitaid sort of readjusted or renavigated its direction in this area. So the TIMCI project was originally thought of in terms of fever management. Now the thinking is more in terms of oxygen provision and the oxygen space. So Unitaid was one of the co-conveners of the GOAL Alliance, the Global Oxygen Alliance, which was launched last year in order to boost access to oxygen. And post-COVID pandemic has been really thinking about how we strengthen oxygen systems and how we strengthen health systems in general to be able to respond to pandemics. Now, I firmly believe, and I know Yasir is there, and he and I have had conversations on this as well, firmly believe that the pulse oximetry plays a critical role in being able to strengthen those systems and in being able to work with them. The role it plays, whether and the limitations that the devices have, and the need they have to be placed upon stronger systems, are all very important aspects. So this is probably a very complicated way of me saying that as we move forward as an organization, Unitaid, and I think I'm not really just talking about Unitaid, I think as the global donor community moves forward, there's this greater understanding of how we have to look at how systems are strengthened. We have to look about how communities that are accessing care and the individuals that need that care can be sure that when they are plugged into a device, be it a pulse oximeter or whatever, and a number comes out which suggests a certain pathway for treatment, that we need to make sure we've not looked at the device in isolation, and the pathway for treatment has to be there. So the Global Oxygen Alliance is what we're getting behind in order to push that forward. So GOAL is housed at Unitaid and we're working towards having funding opportunities. As I said at the beginning, Unitaid's work is really about supporting the research of being able to get something from proof of concept to being able to scale it up in the market. And then it's other donors like your PMIs or your global funds that are much larger than Unitaid that come in to bring things to scale. So I think the role that Unitaid can continue to play is ensuring that something like pulse oximetry remains understood as being a critical part. We continue to look at how things like the CDSA tool can be better integrated into existing systems, and how the work that we do and the data that we gather can be ensured to be can be ensured to be integrated across the work of different ministries of health. So that's my 10-minute answer. Maybe my 30-second answer is look at the read and understand about the Global Oxygen Alliance and be keen to see what direction that is heading in, and how you can participate in various different conferences or forums or whatever to ensure that the direction that the GOAL Alliance takes is in line with the needs of communities and the needs of countries like the ones involved here today. Thank you very much.
Thank you, Matthew. Appreciate you answering the question for us. Any reflections from the crowd? I know that we've talked on a little different things. Panelists, any thoughts, reflections? No? A couple more questions. Andrula, how much more time do we have? Okay, we'll keep going. Maybe I'll take this opportunity to ask Yasir a question, if you don't mind. I wanted to ask you about which child should have SpO2 measured. There are, as you know, different criteria for indication of pulse oximetry in different countries. And at the same time, we saw different uptake of pulse oximetry in the different areas, which may be an important indication to the feasibility of implementation using this different criteria. We also observed different rates of hypoxemia among different subgroups of children and across the different countries, but overall prevalence was relatively rare. Given the complexity of the interaction of implementation and clinical factors at play, what do you think we have learned from TIMCI about the potential benefits and challenges of the test all versus test high risk versus test none approach to pulse oximetry in primary care?
Thank you very much. It's 5:30.
I promise this is the last one for you.
And you are asking me such a difficult question at that time. You should ask me tomorrow morning, but I think from these results from this morning and previously also we have seen these results, the answer is not very simple, because still we are struggling with which group we should do the pulse oximetry. When we say all children, it seems like we are at one end, we may be wasting time of health worker, which is very important because it's only a 1 or 2 person sitting in that facility. On the other hand, we cannot say that they can miss some of them. So it should be a balance. And I would go with some algorithm rather than saying do pulse oximetry once a child reach the facility. And that algorithm needs some time, how we can frame it. We are still struggling, to be honest. We put it as a just for a static that under pneumonia management that any child with cough and cold, if pulse oximetry is available, we should do it. But seeing those results, there are two extremes. One is a green classification of IMCI. It seems no need for that. And another extreme is red classification, which is already having a danger sign and should be referred immediately to a higher facility. So why should we spend time on doing the pulse oximeter when they are going to a hospital where we assume that pulse oximeter and oxygen is available? So it seems like this is important for those, I'm talking about only for pneumonia, those who are in yellow classification. And I think Alima project previously shown us that 5% of the children in yellow classification, which we call pneumonia, either having fast breathing and or chest syndrome, they were hypoxemic in their study. Unfortunately, they did not collect the data about the outcome of those children, which was very important to see that even 5%, what happened next. Tomorrow we will discuss it more, but I can give you a general answer that we have started the process of updating the IMCI. And one of the component is pulse oximetry also. So we have already commissioned some of the academic institute to do some scoping reviews and see what existing literature is available on use of pulse oximetry in consultation, in IMCI consultation, whether it is a useful tool. If it is a useful tool, how we can incorporate within IMCI consultation, plus at which stage we have to do it. And lastly, most important, what specification we need it for a pulse oximeter. Nowadays, you can see in many of the countries, I'm sorry to say that they are using substandard pulse oximeters, which are not meant for pediatric or even neonatal groups. They are using the fingertip, which is useless for the pediatric population, but they are very cheap, like less than $10, $2, $3. So it's easy to, so we don't want that one because it will give us false reading. And once we are having a false reading, nobody will believe on pulse oximeter actually. So instead of having a benefit, it will be a disadvantage of having pulse oximeter. And this is a very useful tool, a device. We don't want to waste this device. So that is the plan, how we can incorporate, but definitely, and this is difficult question to answer, where should we place it? Keeping in mind the results of TIMCI study, which showed us less than 1% prevalence when we do it to entire population, but 6% in severe cases. Anyhow, we have to send those 6% because they already have the danger signs. They should be in the hospital. We are referring them. Lastly, it seems like in TIMCI study, the community is, and community is always smarter than us. They know where they can get the services. So it seems like they are going to the right place where they can get the services rather than coming to the primary level facility, doing assessment and then going to that facility. So they are much more smarter than us and they are going straight to that facility to get the services. So I'm just saying on a lighter note, we don't know actually what is happening, but there is a likelihood that the severe cases are actually going straight to the hospital or a district hospital or a sub-district hospital where they know that services are available. So thank you very much.
Thank you, Yasser, for answering my question at 5:30. Since we are out of time, I think that was a great intro to tomorrow's session. So I'll hand it over to Ndolo to close us out for the day, and then we'll go from there. Thank you, panelists, for coming back up on stage and answering questions again.
Yeah, good afternoon, everyone. Good afternoon. Can you stand up just a little? We've been sitting and just greet someone next to you. just to show the day is coming to an end. Can you stand up? Stand up and greet someone next to you and talk to you, say, congratulations, the day is at least coming to an end. Yeah, the day is almost, greet someone. Okay, thank you, Le. Good evening once again. Yeah, so just to summarize a few things, I think one of the things that has come out very clearly is that this particular meeting was very important because it has brought up key issues for the project and key issues as he summarizes for pulse oximetry implementation. One of the things that came out very clearly was the issue of collaboration in terms of implementing this kind of strategy. From all the beginning, from Mike, from Dr. Mukisa, from the rest of the team, the aspect of collaboration was very important and it came out very, very clear. The other aspect that came up is the rationale that was actually developed for IMCI strategy is still important up to today to be able to see how we manage the very sick children. And within that rationale, what came out very clearly is that TIMCI was designed as a project to respond to the IMCI rationale, following various in-country, across-region studies to see how adherence and quality assessment of sick children could actually be improved. During the results that were actually presented across various areas, pulse oximetry uptake, CDSA uptake, antibiotics and referral, we've all been taken through various results and we've all seen and agreed that we had a great project implementation. The results that we've been provided across those areas are informative and form a basis on how we fashion things going into future. One of the key things that has also come up is that in those areas of TIMCI, pulse oximetry uptake, CDSA uptake, antibiotic use, referral completion, there are still areas that we need to do further analysis. Areas that we need to do further analysis. And those areas actually came in terms of questions that you raised during the discussion. What was the follow-up uptake? What are factors that are affected? How would areas that we can improve as we look into utilizing these particular results. And the last message I get even from the last speaker is that we still have the room and the long process of improving IMCI implementation, including use of pulse oximetry. Where do we place it, in whose children, and which type of category of children do we use it? And as he rightly mentioned, is we looked at WHO and various countries following WHO and even COVID-19 have revised their existing guidelines and incorporating use of pulse oximetry in one area or so. But we learn from these particular results, we need to revisit that and define in which population of children, in which particular hospital setting, and within even hospital where do we place pulse oximetry. So I think we've learned a lot of today. that informs how we move on. Having said that, one is our friends from Malawi, they have lost their vice president, and let us mourn with them. Is that, a tragedy that befalls us all on the African continent. So to our Malawian colleagues who are here, we mourn with you, and we are sorry for the demise of your vice president. I want to summarize by saying in the morning, you are told when you are here, take time, even if it's around 5:30 to visit around. One of the places you are told to visit is Kilimanjaro, isn't it? Mount Kilimanjaro. But when you're in Mount Kilimanjaro, just at the foot of Mount Kilimanjaro, there is Amboseli National Park. So you can as well just cross into Kenya, go to Amboseli. And while you are still at the foot of, Mount Kilimanjaro, you can just cross over and go to Kenya, Tsavo National Park, and also have enjoyment, isn't it? So for those who are planning to go to Kilimanjaro, you have the opportunity just to also go into Kenya. The last thing is Tanzania is a very lovely country with very polite people. You might not have been told this, but lovely people, women, men. But there is one area or from one region, when you are here, you can get the best. It's called Pemba. They have good perfumes. They have good big people. And if you associate with them, good things can happen. With these few remarks, ladies and gentlemen, I wish you a lovely evening. Thank you so much. See you tomorrow.